So start. Sir. Good morning, everyone. It's a moment of extreme pleasure to welcome each one of you present today. Gathered here today are the minds at the forefront of medical innovation, dedicated to advancing global healthcare paradigm. With immense pleasure, I, Dr. Lavanya, Senior Registrar of Hematology Department, open this conference, a convergent point for trailblazing ideas and transformative insights. This gathering is not just an event, it is a testament to our collective commitment to medical excellence. Today's discourse signifies a step closer to redefining patient care and wellness trajectories. With this, it's my pleasure to welcome my mentor, my guide, a good orator, Dr. Ganesh Jeshatwa sir, leading hematologist and bone marrow transplant physician, a man who needs no introduction over Andhra and Telangana, a doctor who has built identity of hematologist and bone marrow transplant, Yashoda Hospitals. His 12 years journey with Yashoda Hospitals led to 400 successful bone marrow transplant. I would welcome Ganesh sir with a warm round of applause.
Good morning, everyone. I'm overwhelmed by the presence of all esteemed physicians from our Deccan region, and that too early morning hours, 9 o'clock. It's really wonderful. This shows the commitment and enthusiasm about hematology across our the physician society from our region. I'm really thankful to each one of you for sparing entire busy working day for the learning hematology through this Deccan Hematolink 2024. I welcome all of you on behalf of Yashoda Group of Hospitals. Medicine is an ever-changing science, and hematology is the newest subspecialty of medicine in India. The beauty of hematology is it is wonderful amalgamation of the art of clinical evaluation integrated with the science of lab evaluation, and that makes this specialty wonderful, exciting, and really interesting. I'm sure the deliberations by the eminent hematologists from the country today are going to give you a very rich learning experience, and all of us here today, gathered today for understanding and optimizing our hematology cases management skills will be a fruitful and a very great rewarding experience. With that, I will once again thank all of you for sparing your time amidst your busy schedule and coming all the way to Yashoda Hospital, High Tech City. We at Yashoda Hospital, High Tech City are committed to provide the best possible care across the vast spectrum of hematological conditions. We have concluded 500 plus bone marrow transplants over last 10 years. And I take this opportunity to share my humble gratitude to each one of you, because it is, the number is reflected on the credit of Yashoda, but it's all teamwork of all the eminent physicians, pediatricians from our state. It reflects the amount of efforts, the collaboration and teamwork done by all of us together. It's really wonderful. I had been working here at Yashoda Group of Hospitals for past 12 years, and I'm really blessed and privileged to have the association of all eminent physicians, pediatricians from our region. And I really thank each one of you for our collaborative teamwork over last 12 years, and look forward to continue the legacy of our teamwork for managing patients with hematological conditions. Thank you one and all. I hope and I'm sure end of the day, all of us here will feel content that we have learned a lot of new things from the legends of hematology from our country. Thank you one and all. I request Dr. Lavanya to proceed the sessions.
Thank you, sir. Let's kickstart the day with session 1. I would like to invite our chief guest, Dr. Venkatraman Kolan, sir, consultant intensivist, Yashoda Hospitals, High Tech City. Dr. T.V. Srinivas, sir, neurosurgeon, Kachiguda, Hyderabad. Dr. Pavan Kumar, sir, Professor of Pediatrics, MNR Medical College, State Secretary, IIP Telangana. So kindly address this session 1.
Good morning to everybody. Let us start the first session. The speaker is Dr. Mallikarjun Kalashetty. The topic is CBC interpretation, what clinicians need to know. I request Mallikarjun. He is a consultant hematologist, hemato-oncologist, blood and bone marrow transplant physician, Manipal Hospital, Bangalore. Dr. Mallikarjun, please.
Good morning, everyone. So, at the outset, I would like to congratulate Dr. Ganesh and his entire team. When we walked into this hospital this morning, I couldn't believe my eyes. I haven't seen anything like this. This is quite extraordinary, really. So, congratulations. And thank you all of you for being here early morning. So, I'll start, and I'm being told by Ganesh not to exceed my time limit by a second. So, CBC is something that all of us see day in and day out. Perhaps the most commonly ordered test, we all know about hematopoiesis in the bone marrow, hematopoietic stem cells producing, differentiating into the formed elements of the blood. So when you say complete blood count, what are we talking about? We're talking about these cellular component of the blood, essentially red cells, white cells, and the platelets, and various parameters which would help us in not only looking at the hematological abnormalities, but oftentimes also of value to look at the systemic disorders. So they are not just a screening test for many disorders, but rather diagnostic and prognostic value for hematological disorders, and the easy test to follow how well the patient is doing with the treatment. So the story is not of red, white, and platelet cell, but beyond that. So this is a typical CBC wherein you look at the hemoglobin, the red cell indices, the white cell count, the differential count, platelet count, and even the platelet indices. And we'll go through how we can look at these a little more closely and get to the diagnosis in some patients. So looking beyond the obvious is what we'll try and do. So when you talk about red cells, you talk about the hemoglobin, the hematocrit, the red cell number, which will give us an insight. We'll look at the indices more closely, and of course, white cells, whether the count is normal, whether the count is low, whether the count is high, what are the different components of the white cell count, and what is happening to the platelet count. So it is not just looking at the indices, but looking at the whole thing as a forest and not missing the forest for a tree. So reticulocyte response is an indirect assessment of how well the bone marrow is responding to anemia, and based on the reticulocyte count, you can know whether the bone marrow is making enough cell for the peripheral destruction, whether the anemia is because of the marrow failure based on the red cell production index really. So when you look at the complete blood count, what we should do is first look at all the 3 cell lines, look at whether they are in the normal range. Always try and see whether the abnormalities of a single line, whether the patient has isolated anemia, isolated thrombocytopenia, is it bicytopenia, is it pancytopenia. Now once we have that clinical picture, then we would know how best to approach, because we would approach a patient with an isolated anemia differently compared to a patient who has pancytopenia, or a patient who has very high blood cell count or a high platelet count. So looking at the CBC more closely and taking a pause and looking at the indices a little more closely would help us in trying to decipher what is happening to this patient. So isolated anemia is perhaps one of the most common thing that the pediatricians and the physicians face, and we'll dwell a little more into that. So when you look at child with anemia, we all know that the hemoglobin normal values range differently in different ages of the children, and most of the time we look at the anemia based on the MCV, because we divide that anemia into microcytic, normocytic, and macrocytic. So when you talk about microcytic anemia, I think the commonest cause all over the country is iron deficiency anemia, and oftentimes microcytic anemia because of thalassemia minor can be misdiagnosed as iron deficiency anemia, and such children may be inadvertently given iron for a long time. That is something that can easily be diagnosed. So when you talk about the normocytic anemia with reticulocytosis, whenever a patient has reticulocytosis, indirect hyperbilirubinemia, low haptoglobulin, high LDH, we are wondering about hemolytic anemia. which can be inherited or congenital hemolytic anemia, commonly thalassemia, sickle cell anemias, red cell enzyme defects, and also it can be autoimmune hemolytic anemias. Whereas when it is macrocytic anemia, the commonest causes are B12 and folic acid deficiency. But again, the autoimmune hemolytic anemia can have spuriously high MCV. There can be systemic disorders like liver disorders, hypothyroidism. And if the patient has refractory macrocytic anemia with low red cell distribution width, we start wondering about marrow failures like myelodysplastic syndrome. So when we're looking at a child who has not just one cell line but multiple cell line involvement or pancytopenia, then you always worry about more sinister problems like leukemia, myelosuppressive medications, marrow failure disorders, which could be constitutional aplastic anemias or acquired aplastic anemias, and of course the B12 and folic acid deficiencies. If the patient has anemia and low platelet count, you always try and make sure that you're not missing a serious problem like microangiopathic hemolytic anemia, disseminated intravascular coagulation, and of course the immune event syndrome of autoimmune hemolytic anemia and immune thrombocytopenia. So depending on what the initial numbers tell us, you can plan your further evaluation. If the patient obviously has atypical cells, if he has blast, you would go ahead and do a bone marrow examination, immunophenotyping with flow cytometry, karyotyping to make sure you're not missing a leukemia. On the contrary, if the patient is septic in ICU, you worry about sepsis-induced reactive bone marrow. So I think looking at the CBC and peripheral smear are extremely important, and that is how we proceed to look at other things. And these are the common causes of hemolytic anemia in children. So in adults, again, you look at the same microcytic or macrocytic anemia, and then based on the initial evaluation, you do the further evaluation. So this is something that you were always asked, how do you differentiate between thalassemia trait and iron deficiency anemia? We look at what is called as Menzel's index. So if the patient has low MCV, low red cell number, high Menzel's index, you are quite likely dealing with iron deficiency anemia. On the contrary, if the MCV is low and yet the red cell number is high and the Menzel's index is low, you're talking about beta thalassemia trait. And red cell distribution width in thalassemia trait is normal, whereas in iron deficiency, it is more because of severe anisopoikilocytosis. Again, macrocytic anemia, the commonest cause of B12 and folic acid deficiency, drug-induced anemias, and of course, systemic causes. So we always say, never ask for a complete blood count without looking at the peripheral smear. Peripheral smear is extremely important and oftentimes gives us the diagnosis even without doing too many other things. So normal smear, you have normochromic normocytic red cells, you have platelet aggregates, and then you have normal white cell count. In B12 deficiency, you have macrocytes, macroelocytes, and hinge bodies in some of them. Beta thalassemia trait, as against iron deficiency anemia, you have uniform microcytosis, and then you have target cells. Whereas this is a smear of a serious illness called as thrombotic thrombocytic purpura or other microangiopathic hemolytic anemia, where you see cystocytes. Even if one has more than 1% cystocytes, then you worry about MAHAs, right? Sickle cell anemia, you obviously see sickle cells. If it is associated with sickle beta thalassemia, you will also see target cells on the smear. Dirty smear with anisopoikilocytosis, NRBCs, and all forms of shapes of red cell is perhaps a feature of thalassemia intermedia. So if a patient has a cold agglutinin disease, if there is, the agglutination is so much that people can't even run a hemogram on that smear, it is likely that patient has cold agglutinin disease. So depending on the smear, you get a peek into what is happening to the patient, and it is extremely useful. So always when you see a patient for the first time, do not ask for complete blood count alone, but please ask for a peripheral smear and try and have a word with your pathologist, which can be of great help. Spirocytosis is something that can be easily diagnosed on smear. So we'll switch gears and look at thrombocytopenia. If the patient has normal hemoglobin, normal white cell count, and low platelet count, then you kind of see whether the patient has a medical condition causing thrombocytopenia. But before that, you almost always want to see whether it's a pseudothrombocytopenia because of agglutination of the platelets or pre-analytical errors of sampling. And if the platelet counts are indeed low, confirmed on peripheral smear, then you try and find out what is the cause. So first thing is almost always rule out pseudothrombocytopenia. There have been instances where in patient count, platelet count of a patient has been 0. He was admitted in ICU, given transfusions, only to realize later that it was a pseudothrombocytopenia. So that is the point that one has to be careful about. So if the patient indeed has decreased platelet production, then it could be marrow failure disorders, infiltrative disorders, hematological malignancies. And most common cause of platelet being low in an OPD patient in a normal, in a healthy looking person is ITP. And we all know and we all have seen patients of ITP. It's one of the common causes of isolated thrombocytopenia. It is indeed a diagnosis of exclusion. There is no single test which confirms ITP. ITP, and ITP can be classified as acute, persistent, or chronic based on the duration of diagnosis and how long the patient has the illness. It is an autoimmune condition which is because of the accelerated destruction and clearance of the platelets. And again, what are the minimal tests that you need to do diagnose ITP depends on the age and the presentation of the patient. So if and when you do a bone marrow, which is essentially not needed in most patients, you will see megakaryocytic hyperplasia and a normal cellular or hypercellular bone marrow. Another important thing for us to remember is not every patient of ITP needs treatment. Most patients of ITP suffer because of treatment and not because of the lack of it. If the patient is well, has no bleeding symptom, needs no surgery, and if the platelet count is more than 20 to 30,000, such patients should not be treated with any medications. So we'll go through a few cases. I have another 3 minutes left. So this was a young boy who came with petechiae ecchymosis and gum bleeding. Clinical examination is essentially normal. Hemogram showed severe thrombocytopenia. So, diagnosis obviously is ITP. Do we need to do more tests? Perhaps not. Does the child need bone marrow examination? No, the child doesn't need bone marrow examination. Since the platelet counts are less than 10,000, most of the children are treated with either IVIG or steroids. There is no role of platelet transfusion because it won't help in such children without bleeding. This is an elderly man, pure vegetarian, weakness, fatigue, dyspnea, or exertion, knuckle pigmentation gives way to the diagnosis, macrocytic anemia. So this is a case of megaloblastic anemia, and I'm sure all of us have seen, and just therapeutic trial of beta and folic acid replacement would dramatically help in recovery of such patient. So this was a young man with petechiae ecchymosis, gum bleeding, and loss of weight and appetite. He had severe bony tenderness. Clinical examination revealed hepatosplenomegaly, and obviously there was severe cytopenia. So whenever a patient has such clinical situations, you would always worry about a sinister problem, and bone marrow obviously confirmed the diagnosis of acute myeloid leukemia. So this was a young lady, primary, referred from obstetric department in view of thrombocytopenia at 7th month of gestation. She had no other complaints at all, and clinical examination was unremarkable, and it was isolated mild thrombocytopenia. So gestational thrombocytopenia is extremely common in 3rd trimester, and oftentimes we see obstetricians being very worried about low platelet count, and one must be careful not administering any medicines to these patients because they don't need treatment, and oftentimes post-delivery such thrombocytopenia is self-recovering. So this was a young lady who was brought to adult emergency with altered behavior, abdominal pain, ecchymotic patches, waxing and waning sensorium. There was mild hepatomegaly, and then there was mild azotemia. So whenever a sick patient comes to you with neurological symptoms, mild azotemia, thrombocytopenia, you're always worried about microangiopathic hemolytic anemia. And sure enough, the peripheral smear did show the cystocytes, and LDH was very high. It was a Coombs negative microangiopathic hemolytic anemia. There was no overt coagulopathy, and obviously Adamsitine activity was extremely low. So she was a case of TTP, was initiated on plasma exchange. So that is the importance of asking for peripheral smear and making sure that we don't miss a serious problem. So this is a 54-year-old man, came with history of loss of appetite, left hypochondriac fullness for 2 months. Clinical examination revealed a massive splenomegaly. He had leukocytosis, left shift, lot of immature cells like myelocytes, metamonocytes on the peripheral smear, and peripheral smear did have features of chronic myeloid leukemia, confirmed with Philadelphia chromosome positivity being demonstrated. So we all know such patients can walk into OPD with various subtypes of high cell count, and depending on the PCR reflex MPN panel, bone marrow examination, you classify them into one of these classical myeloproliferative neoplasms. So concluding, so when you look at a complete blood count, please make sure you look at all the cell lines, look at the indices closely, always ask for a peripheral smear, which can help us in not missing a sinister problem. Try and corroborate with clinical examination and physical examination of such patients. Always remember, CBC with peripheral smear oftentimes is enough to diagnose most clinical conditions, and even if it doesn't give you a diagnosis, it certainly will lead you in the right direction. And with that, I'm going to stop, and thank you all for patient hearing, and 30 seconds are for Ganesh.
Thank you. Thank you, Dr. Mallikarjun, for your excellent, lucid oration and importance of CBC in anemias. Audience, any questions, please?
Yeah, please.
Hello, doctor.
Vitamin B12 deficiency. So recently I have come across there are 2 different kinds of B12 testing. There is active vitamin B12 and normal, total vitamin B12. So how important is to order active vitamin B12 in ruling out, megaloblastic anemia or microcytic anemia? Yeah.
So there was a time that we would debate all day about the fallacy of B12 level, spuriously high levels, spuriously low levels, and our bosses would always tell us, if the patient is well, if he has macrocytic anemia, regardless of B12 level, try and give a trial of B12 and then make sure that you're not misdiagnosing a megaloblastic anemia as myelodysplastic syndrome. And I would think that holds true, So in a clinical scenario, you do a B12 level, B12 is extremely low, it's a corroborative evidence. But if the patient is well, has no red herrings, has no organomegaly lymphadenopathy, has macrocytic anemia, even if the B12 is high, I would rather give a trial of B12 and then assess the patient after 2 to 4 weeks. If the patient has refractory cytopenia, then you embark on the journey of doing a bone marrow. Otherwise, if there is a response, then you would assume it to be megaloblastic anemia. So long story cut short, low B12 in a clinical scenario will confirm. There is no data to suggest whether active B12 is indeed necessary, and in a clinical situation, therapeutic trial is often enough.
Okay, you're saying MCV is not an indicator for treating, vitamin B12 deficiency.
So you always look at the homocysteine level and then try and see if hyperhomocysteemia is a corroborative evidence. My point is, we're doing too many things for a simple problem which can be easily assessed by a therapeutic trial.
Okay, thank you, doctor.
Yeah, please. Yes, please, sir.
Morning, everybody.
Morning, sir.
Is there any role of vitamin D3 in this?
So vitamin D deficiency is very prevalent now. If you see all the health checks, oftentimes everybody has vitamin D deficiency. And yes, vitamin D replacement is extremely important.
So I think Dr. Mallikarjun elicited the importance of a peripheral smear, and just not the values of a hemoglobin or a TLC or a platelets, but interpreting the peripheral smear gives you a lot of clue and a direction to go forward. So I think he covered the whole spectrum of the whole day topics in such a short time of 15 minutes. He gave an overview. Thank you, Dr. Mallikarjun, for that.
Thank
you. Indeed, it's actually a pleasure to invite Dr. Sanjeev Yadav, the next speaker. It happens to me that we spent a good time of 5 years in our medical college days when he was a colleague of me. And he was one of the sharpest minds at that period of time. And he happens to be now the associate professor in the Department of Hematology and Bone Marrow Transplant, SGPGI, Lucknow. So Dr. Sanjeev will be speaking on iron deficiency anemia for clinicians. So how do we go about? Over to you, Dr. Sanjeev.
Good morning, everyone. I thank Dr. Ganesh for inviting me for this Deccan Hematology link. Previous speaker has told about the importance of CBC peripheral smear. I will deal with iron deficiency anemia for clinicians. Basically, iron deficiency anemia is the most prevalent anemia in India and all over the world. And the classical evaluation that microcytic hypochromic anemia in peripheral smear, that can have 4 possibilities, that is iron deficiency anemia, hemoglobinopathies except sickle cell disease, and anemia of chronic disease and sideroblastic anemia. Out of this, there may be multiple combinations possible, and if you ask a single test which will tell about the iron deficiency anemia, that may be serum ferritin level, but sometimes like functional iron deficiency, you have to do a combination of serum ferritin, TIBC, transferrin saturation and serum iron. Then only you can tell whether there is a anemia of chronic disease with functional iron deficiency or without functional iron deficiency. So let's go through the scenario. I have already told iron deficiency anemia is the most common cause of anemia, and especially in cancer patients, iron deficiency is more frequent complication. Solid cancers as well as hematological malignancies. And regarding iron correction, there are 3 options: either we can do blood transfusion, which is a wrong practice for iron deficiency anemia treatment. Oral iron supplement, which is sometimes associated with many side effects like constipation, GI upset, nausea and vomiting tendency. The remarkable breakthrough in the treatment of iron deficiency anemia is the IV iron, and iron dextran was the first molecules which was available for IV iron treatment, but unfortunately associated with anaphylaxis and so many hypersensitivity reaction related to IgE. Later on, there was development of iron sucrose. The problem with iron sucrose was we cannot give a large amount of iron replacement in a single shot for iron sucrose. Then came the FCM, that is the iron carboxy maltose. Iron carboxy maltose is a wonderful molecule. You can replace up to 1000 gram at a time, but not more than that. And then come the iron isomaltoside. That is the wonderful drug. You can calculate the iron deficit and replace at one time. So this is the drug which is going to change the IV iron treatment in a dramatic way. It will be a game changer. And the most important problem which is occur with FCM treatment, that is the hypophosphatemia, that also is minimum with the iron isomaltoside. The international guidelines also prefer IV iron because it is more effective, better tolerated, improved quality of life, faster and prolonged response, and nutritional iron may be exogenous promoter for the onset of colitis. Regarding ferric carboxy maltose, there is a iron core and there is a carbohydrate coating. But problem with this molecule is sometimes there is a excessive release of iron and there is an increase in labile iron, which is highly toxic and sometimes it harms. But in iron isomaltoside, there is a sustained release of iron with labile iron minimum. So I will show in next slides how iron isomaltoside has an advantage of producing less labile iron, which is required for the ideal parenteral iron therapy. It is a molecule in which 5 chains of maltoside is there, and with each chain there are 10 units of iron molecule is there, and it is released in a very sustained release manner with minimum immunogenicity and anaphylaxis potential. There is a iron matrix and there is a delivery in a sustained way, controlled release is there. That is the mechanism for the iron isomaltoside. Labile iron, when there are studies which has shown the labile iron levels depend upon the stability of the iron carbohydrate complex, and we can see it is minimum with the iron isomaltoside compared to the FCM or any iron sucrose molecule. Regarding non-transferrin bound iron, NTBI, there is a minimum non-transferrin bound iron formation with the use of FCM and the isomaltoside, but it is high with the iron sucrose preparation. So that's why FCM and iron isomaltosides are preferred over iron sucrose. What should be the ideal iron preparation, parenteral iron preparation? It should be robust, long half-life, antigenicity should be low, and time for injection should be short, and maximum dose can be given as a single shot. So that all features are fulfilled by the iron isomaltoside. It's a robust, half-life is 20 hours, antigenicity is very low, time of injection is 15 minutes for less than 1000 milligram, and more than 1000 milligram it has to be given more than over more than 30 minutes, And maximum dose, there is no upper dose limit. In a single dose, you can replace the total iron. There are many studies related to the iron maltoside, and with that, FDA has approved this drug. And there are similar study in cancer patients also, that it is the IV parenteral iron of choice for iron replacement. This is the approved doses in US and as well as Europe, and maximum dose limit is not defined. You can replace completely. Duration of infusion is defined, that if it is less than 10,000, it is given over 15 minutes. If more than 1,000, it has to be given at 30 minutes. And how to calculate the patient's iron need? The classical Ganjonis formula: iron need is equal to body weight into 15 minus actual hemoglobin into 2.4 plus iron store, which is 500 for this is the simplified table by which we can calculate the iron requirement of the patient. Simple example, calculating the iron need. It is a patient, 58-year, large B-cell lymphoma on chemoimmunotherapy, hemoglobin of 9 and weight of 69. We can clearly calculate that it is the requirement of around 2,000. And how many vials we have to give? If maximum dose that we can give on visit 1 is 1300 milligram, and in visit 2 it is 200 milligram. So total deficit is 1380 milligram, which has to be divided. But suppose we are using iron isomaltoside, we can give in a single shot. Similarly, there are in this case the maximum iron is 1500. If we are using iron isomaltoside, we can completely give in a one shot, but if we are using FCM, first dose should be 1000 milligram, second dose should be 500 milligram. This is a expert review by indirect comparison of iron isomaltoside, iron carboxy maltose and iron sucrose. It clearly tells that similar efficacy of FCM in increasing hemoglobin, but iron isomaltoside offer faster and greater improvement in fatigue, which can be clear from this graph. Regarding IV iron safety, two main important issues are there. That is the hypophosphatemia, which is very common with FCM. Almost 80% patients may have hypophosphatemia, and around 30% may have symptomatic hypophosphatemia, contributing to the fatigue. And hypersensitivity, which is a year-known side effect of IV iron preparations. There is a phosphate program in which there was a evaluation of hypophosphatemia by the use of parenteral iron was done. It is a multicentric study, and it clearly tells that incidence of hypophosphatemia significantly lower in iron isomaltoside group, 8% versus the FCM group, where it is 74.4%. There is FCM induced hypophosphatemia is getting concerned in various regulatory authorities. Further studies are ongoing, and many drug authorities have raised questions. There are some factors predisposing to the increased risk of hypersensitivity reaction to the iron infusion. Especially, we should be very careful at the first dose. When there is a severe anemia, there will be more reaction. Other risk factor are the previous reaction to parenteral iron, history of other drug allergies, mastocytosis, fast infusion rate, male sex, vigorous physical exercise, severe asthma, severe respiratory or cardiac disease, old age, treatment with beta blocker or ACE inhibitors, pregnancy, anxiety. So the main mechanism for hypersensitivity is usually IgE mediated complement activation and Fishbane reaction. Fishbane reaction is characterized by flushing in the face, acute chest and back pain and tightness, sometimes with dyspnea. This is usually occur with the first dose of the IV iron preparation, and more common in second or third dose. And this is the most important paper which compares the risk complications with IV iron, basically FCM versus iron isomaltoside and iron sucrose. And it clearly tells the risk of serious or severe reactions are less with iron isomaltosides compared to the FCM and iron sucrose. The take home message, the prevalence of IDA in India is high, anemia has serious consequences, and international guidelines recommends IV iron, and the robust clinical development program in different patient population including cancer patients have shown that IV iron as a better treatment option. There is now more than 12-year experience with iron isomaltoside and more than 13-year experience with the FCM. Regarding FCM versus iron isomaltosides has safe delivery of high doses that can address iron need in a single visit for most patients, is efficacious, efficient and safe. Thank you.
Yeah, thank you, Dr. Sanjeev, for that illustrative way of how do we supplement iron. You focused more on it, and that may be adding enlightenment. And as we all understand, even though there were many differentials, this being the most commonest and most commonly encountered by our clinician. So we will open this house to the question answer sessions, and yes, please.
How often should we give IV iron? Because once we are giving once, again after 6 months, the hemoglobin goes down to 10, depending upon the chronic condition.
Usually that occurs with if any blood loss is there, like patient having GI bleed may have recurrent anemia. Means suppose you have supplemented the iron again after 6 months or 1 year, patient will present to you with anemia again. For any such kind of presentation, usually we should rule out any GI bleed by doing endoscopy or colonoscopy and stool occult blood test, whether patient is having any source of blood loss or not.
But that is without a blood loss. Usually in a congestive heart failure or CKD patients.
CKD patient has very different etiology of anemia. They don't have iron deficiency anemia, they have anemia of chronic disease. And you have to look for functional iron deficiency also. Means there is high ferritin, but available iron is not there. That's why if you are only supplementing with erythropoietin, there is no rise in HB levels. In that situation, there is a cutoff, like if ferritin is more than 800, you don't need to give IV iron, but if it is less than 800, you have to supplement IV iron, then only use serum erythropoietin, then it will respond. Only EPO in the situation of functional iron deficiency will not respond.
Thank you.
Thank you.
Sir, is it possible to keep it simple that microcytic anemia of absolute iron deficiency versus any other cause?
Yes.
Simple point of checking red cell distribution with, if it is high, absolute iron deficiency, if it is normal, rest of all other causes.
Yes.
Is my statement true?
Most of my talk was on absolute iron deficiency anemia only.
No, what I mean to say, just looking at the CBP without checking the iron levels and all, microcytic anemia with increased red cell distribution width is a sign of absolute iron deficiency versus normal red cell distribution width can be any other cause. Is this statement true? Can we take that statement and without checking iron level, can we go for IV iron in a case of microcytic anemia with increased red cell distribution width?
Yes, it is an indirect way to conclude, but sometimes serum ferritin level is confusing because it is a acute phase reactant also. It may be high. In that case, transferrin saturation and serum iron level will help to understand what is the actual etiology of the iron deficiency.
Sir, what about IV iron formulation in pediatrics? 11-year, 12-year-old female child coming with iron deficiency. Can we give isomaltoside?
Currently, it's approved for pediatric population, and it can be given.
Sir, good morning. Parental iron preparations for pregnancies?
Both FCM as well as iron isomaltosites can be used during pregnancy as well, and usually FCM is commonly used during pregnancy. Iron sucrose is used way back, but now most of the centers are using FCM or iron isomaltosite, because in iron sucrose you need multiple injections, frequent injections, but iron isomaltosite or FCM, you can calculate the dose, and maximum 2 or 3 injections you can complete the replacement.
In all trimesters?
Yes.
Yeah, thank you.
Hello, sir. What is your experience with Plummer-Vinson syndrome? Does the web resolves only with IV iron, or does it need a surgery? Because I've seen 2-3 cases, so I wanted to know about that.
I have maximum seen 1 or 2 cases, and usually in such cases where GI tract has problem with iron absorption, IV iron is the best way to replace, especially in a patient of IBS or even autoimmune diseases like rheumatoid arthritis.
Sanjeev, a specific point related to the intensive care or a critical care department. We see patients coming with anemia and sometimes iron deficiency also, but they are inflamed. And they are in sepsis, they are in some acute inflamed conditions like any autoimmune and all. So we have seen clinicians practicing giving IV iron in there, where it is contrary to that, we avoid IV iron in that. What is your comment on that?
During ICU care, there may be a very high ferritin level, and because ferritin is an acute phase reactant, and we should not conclude with that ferritin level, and we should rely upon the combination of ferritin, transferrin saturation, iron levels, and what is the peripheral examination. Usually at during sepsis we avoid IV iron preparation, and once patient is stabilized, then we can use IV iron.
Thank you, Sanjeev, for that extraordinary good interaction. Thank you. Thank you for your. We'll move on to the next talk. You can take the questions on the directly with the Sanjeev. So we'll now.
Yeah. Very good morning, dear esteemed delegates. We know that blood products play a pivotal role in various medical conditions, and we know that the rational use of these blood products are very crucial to optimize patient outcomes and minimize risks. So let us welcome Dr. Professor Tufan Kanti Dolai, who is the head of the Hematology Department, NRS Medical College Hospital, Kolkata, to enlighten on this topic.
So, good morning to everybody, and respected chairperson and the ladies and the gentlemen. So, I must first congratulate Dr. Ganesh and the Yashoda Hospital for a wonderful the hematology feast related to the blood disorder. So, I will be talking about the rational use of the blood component. This is a very, very important aspect of this rational use, because this terminology is very important. So, everything should be rational, not only in the blood product, but also the other indication, the treatment of the patient, everything should be the rational. That's why the rational is the very, very important. If we go to the very back, into the 1600 and 1700, the people have been trying to give blood transfusion from the one patient to the another without doing nothing. And this had been reflected in our different movie also. So we are taking the blood from the one hero and have been transfusing the blood to the heroines. But this is science, this is not so like that. And this discovery of the blood, the ABO product systems in the 1901 by the Karl Landsteiner have been advances, have been changes the scenario of the blood transfusion. And based on this discovery, he have been got Nobel Prize in 1930 that the Karl Landsteiner is the important fellow that have been described the ABO blood grouping systems. You have to remember that the none of the blood product is safe, because there's a lot of the problem can happen, particularly the transfusion reactions can happen during the blood transfusions. It's starting from the immunological reactions, non-immunological reactions, and also the immediate and also the delayed transfusion reactions. It might be the mild transfusion, maybe the moderate, but maybe the severe also the transfusion reactions. But we are interested about the different transfusion reaction incidences. Because if we go to the incidences, the acute hemolytic, the anaphylactic is the very, very important, and also the simple, the arterial rashes, fever and the chills we get in our day-to-day clinical practice, their incidence is there. And it's the delayed transfusion reactions also, there is a problem of the GVHD, the post-TTP, this is the important concern of the blood transfusion. Not only that, in Indian context, the hepatitis B, hepatitis C and the HIV infection is always there. In terms of the gold standard, the technique that have been screened from the TTI, that the 1 in 1 million the chance of hepatitis B, 1 in 2 million there is hepatitis C, and 1 in 1.6 million there is a chance of developing of your HIV infections. And not on that, your incidence of the fatal reactions in 1 in 0.6 million. So you should be more cautious. So you starting for the transfusion outcome, that the mild allergic reactions, the fluid overload that can happen in 1 unit per 100 transfusions. And in terms of the TRALI, the anaphylactic reaction, which is very life-threatening, can happen in 1 in 10,000 reactions in 10,000 transfusion. And very reactions, the late and the very, very severe reactions can also happen in patients with the blood transfusion also. So you have to know that the reactions can happen in the any times. That's why in 1965, the long way, the Dr. Louis Diamond had said that the blood is often used wastefully, improperly and dangerously, because that has to be used in a rational way. Why? The clinical and the indication has to be balanced properly. And not only that, you should be your rational, because the blood is not available in the medicine shop. We have to donate it. So it is the precious product, and safety concern is always there. And also the important thing is that you can avoid the transfusion, particularly the vitamin B12, the iron deficiency, where the drugs can increase the hemoglobin level. When the 1 unit transfusion is required, means there is no transfusion requirement is there. So you should be judicious for your transfusion. So you should be rational for giving the transfusion in the right product, the right dosage, the right time, and also the right reasons. That is the very, very important in terms of your blood donations. We are asking the people for the donation of the blood for the saving the life, but we are the doctor, we are making the patient dangerous. Why? Because we are not transfusing the patient properly. There is a concept that we have to give the component therapy. There is no concept nowadays for the whole blood therapy. There is a concept of a component therapy has to be given. From the single donation, we can prepare the 4 components. So one donation can save the life of the 4 people. This is the very, very important in terms of the blood transfusion. And the more important thing is that you have to keep the blood in a proper way. The RBC should be stored in a 35 to 42 degrees centigrade in 2 to 6 degrees centigrade. And the phase frozen we can keep for the year. And also in terms of the platelet, usually we keep in 5 days in a room temperature with the agitations. And the cryoprecipitate we usually preserve in a -40, -80 deep freeze, you can keep for a year. So from the single donation, this 4 precise product we can keep it for a blood bank for the longer time of the use of these patients. And the more important is the time also. Because sometimes by giving the requisition to the blood bank that we need blood immediately, but this is not possible. Because for the cross matching, you need at least 1 hour for the cross matchings. Because the blood has to be given proper way, the cross matching. So immediately by giving the requisition, blood is not available in your bedside. The right time is also very important. So you have to use the right product in the right times. So we have a pack cell, we have a platelet, we have a fresh frozen plasma, we have a cryoprecipitate, and so on. There is a lot of other products is there. And important thing is that we have to use the right product based on your ABO compatibility. That is also very important. Usually the packed red cell has to be given into the same blood group. The FFP has to be given in the same blood group. And platelet you can give the other group, but better you have to give same group. If it is not, we can give the other things also. So the important thing is that there is a lot of the plenty of the regions. For the regions that you have to use the blood judiciously and you have to be blood used the rationally. Let us why it is rational, because the whole blood transfusion is no longer effective, because there is a lot of the problem can happen into the whole blood. There is a chance of circulatory overload, there is a chance of incipient heart failure is there. And more so that in terms of the whole blood vis-a-vis the PRBC, that in PRBC the reaction is very less comparing to whole blood, particularly the allergic reaction, the febrile non-hemolytic transfusion reaction, and the several TTI is very less comparing to the whole blood. So you have to use the packed red cell, not the whole blood. There is a concept of the fresh blood, but there is nothing is fresh, because you need at least 4 hours for the different testings. By giving the donation, you need some times. And even in the giving the fresh blood, there is a chance of the syphilis, the malaria, the CMV transmission becomes very high. So you have to be very cautious in that. There is no concept of your warming of the blood, because the more important is that you keep warm the patient, not warm the blood, because it will destroy it. So there is a chance of the different hemolytic reactions, and there is also the concentration is there. Let us come to the whole blood. In terms of the whole blood preparations from this whole blood single donation, we can able to prepare the 4 component, or at least for the 3 component by the 2 different centrifugation technique. I am not going into the details. But in terms of the usage of the whole blood, that in whole blood usually it is 350 ml. Nowadays it is the rarely required. Usually in case of the massive bleeding, in case of the trauma management, sometimes in case of the exchange transfusion, only these are the indications we use the whole blood. There is no other concept for giving the whole blood. Let us come to the packed red cell. I think the text is missing. So in terms of the whole blood, in terms of the packed red cell, this packed red cell is becomes very important, because the packed red cell has to be given in the bleeding patients, has to be given into the anemia patients. And into the packed red cell, this is usually the 200 to 250 ml is there in the packed cell. So packed cell has to be used. And the single packed cell will raise your hemoglobin by 1 gram in adult, and also the 3% of the hematocrit, and children it will raise up to the 3 also. But the important thing is that when you do transfuse the patient based on your hemoglobin level, you should determine the cause of the anemia first, whether the transfusion is essential or not, and you have to also think for the clinical context also. So there is a concept of your liberal vis-a-vis the restrictive strategy of the transfusions. So my product has to be given when the patient hemoglobin is 10, should I transfuse it? Or the hemoglobin is 7, should I transfuse it? That is called the liberal vis-a-vis the restrictive strategy of the transfusion. There are several trials and recommendation is there. Even in case of the intensive care unit, in terms of the trauma patient, sepsis, the brain injury, cardiac surgery, there is a restrictive strategy has to be used. When the hemoglobin is 7 and 8, blood has to be given. There is no concept of giving the 9 and 10 blood for the patient. There is several meta-analysis is there. The people is confirming that the restrictive strategy has become superior comparing to your other things. So in terms of the indication for the transfusion is that in case of the symptomatic patient, if the patient is symptomatic due to anemia, hemoglobin 10, you should transfuse it. If the patient has a coronary artery disease, 8 gram is the threshold, has to be transfused. In terms of the ICU, the 7 is in the indication, orthopedic surgery 8, and also the cardiac surgery, oncology, it is the 7 grams of the hemoglobin that you should order for your the blood product. And in terms of the RBC into the different hemoglobin level, means in thalassemia, aplastic anemia, a lot of the other indication that we hematologists usually give transfusion at the hemoglobin level of 6 grams only. So there is no concept of the transfusion. Even in case of the children also, if they are more than 15 days old, then the 7 gram is become threshold for your initiating the transfusion strategy. In terms of their FFP, the fresh frozen plasma, usually we use in case of the bleeding patients. Usually we using in patients with multiple coagulation factor deficiency patient, and sometimes we use the isolated coagulation factor deficiency patients in the dose of 10 to 20 ml per kg. Usually we prescribe that. In terms of the cryoprecipitate, usually the cryo has been preparing from the fresh frozen plasma. In terms of this, the cryoprecipitate, usually it is used in case of the hypofibrinogenemia, and sometimes in case of the hemophilia A, and also in case of the DIC. You should remember that When you are ordering for the cryoprecipitate, usually order for the 5 to 10 cryo bag, not the 1 to 2 units become sufficient. You have to give at least the 10 cryo bag for the treatment of the patients. In terms of the platelet concentrate transfusion, either you can use the RDP or you can use the SDP. The random donor platelet means from the whole blood you can able to 20 to 30 to 50 ml blood, means platelet. In terms of the SDP by the apheresis, we can able to get 200 to 250. And if you give the transfusion, that your the RDP raises the 5,000, and in terms of the SDP, it raises around the 30,000 of your the platelet. So that has to be remembered, and the platelet transfusion has to be given usually has to be given prophylactically if your the platelet count is 10,000s. Because sometime in the dengue and the other indication, the platelet count is 40,000, 50,000 patient become urea, become giving the transfusion requisition to the platelet. Don't give it. Because if the hemoglobin platelet count is less than 10,000, then only there is a chance of your spontaneous bleeding is there. Otherwise, there is no requirement is there. This is a beautiful chart which you have to be given the transfusion of the platelet. Usually in case of the prophylaxis, the 10,000, central venous catheter it becomes 20,000, the platelet has to be given, and different intervention, the platelet count recommendation is there. So usually it is the 50, around the 20,000 you can do that. But the central venous catheter you can put in platelet count as low as 20,000 also. Lumbar puncture you can do as low as 20,000 also. So platelet transfusion is become very judicious, has to be given each and every patient. But you should some point has to be remember that the important thing is that the transfusion should be started within 13 minutes of your issue of the blood, and the transfusion has to be completed by the 4 hours in packed red cell transfusion. In terms of the platelet, it should not keep in the refrigerator. The platelet is to be kept in 20 to 20 degrees centigrade. It's to be simple agitation, and transfusion has to be complete within half an hour has to be completed. In terms of the fresh frozen plasma also, it should be completed by within 30 minutes. And important thing is that you should monitor. We have two more slides there. So we have a monitor the patient is also there. In terms of the monitoring that, by initiating the transfusion, you have to monitor the patient like the recording of your different baseline, temperature, pulse, BP, respiration, oxygen saturation has to be maintained properly. And after 15 minutes, you have to monitor the patient of the transfusion reaction, anything is happening or not, because the majority of the transfusion reaction happens within a 10 to 15 minutes. So the major transfusion reaction has to be often there, and you have to continuously monitor the patients during the lifetime. And important thing is that in terms of the rational use of the blood product, my take home message is that you should first judge the clinical situations, and you have to assess the risk benefit ratio, because the right product has to be used, right dosage, the right region has to be used. And important thing is that in terms of the packed red cell transfusion, the restrictive strategy has to be used when the hemoglobin level is 7. In terms of the platelet transfusion, you are worried about the 10,000. Prophylactic transfusion is only the 10,000 is become sufficient enough, and you have to monitor the patients before and during the blood transfusion. With this, thank you very much for the patient hearing.
Yeah, thank you so much, sir. That is a fantastic presentation. Within a short time, you made us, go through the entire and all practical aspects which postgraduates can use in day in and day out. So despite man's eternal quest for conquering the nature, still we are not able to prepare the artificial blood and artificial blood products despite the rapid technological advancements and artificial intelligence everywhere. So thank you so much, sir. I think any more questions from the audience?
Sir, let's keep it simple about that blood transfusion criteria, absolute indication. See, what I follow is the divide into 3, like HB of 6, HB of 8, HB of 10. Less than 10 in a congestive heart failure, indication for transfusion. Less than 8 in the case of myocardial ischemia, or in case of septicemia, indication for transfusion. Less than 6 if it is chronic anemia, indication for transfusion. Am I right?
You are absolutely right. So in case of the chronic anemia, the 6 is right.
6, 8 and 10.
In terms of the other conditions, 7 to 8 is right. In case of the myocardial, 9 to 10 is right. You are absolutely right.
And secondly, I have very strict objection to the platelet transfusion. Traditional teaching never says, I didn't read anywhere that low platelet will produce a massive bleed, like visceral bleed or anything. It's purely a subcutaneous bleed, which is not deadly. So what is the indication for platelet transfusion in a dengue or so? What I feel is, in a polycythositis, when that happens in dengue, you are aggravating that inflammatory reaction by giving a foreign product. If you ask me, there is no indication for platelet transfusion except in a case of a traumatic case, which is posted for surgery, which needs perioperative transfusion. Except that, nowhere else, except in case of bone marrow transplant, malignant hematological conditions, I am not aware. In any other medical condition, platelet transfusion is not worth, in fact, it is harmful.
You are absolutely right, because there is a misconception of the platelet transfusion. Majority of the people, they are very worried about the platelet count of 60,000, 40,000, even in 30,000s. When this low platelet count is there, they are giving the requisition to 4 to 5 unit or 6 unit to the patient, but it is not justifiable. You are absolutely right. When the patient is bleeding and your platelet count is less than 50,000, you transfuse the patient. The second thing is that if there is no fever, nothing is there, if the platelet count is around 10,000 to 15,000, then only you order for the platelet.
I want to emphasize the point that bleeding will be never deadly in thrombocytopenia. If the platelet count is 50,000, if the patient is actually bleeding, it can be something else, like DIC or something. You have to check the factor, and platelet transfusion do not help there. In fact, it can be harmful.
You are absolutely right, particularly in the dengue and the common indications. Yes, please.
Methotrexate toxicity or any
Sorry,
chemotherapeutic.
please repeat, I am unable to hear.
But in any case of myelosuppression like methotrexate toxicity, which I've seen in recent times, so do we have to immediately give the platelets, or do we have to give, do we have to wait until what time should we wait?
Means you are talking about the myelosuppression due to the variety of the chemotherapy, that including your methotrexate. The guideline is same. Okay. You have to give the platelet count when there is a platelet is around 10,000, there is no bleeding. Okay. If the patient has a fever with your platelet count of 20,000, you have to give the platelet. If the patient has a bleeding, okay, and patient platelet count is less than 50,000, you have to transfuse it. So okay, the guideline is the more or less similar in majority of the situations.
Okay. Sir, in case of females, then menstrual bleed, early menstrual bleed, in case of dengue also we have seen in recent times that is more a common finding. So do we consider that also as a spontaneous bleed and give platelets, or no?
I think this is a very, very important clinical questions you have been asking. So if your date is coincide your low platelet count, then you should be judicious. If your date is not coincide with the platelet count, you may manage with the hormonal therapy also. By giving the tranexamic acid, by giving your estrogen containing drugs, we can also give it. Okay. If there is no bleeding from any other sides, only there is the bleeding PV is there, then you have to manage properly.
Okay, thank you, sir.
In case of dengue fever, if the platelet count is 20-30,000, but the patient may have some subconjunctival hemorrhage or large purpuras, what do you indicate that time?
You have to give it blood, because if the patient has a bleeding symptom, in terms of the mucocutaneous bleeding is there, and the platelet count is 20,000, you have to give the platelet. You are absolutely right.
Okay. Sir, with respect to...
Yes, please.
Sir, with respect to bone marrow biopsy, you said there is no set limit for the platelets. But I'm a pediatrician, sir. With the concern of the parents is a lot when compared to adults. So how to go about, because we don't have a specific value, you are saying.
There is a guideline is there, there is a recommendation is there. So you have to be convinced the parents that there is no threshold of the platelet count. So if you go to the old textbook, they have been written that the 20,000 platelet has to be there for the
what we know is 20,000, sir.
But if you go to the current recommendations, usually we follow regularly, we are doing the regularly for the bone marrow biopsy, even the platelet count of 10,000 also. So that has to be convinced to the patient and the patient relative. And another thing is that you have to take the proper consent also, because there is always chance of bleeding is there. So during your procedure of the bone marrow biopsy, that might be the excessive bleed. The consent has to be given.
Okay, thank you, sir.
Yes, please.
Hemoglobin, sir, in our clinics.
Please repeat, sir.
Sir, 2 to 3 grams of hemoglobin, we are commonly seeing in our clinics. How to manage, sir? Patient is little bit symptomatic with 2 to 3 grams. In Warangal district side, we are seeing 2 to 3 grams with the patient is coming with walking little bit symptomatic only. So how to manage that case, sir?
So I think this is the extreme situation. There is an indication of the blood transfusion. We have been already told that if the hemoglobin level is 7, you have to transfuse the patient. And even if the patient is become symptomatic, the hemoglobin threshold is the 10 gram. So if the patient is symptomatic due to the anemia, even in the platelet, if the hemoglobin level of 9 gram and the 10 gram, you have to transfuse it. I think this is the chronic anemia. The patient has a hemoglobin level of 2 and the 3. You have to transfuse the patient immediately, but the proper precaution has to be taken, because In the severe anemia, there is a chance of heart failure is there. So you have to be monitored during the transfusions, particularly the vital, and you have to give the first two to 3 units very slowly over the 4 to 6 hours. So this precaution has to be given. But yes, you're absolutely right. We can sometimes see in our clinic that patient came very late. They are reluctant to give the blood transfusion. But our advice is that if it is below 6 gram, patient is symptomatic, you have to transfuse it.
Thank you, sir.
Thank you.
So I think there was a lot of interest and queries related to in and around the transfusion threshold, and this has been a controversy, and there were a lot of, I think, different schools of thoughts, the availability, your own local availability, protocols, patients, emotions, families, many things play a role in that, but as long as scientific data is concerned, I think you try to elicit that. It may vary as a local practice and a personal way. I think with this, we conclude this session and give a
thank you very
large
much
applause to all of them. And we hand over the session.
Thank you. That was a mesmerizing presentation. We are truly grateful for sharing your valuable insights. Now let's break for quick tea and we'll resume here at 11 a.m. Please return promptly in 15 minutes. Welcome back. Dear delegates, hope you had a refreshing break. Now let's move on to the next session. I would like to invite Dr. Vamshi Krishna Kondle sir, Professor and HOD, Department of Pediatrics, Venus Mother and Child Hospitals, Hyderabad, and Dr. Rabindra Kumar Jaina sir, Professor and Head at SCB Medical College and Hospitals, Cuttack, to come forward and address this second session.
So it's a great privilege to officiate and to be chairperson for this great gathering, Deccan Hematolink 2024 at Yashoda High-Tech branch. It's a great gathering, and without wasting much time, let me talk about our speaker, Dr. M.B. Agarwal. He'll be speaking on topic life without platelets. So he is the president, Mumbai Hematology Group, a professor. We will have a short video of Dr. M.B. Agarwal sir.
Yashoda Hospitals welcomes our chief guest for Deccan Hematolink 2024, Professor M.B. Agarwal. Here in Hematology, Professor Agarwal is the head Department of Hematology at the prestigious Bombay Hospital, Mumbai. Professor M.B. Agarwal has an illustrious career in hematology spanning over last 5 decades. After finishing his MD medicine from prestigious St. GS Medical College in 1978, Professor M.B. Agarwal has set up the hematology department at the prestigious Lokmanya Tilak Medical College and Sion Hospital, Mumbai in 1983. He has a teaching experience of more than 40 years at University of Mumbai, and he has numerous peer-reviewed national international publications to his credit. He is recipient of many prestigious national international felicitations, orations and awards. Professor M.B. Agarwal is the torchbearer of hematology education in India. He has revolutionized hematology awareness, orientation, education across India and Asia Pacific region over the last 5 decades. His conferences and webinars under the banner of Mumbai Hematology Group are the great source of hematology education for students, postgraduates and consultants alike. What is mesmerizing about Professor M.B. Agarwal is his presentations and his lectures and his orations prove that age is no barrier when it comes to keeping up with the latest technology. In fact, he is so cutting edge, he makes the term cutting edge feel like it's from the Stone Age. Professor M.B. Agarwal is an astute clinician and teacher, and the special about Professor M.B. Agarwal is he's always first one to join such scientific sessions and only one amongst many to stay throughout such scientific sessions and the last one to leave the halls when it comes to academic endeavors. Once again, on behalf of the organizing committee of Deccan Hematolink 2024 and Yashoda Group of Hospitals, we welcome Professor M.B. Agarwal to this conference, and we look forward to an exciting and enriching experience together. Thank you.
Hello. Thank you, everybody. I want to speak to you on life without platelets. A big thank you to Hyderabad. I haven't seen an audience in this number for a Hemat meeting. A lot of credit goes to the organizer, headed by none other than Dr. Ganesh. Ganesh has done a tremendous service to hematology by organizing the first Deccan meeting, and the presence of all of you over here speaks volumes about the deficiency that existed and the amount of learning that you want to do in this field. So thank you, Ganesh, for your invitation. Platelets. About 50 years ago, there was a Hollywood film, Dust in the Blood. Platelets are like the dust particles in the blood. This is what they look like under the microscope. If you did your second MBBS sincerely, then you remember this is what they look like. Their size, their shape, their color, and their clump. One look at the microscope and you know the platelets look fine. And the platelets are deficient. This is what the film looks like, that there's hardly any platelet. You can make out one over there. That's the mother cell, megakaryocyte, which is relentlessly producing platelets from the bone marrow throughout your 80 to 100 years of life. And this goes on irrespective of your age. Once the platelet is produced, it does its job for 10 days and then it's destroyed in the reticular endothelial system, the most important of which is this little organ, spleen. The platelet count is physiologically 150,000 to 400,000, and it varies with the age, varies with the sex. What you see in the top and what you see in the bottom are two different lines for the female and male. Female outnumber the male everywhere in life in numbers, and as the aging occurs, the platelet count slightly drops, but it remains in the range of 150 to 400,000. Let's come to the reasons for the low platelets. So platelets could be low because they are not being produced, as seen in the green, or they may be destroyed, as seen in the red. So these are the two major group of causes of thrombocytopenia. If the platelets are being destroyed, the marrow will pour more and more and more platelets. They are young platelets, so they are large in size, as you see with the arrow over here. And the platelets are not being produced, then whatever platelets you have in the peripheral blood film, they are the late platelets, they are small platelets, as you see with the arrow again in this slide. So the look at the slide can tell you whether this is a production problem or whether it's a destruction problem. Then, of course, there are a few scientific ways a hematologist decides what's happening. MPV, that is the mean platelet volume. You remember the reticulocyte in the field of red cell. Reticulocyte count will be more if there is a peripheral destruction or loss. A lot of young RBCs are being produced, which are reticulocytes, which are large. So the red cell size goes up here, the platelet size goes up, so the volume goes up, that is increased MPV. And the immature platelet fraction called IPF, which will come to you very soon. When the early platelets are coming into the peripheral smear, then they have some remnant of the nuclear debris. So these are reticulated platelets, as shown you in the second line in this slide. And these patients who have got young platelets are aspirin resistant, which may be of importance to the physician and the cardiologist who like to give a specific dose of aspirin as an anti-platelet agent. And then, of course, there is platelet aging, which we'll discuss some other day. So this is where a electronic cell counter tells you that there is presence of young platelets in the peripheral blood, the IPF, the immature platelet fraction, seen in the circle by the arrow. These are large-sized platelets. And these are reticulated platelets where the remnant of the nuclear debris is lying inside the platelets, which can be seen by various kind of scopies. Now, reticulated platelets are newly released platelets from the bone marrow. They are the young RNA-rich platelets. These are having a tendency to be more thrombotic. So in a patient who has got infection, young platelets are being poured, and that can cause thrombosis, one of the mechanisms of consumptive coagulopathy. Reticulated platelets in the blood can be easily measured by this cell counter, and it doesn't cost you anything more. Elevated reticulated platelet count correlates with the insufficient response to the platelet therapy. So aspirin 75 milligram may fail if you've got a very high number of reticulated platelets in your blood, etc. What happens if the platelets are not present in the blood? Your MBBS teaching is that you will bleed. So you get purpura, as you see in the neck of this young woman. There are fine purpuric spots. But very few people realize outside hematology that deficiency of platelet leads to fatigue. So if your stamina was fantastic and now by lunchtime you are exhausted, feel like going home, it's possible that you got thrombocytopenia. And this is very important from the angle of quality of life. The bleeding may not be troublesome from the angle of quality of life. It's okay you get purpuric spot. But if you are fatigued out, it's important. A lot of people need treatment because their work efficiency is markedly gone down. And the least is realized that thrombocytopenic conditions are prothrombotic conditions. These patients are more prone to even thrombi, and this can happen on the arterial side like a white clot. This can happen on the venous side like a DVT. So conditions that produce thrombocytopenia are inflammatory prothrombotic conditions. So don't get surprised if an ITP patient with 5,000 platelet count is bleeding and has got a DVT. So these are three clinical manifestations of thrombocytopenia: very well known, bleeding; less well known, fatigue; almost unknown, thrombosis. Platelets have a role in hemostasis, you've understood. They have a role in thrombosis, you've understood. Platelets also have a role in immune defense and inflammation. What you see over here is the role of platelets as immunocytes. You get malaria, you get dengue, you get viral infection, your platelet count first zooms up and then it drops down because it is consumed. Why does it go up? It goes up because it is going to go and kill the organisms. And here you see an electron microscopic picture of how the platelets are engulfing the organism and trying to kill. So it's not just neutrophil, lymphocytes, monocytes that form your immune system, but also the platelets. History taking is important. Unfortunately, it's an art which is getting lost. I'm told that there are no students over here, so this slide is redundant because physicians in their time took history. Today's students don't take history. They directly look at the X-ray, they look at the CT scan, they look at the lab reports, and then if they feel like asking, they ask a question to the patient. But history taking is extremely important. This lady had a bruise on the knee. She was sent to the hematologist. Hematologists take history. So he took history and she had a fall. So the cause was obvious. You didn't have to do the platelet count or coagulation study. This is just a traumatic bruise. This lady has got bruises all over her back along the ribs. And there was a history that she had gone for an Ayurvedic massage in Kerala. And this is a thrombocytopenic patient. Because of that gentle rub on the back, got bruising along the ribs. Examination, that's another art which is going away. In your days, probably you said hello to the examination, but today's residents say goodbye to the examination. Why touch a patient when you got all the investigations ready? And stethoscope is dead. Today you enter a hospital with a stethoscope only so that the guard recognizes that you are a doctor and he allows you to enter. After that, the importance of a stethoscope is totally lost. In hemophilia, where there is a factor deficiency, the bleeding is in the form of hemarthrosis, as you see on the right side of this slide. While in thrombocytopenia, the bleeding is in the form of the skin bleeding, as you see on the left side. The two don't happen usually together. Purpura, petechiae, or bruises are non-blanching when they are due to low platelet. These hands show you some purpuric spot which are blanching. And once it is blanching, it is not a skin bleeding, so it's not due to thrombocytopenia. These are forearm and hands of an 85-year-old man. And he's got these kind of spots only in the forearm, and that history is diagnostic of what is called senile purpura, which is just because of the laxity of the vessel wall, and it peculiarly happens only in the forearm. You made a diagnosis on the clinical grounds. So that's senile purpura in an old man. This peripheral follicular hemorrhage is classical of vitamin C deficiency, scurvy. Anyway, we come back to the thrombocytopenia. How do you investigate a case of thrombocytopenia? So first is the automation. You do the cell count, and the cell count will tell you that the platelets are low. But the question is whether this platelet count is genuinely low or it is an artifact. And I bring you to a condition called Bengal syndrome. So if you have a patient whose name is Burman, Basu, Ganguly, Tagore, Bhaduri, etc., then be sure the thrombocytopenia may be Bengal syndrome. What does that mean? That means that you are born with large platelets. Large platelets are not counted by the cell counter as platelets. They go into the RBC count. In RBC count, which is very high, a couple of thousand of platelets do not matter, so it looks normal. But the platelets which have gone away will give you a thrombocytopenic picture. And it has happened that the patient count is 3,000 But you look under the microscope, the platelet are 300,000. Now let's come to some serious business. So say somebody's got a platelet count of 12,000 and the genuine count of 12,000. There are three major conditions that should come in your mind: the good one, the bad one, and the ugly one. Again, a Hollywood picture on the right side. The good one is a condition like ITP, which is relatively innocuous. So platelet count is 12,000. The final diagnosis is ITP. Patient does not have too much of morbidity and mortality, easy to treat. Platelet count is 12,000, but the diagnosis is bad. It is aplastic anemia, bone marrow is shut. It's a serious diagnosis. This patient may require immunomodulation or even bone marrow transplantation. And the platelet count is 12,000, but the diagnosis is ugly. It is acute leukemia. Patient had come with the same platelet count, with the same picture of bleeding. One had ITP, one had aplastic anemia, one has a condition where whatever you may do, some will die. You cannot save everybody. So ITP, the good; aplastic anemia, the bad; acute leukemia, the ugly. And I think for a physician, this is the most important aspect. Before you give any steroids or treat, you must at least know whether the patient has got one of these three conditions. Well, never forget hypersplenism. Spleen is the site where the platelets are being destroyed, and the spleen may not be enlarged clinically, though you should do your best to palpate the spleen. But almost all patients should undergo a sonography to see whether the spleen is enlarged, and if it is enlarged, do a Doppler to see whether there is portal hypertension, cirrhotic, non-cirrhotic. But once there is a portal hypertension, platelet count could be low due to pooling into the spleen, which invariably happens together with hemoglobin, together with WBC, and not affecting the neutrophil count. So you will have a gentle pancytopenia, severe thrombocytopenia, but good neutrophils. And that's a clue that this may be portal hypertension. If you are a pediatrician, and sometime even in the adult, there could be congenital thrombocytopenia. And there are conditions where a congenital thrombocytopenia can present to an adult physician at the age of 20 and 30s. But first, let's talk about the newborns and the infants and the children. Many of these conditions have their associated physical stigmata. So look at the patient very carefully. Sometimes it is looking at you. For example, this child does not have the forearm at all. So it's very simple that this may be thrombocytopenia with absent red eye syndrome, what we call TAR. But sometimes you have to look for the congenital abnormalities, or you may even have to do a sonography to look at the organ abnormality, or a chest X-ray, etc., to look at what is happening inside. So associated congenital malformations have to be searched for. Sometimes the platelet color may look different. What is this color? This is gray. So gray hair, gray trouser, but gray platelet syndrome. And these are gray platelets. This is not a bad staining of the slide. Despite all the efforts, the platelet looked this only because certain particles in the platelet are not there from birth, and that's called gray platelet syndrome. When there's a pediatric patient and you diagnose ITP, one of the treatment of ITP is splenectomy. Three conditions must remain in your mind before you touch the spleen. One, whether this is not an inherited or congenital thrombocytopenia, because their splenectomy will be a futile surgery. Second, it's not an ITP which is of secondary type due to a systemic autoimmune disease like SLE, where the treatment is medical and not surgical, because splenectomy will only take care of the platelet. Then why should you make the person lose the spleen? And third is disorders characterized by primary immunodeficiency disorders, where also thrombocytopenia can occur as an immune-mediated condition. If there are pediatricians in the auditorium, they will realize that PIDs are often associated with immune-mediated problems also. You can get autoimmune hemolytic anemia, you can get thrombocytopenia. All these conditions, splenectomy is almost contraindicated. So this is an article published, an update on pediatric ITP, differentiated from ITP, IPD, and PID, which we just discussed. When you go to the hospital in the morning round, there are 5 references. Probably all 5 are for thrombocytopenia. In Indo practice, thrombocytopenia is extremely common, especially in the ICU areas. And when you are called to see a patient of thrombocytopenia, that patient is getting 30 drugs, which is very common today in ICU. And you are asked whether this is a drug-induced thrombocytopenia, and if it is, then which drug. It's a very difficult territory. You have to really know which drug does not cause thrombocytopenia, because every drug can cause thrombocytopenia. So the best way is, when you're thinking of drug-induced thrombocytopenia, is to request the physician to replace that antibiotic or that drug with an alternative from a different group. Because it's not very easy to say this is teicoplanin induced or this is vancomycin induced, etc., etc. Vaccines can cause thrombocytopenia and vaccines can cause thrombotic thrombocytopenia. What you realize during the area of COVID infection and the COVID vaccination is people who died of thrombocytopenia or died of thrombotic thrombocytopenia. Sometimes the chemicals can cause thrombocytopenia, and here you have an example of something which is becoming very common in a buzzing city like Hyderabad. Tattooing, extensive tattooing can lead to chemical-induced thrombocytopenia. If you are an obstetrician, you are dreaded with thrombocytopenia during pregnancy because causes are too many. There's something called gestational thrombocytopenia, which is very innocuous. Third trimester platelet count dropping to not below 75,000 and recovering with delivery is gestational thrombocytopenia, only to recur in the next pregnancy. Anyway, thrombocytopenia of 75,000 needs no attention, so it does not matter what the etiology is. Then you got this preeclampsia, HELP syndrome, hemolytic uremic syndrome, dangerous condition where the baby has to be taken out or else the mother can die. And then something which can go beyond the delivery, thrombotic thrombocytopenic purpura and microangiopathic hemolytic anemia. I'm not giving a talk on this condition, but just to tell you that during pregnancy, not the disorders which we were talking in kids and adults, there is a different set of conditions which have to be kept in mind and investigated accordingly. What you see over here is the RBC fragmentation. And when you have thrombocytopenia, you can't see a single platelet there. Together with broken RBCs, this is MAHA, microangiopathic hemolytic anemia, dreaded condition, a subject for discussion on some other day. Sometimes you have to look at the platelet ultrastructure. Mumbai, we are quite fortunate to have the electron microscopy at least one institute where the data is offered to the clinicians and you can look at the platelet to diagnose certain conditions, especially the genetic one. And the last part of my talk is related to the management, which is, as a clinician, you are probably most interested. And we'll take one prototype example, ITP, and see what we do. So how to improve the platelet count of a patient in ITP? So if you ask a layman, first thing that he will tell you is, I take papaya leaf juice. Isn't it? And if you are very smart businessman, then what you do is to prepare medicine out of the papaya leaf and sell it and become crorepati. And FDA even approves these drugs. This is an approved drug of papaya leaf. How many physicians and intensivists prescribe it is shocking. Despite there is absolutely no evidence that it does anything to the platelet. But anyway, in India, patient always wants to know what to eat. So he wants to take these things, if not in the medicinal form, in the food form. Even a patient of hydrocele and hernia, last question he will ask you, what should I eat? And you have to answer that question, otherwise you're a bad physician. How do you treat ITP in 2024? For that, you have to first look at what is causing ITP. That means ITP is not always primary. It could be secondary to a systemic collagen vascular disease. We gave an example, SLE. It could be secondary to a chronic lymphoid malignancy. Examples are chronic lymphocytic leukemia, lymphomas, etc. It could be secondary to a metastatic malignancy. It could be secondary to the drugs causing ITP, chemicals causing ITP. We have discussed all that. So ITP means you have to search for the etiology and treat the etiology as well. Now let's come to the primary ITP. Primary ITP, we divide the patient into three groups. The platelet count is less than 10,000 or he is bleeding. This patient needs treatment, no discussion. On the last side, you've got a platelet count more than 30,000 and patient has got no bleeding. This patient does not require treatment. He requires what is called wait and watch. It's not just wait, it is watch. You have to carefully follow up this patient because he may tilt from the last group to the first group in no time. So that is something where you refrain from prescribing. And the center one is that you have to be an astute physician. In a group where the patients are patients have got a platelet count between 10 to 30,000, some are bleeding, some are not bleeding, you have to be absolutely a very, very smart physician to decide who needs treatment, who does not need treatment. Now, treatment of ITP can be divided into three groups. Emergency treatment, where treatment will be life-saving, treatment of acute ITP, and treatment of chronic relapsing ITP, and the three are very different. The first is the treatment of an emergency situation. A patient is brought to you, platelet count is 0, he is bled, subarachnoid hemorrhage, or is bleeding from the gut, or a woman has got a hemoperitoneum. Now, these are life-threatening complications of ITP happening in 1 in 1,000 to 1 in 10,000, but happening. The treatment which is best is IV gamma globulin because it brings up the platelet count to a safe range in 48 hours. We don't have anything better than this. Even platelet transfusion cannot bring up the platelet because transfused platelets will be destroyed. The second thing which is added to this is a treatment for acute ITP, that is steroids in some form or the other. Steroids take about 1 week for pushing up the platelet. So it's not really an emergency treatment, but IV gamma globulin is very expensive. It is intravenous. It is over 6 hours. You can't give more than 1 course, and that course will last, the effect of that course will last only for 2 weeks. So you need to back it up by something which will work during the second week, and that is corticosteroids. And yes, in life-threatening situation, we do give platelets as a continuous flow so that it does its job and it is getting destroyed in 1 hour, but it's doing its job. One of the major breakthrough in the treatment of ITP is this drug called TPO receptor analogs, thrombopoietin receptor analog. It's a fantastic addition. You got 2 products, L-Thrombopag by mouth, Romiplastin by injectable subcutaneous route. Romi is given once a week, L-Thrombopag is given by mouth daily. This is very important addition to the armamentarium because this is the only treatment of ITP which is not immunosuppressive. So if you've got a patient where you don't want to immunosuppress further, give these drugs, they work through bone marrow, they work through megakaryocyte, they act there on the TPO and increase the platelet production. And they are wonderful. They work in 80% of patients, and they are wonderful because they hardly have any side effects, and they can be given lifelong if the patient is dependent, and they can be curtailed because they also work through immune system and improve the situation of ITP so that they can be withdrawn. There is another great addition to the treatment of ITP, which is a little old. That is about 15 years ago, we started using rituximab in the treatment of ITP. 100 milligram, 1 dose is good enough to give you remission in 50% of patients, which lasts for 1 year. So that's cheap, that is simple, and that is useful, and you can do it every year. So why not? Acute ITP, standard treatment was corticosteroids, and probably 9 out of 10 still use corticosteroids. The days are changing. Today, you give corticosteroids, you add L-Thrombopag, and you give a dose of rituximab. The idea is to get rid of that corticosteroid, which is such a nasty drug, as fast as possible, and let L-Thrombopag take over. And rituximab will work, and they all 3 work through 3 different mechanisms, and ITP pathogenesis is extremely complex, so why not hit all the 3? Most of these patients then can be continued L-Thrombopag till a spontaneous remission sets in, or if the patient is a chronic ITP, is going to become a chronic ITP, he's still getting the safest of the drug in the form of L-Thrombopag. So all that is getting changed is published here. Current concept of diagnosing and managing adult primary ITP, our views, proposal for a new protocol for management of ITP, etc. One of the treatment that I did as a student 40 years ago was chronic ITP, remove the spleen, 60% of the patients will be fine. Today, that's the last thing we ever do. In last 15 years, I have never done splenectomy of a patient, except for an occasional patient coming from a very remote area where he says, I don't have a lab, people are not educated, doctors are non-existent, emergencies cannot be handled. Then what do? Allow him to go there where there is no platelet count available, there is no support available, there is nobody to decide, or ask him to keep coming when he doesn't have money in his pocket. So do splenectomy, let him have all the complications of splenectomy, but at least get cured of his chronic refractory ITP. And if you're doing splenectomy, do it through the lab splenectomy. You don't need to do the formal splenectomy, etc. There are some orphan drugs in the treatment of ITP. One is hitting the H. pylori. H. pylori somehow produces some antibody which cross-react with the platelet. Treatment is simple, 2 weeks oral therapy. Why not try in an odd case? There are certain new drugs on the horizon. There is a BTK inhibitor called ibrutinib on the right side. We'll discuss it post-lunch in the treatment of chronic lymphocytic leukemia. There's a derivative of that shown on the left side called rilzabrutinib, which is a fantastic addition to the treatment of a refractory, life-threatening chronic ITP. And this is a publication, oral BTK inhibitor in ITP, published 2 years ago. You'll be surprised, but there is a research work showing that low-level laser therapy to the megakaryocyte can increase the production of platelet from the megakaryocyte. If this comes to the clinic, then this is another fascinating addition to the treatment of ITP. What to expect when the ITP patient is expecting? Expecting means pregnant. So if a pregnant woman is there, how do you treat the ITP? First of all, avoid treating till the delivery is imminent. Second is plan the delivery. That means cesarean or vaginal, but plan it. You can't allow nature to take its call. Third is at that time give IV gamma globulin, push the platelet to the safe range so that you can give epidural, you can have the cesarean section, you can have vaginal delivery without any bleeding. In case patient needs treatment in between because the platelet count is in the range of 10,000 or she is bleeding, that criteria where the patient needs treatment, then corticosteroids can be used. Azathioprine can be used, cyclosporin can be used, and this we have learned from our nephrology colleagues who have a kidney transplant patient who wants to become pregnant. Platelet transfusion is an art again, and you've got to be once again a very astute physician to understand when to give platelet, when not to give platelet. More importantly, you need to know when not to give platelet. It's very simple. Platelet is low, give platelet. Your job is over. But then you are not a smart physician. So personalized platelet therapy is a step closer to the clinic. A patient who has got a retinal hemorrhage, and I hope you're doing fundoscopy of your patient, and if you do that, this is a forerunner for intracranial bleeding. So this patient needs emergency treatment, and platelet transfusion could be one of that. We divide the conditions of thrombocytopenia into 3 groups. One, where you will be harming the patient by giving platelet transfusion. You will allow the patient to either become morbid or die, and that is thrombotic thrombocytopenic purpura or heparin-induced thrombocytopenia. So first rule that out. Second is where the platelet transfusion does not work. So it's a waste of monetary resources, and that platelet transfusion can produce morbidity or mortality. Somebody may die of anaphylaxis, ITP, and hypersplenism. And third, where you can't do without platelet, and that's actually hematology and physicians, patients of bone marrow disease, aplastic anemia, leukemia, and in your field, DIC, infections, etc., where you need platelets sometimes, if not all the time. 2 slides for the future of thrombocytopenia. One is needle-free platelet meter. It's wonderful. You can measure sugar without pricking the patient. You can have platelet count without pricking the patient. And I hope it comes to the clinic soon. And second is a wristband, which can give you the whole hemoglobin WBC platelet. The work is going on at Harvard University at the moment. It can come to the clinic. FDA needs to approve it before that happens. What did we do in last 45 minutes? I told you certain things not to do, and I'm going to repeat them. There are 10 things that you must not do. Not to skip the history and examination before you do any investigation. Minimum of telemedicine. What you did during COVID era should now be kept as a history. Do not trust electronic platelet count because Bengal syndrome is looking at you. Not to skip looking at the peripheral blood film. It's of so much importance. Size of the platelet, number of the platelet, what's happening to the RBC, are they breaking, are they spherocytes, is there malaria parasite, is there a dysplastic cell, is there a blast? The information that you get a peripheral smear is like a window to the hematologist. You can skip. You don't have to refer the patient to a hematologist. Not to investigate all thrombocytopenia. Any platelet count which is above 100,000, though it may be below normal, 99% of the time does not require investigations. Not to mix up good, bad, and ugly. Just don't keep diagnosing ITP. Some of them will be aplastic anemia or acute leukemia. Not to forget congenital thrombocytopenia presenting at the age of 30 and 40. Gestational thrombocytopenia, an innocuous condition, doesn't require any investigation, does not require any treatment. Platelet above 75, 3rd trimester, leave her alone. Not to sacrifice the spleen. Splenectomy is an obsolete treatment for ITP. Do it only when you are pushed, and I gave you an example. Say no to the platelet transfusion. Today's physician is quite astute. Even in a dengue, you will not give platelet till 10,000 a patient is bleeding. So you have become very smart, but you can become even more smarter. And lastly, not to underuse this wonderful addition to ITP, L-Thrombopag and Romiplastim. I told you about ITP. They're useful in large number of other conditions. There is a journal on platelets. So if you want to learn more about platelets, here's the platelet. But your head may be reeling, but you keep reading only about the platelet whole life. Happy days are here again. This is a young resident. I always show this picture, who treated this lady for her thrombocytopenia, life-threatening thrombocytopenia, and as a reward, she became his better half. Thank you so much for allowing me to speak to you, and thanks to Ganesh and Hyderabad again for having me here. I'm enjoying my stay from yesterday, and great, wonderful. Ganesh, keep doing it as often as you can.
Thank you, sir. MB Agarwal, sir. We are all privileged, and myself, especially as being a chairperson for your wonderful lucid talk. Yashoda and Dr. Ganesh is accredited with this wonderful opportunity for this, all the conclave to happen. And with your lucid presentation, you have specially highlighted about all the special conditions from the newborn, child, and adolescent and pediatrics, as well as women, that is pregnancy conditions. And you have also highlighted about where to say no. But I have a small doubt, sir, like in this generation where internet and all the things are provided and people are believing more on that rather than the doctors. Traditionally, doctors were more believed by the patients. How do you communicate to the patients to say no when the platelets are no but still low? When the platelets are low, how do you communicate successfully to the patient? I think you are the right person, sir, being very senior in the audience, and you have worked enormously on platelets. We learned a lot, and we are thankful to you, sir. Thank you.
Thank you for that question. Thank you for that question. Medicine is science, but more than that, it's an art. Patient, a father, a husband, or spouse, they can read your face. So when you're giving them an advice, what's the level of confidence which is being reflected on your face? With what kind of delivery you have to the patient is going to make him change. So if you look little shaky in your advice, he can read it. And if you look absolutely confident, then he knows that he has come to the right person, he's getting the right advice. And you tell him that this evening you go home, open the Google and read whatever I have written and given you, whether that is correct or not. It doubly boosts his confidence. You're talking about platelet. We face this problem every day because hematology is a rare branch. And that's why you got 300 audience here, because you want to listen to hematology, because this is not taught at MBBS. It is not taught at MD. Cardiology, neurology, they are taught. Hematology is not taught. So there are a lot of gray areas, and patient comes with an advice. My platelet count is 30,000. I've got ITP. I have this prescription of tap prednisolone 20 mg 3 times a day. And then you want to say that don't take this. And you say that live with this 30, don't bother. Now you have to reflect your confidence to the patient. Why are you doing this? You have to really be very, very positive in your expressing that what is the type of disease you are dealing and what will happen if you take steroids, what will happen if you continue to take steroids, and why is it not needed in a condition like ITP, and so on. So platelet transfusion, one example where most of the time the resident has to be taught rather than the patient. Patient is lying in the ICU, he doesn't ask you a question, but the residents question you. The medical resident will ask the hematologist, okay, sir, last night my boss has said give platelet, now you are saying don't give platelet, what do I do? So yes, it's the level of confidence, and that confidence will be based on your knowledge, based on your experience. You have knowledge, you have experience, you can do it.
Thank you, sir, for clearing the doubt. I think that is the most common question one faces during our practice. And one more small doubt, sir, role of vitamin E. You have said about the scurvy and vitamin C. Is
Papaya leaf? Papaya leaf,
yeah,
equal to vitamin E.
Yeah, thank you.
Altrembopac and romiplastim take 2 weeks to work. So you're starting that, then have patients for 2 weeks.
Sir, what's your experience, the age-old treatment, dexamethasone pulse 40 mg IV OD for 4 days versus rituximab? If you keep the side effects aside, I consider dexamethasone pulse is a poor man's rituximab.
I won't say it's poor man's rituximab. The two are entirely different drugs. So corticosteroids in whichever fashion. It's like I used to tell 40 years ago, iron in whichever way. Iron is iron. So steroid is steroid. Yeah, he has given methylprednisolone. I must be over and above him, so I will give dexamethasone. Just to show that I'm giving a better preparation. All steroids are equivalent as far as the treatment of acute ITP on day 1 is concerned. That's number 1. Rituximab has a different purpose. Rituximab is a treatment for basically chronic persistent ITP. You're going to give a dose or 4 doses once in a year to maintain the platelet count in the safe range for the rest of the life of the patient, because you don't want to give steroids in a chronic fashion. So it's a steroid sparing agent for a chronic or persistent ITP. Steroid is an emergency drug for acute ITP. You want to bring up the platelet as fast as possible. Rituximab takes a month to work. steroids take a week to work. So steroids is for acute ITP, but can't go on for chronic ITP, can't go on for persistent ITP. You will get tuberculosis, you'll break your bones, you'll get herpes zoster, you'll get cataracts, you'll get everything. You see all the drama of chronic steroid therapy in ITP patient, where you just ask that question, how to change the patient's prescription. So you have to explain the patient, why are you removing the steroid which somebody has given him for 6 months, 4 months, 3 months. But yes, dexamethasone 40 milligram, 4 days, acute ITP, sure. In fact, there is no place for rituximab there because you want something faster.
So, the point here I want to emphasize is, if you take IVIG,
We'll discuss outside. They are not very happy with our dialogue going on. We'll discuss it outside, sure. Yeah, sure. Absolutely. So chronic thrombocytopenia, classical example, ITP, platelet count 30, 40,000. Patient is complaining of fatigue. I mean, those of you who have lived with a disease where fatigue is the clinical manifestation know how terrible it can be if you are an active person. If you are an old man resting, watching TV, that's your quality of life, it's okay. But you want to come and give a talk over here, and if I've got fatigue, how do I stand here for 45 minutes and give a talk? So fatigue is a horrible symptom, has to be respected very well and treated. So if patient says ITP, platelet 40, not needing treatment for bleeding, and I've got fatigue which is affecting his quality of life, it needs treatment.
How to treat, sir?
Same way.
Same.
Treatment doesn't differ.
Yeah.
You are treating for a different symptom.
Okay. Thank you.
I think we'll end this session. I am sure Professor M.B. Agrawal always inside the excitement, etc. You can ask questions during lunch time. So thank you, Professor Agrawal, as usual, for a lucid talk and discussions. Now we'll move to the next session. It's also another very, very important topic. We are moving to the next. The topic is the approach to a child with recurrent infection. The speaker is S.P. Jadhav, and he is the director of the pediatric hemato-oncology. Okay, then we have to wait. There is a MCQ for 5 minutes, then we'll move to the second speaker.
Now let's move on to the quiz. Please scan the QR code for the quiz questions.
So, after the fantastic talk by Professor M.B. Agarwal sir, we have a MCQs, audience poll MCQs for the all esteemed physicians from our region. So, I'll start with the questions. So, each question will carry 30 seconds. So, CBC useful is in identification of all except. You have to choose one among them, type of anemia, pseudothrombocytopenia, leukopenia, cystocytes. So let us see the answers. Perfect. I think this audience is an august audience with esteemed physicians. So almost 2/3 of them have voted for the correct answer. Cystocytes, can I have the correct answer, please? And that's the correct answer, 64%. Fantastic. Next question, please. So all of the below are features of thalassemia trait except low MCV, low hemoglobin, decreased RBC number, and low MCH. Please choose one. Let's see the answers. Perfect. Almost half of them are there. So 48% decrease red cell number, 35% decrease MCH. Can I have the correct answer, please? Almost half of them have voted for the correct answer. Next question, please. All are causes of bleeding tendencies except von Willebrand disease, Wiskott-Ulrich, protein S deficiency, and liver diseases. Perfect. Wonderful. 71% correct answer. Protein S deficiency is a thrombophilia. So, next question, please. Which IV iron can be used as a total therapy? Iron sucrose, iron carboxymaltose, iron isomaltoside, iron dextran complex. Perfect. 81% correct answer. Wonderful. Next question, please. All are indications of platelet transfusions except severe ITP, HIT, heparin-induced thrombocytopenia, DIC with active bleed, and polytrauma. Again, wonderful. 83% have voted for the correct answer. May I have the next question, please? This is how many? 10 and the 8. All are causes of eosinophilia except CML, steroid use, HIV, and Crohn's disease. Fantastic. 52% steroids causes eosinopenia, not eosinophilia. Wonderful. Next question, please. Pick up the false statement regarding gestational thrombocytopenia. The incidence of gestational thrombocytopenia is 5 to 10% of all pregnancies. Gestational thrombocytopenia is observed during latter part of pregnancy. There is no specific lab test. Usually platelets is less than 80,000 and gestational thrombocytopenia doesn't confer a risk of maternal fetal bleeding, and recovery of normal platelet count occurs within 2 months of delivery. Perfect. So great, 62%. That's correct answer. Pick up the false statement regarding ITP. Rituximab is an effective modality of treatment. Documenting antiplatelet antibody helps in accurate diagnosis. Fostamatinib is orally administered. Splenic SYK inhibitor goal of treating ITP is to maintain platelet above 1,50,000. Fatigue is an important symptom, and patients with APLA have highest occurrence of ITP. This is last. Wonderful, 72%, 71%. Professor M.B. Agrawal sir has delivered his precise message to the audience. Thank you, one and all. Before we proceed to the next session, we'll just give us 1 minute. We'll see the winner, and I'll request Professor Agrawal sir to please hand over the winner the prize. And the winner is Dr. Abhishek Mali Patil from Gulbarga. He's an eminent senior physician from Gulbarga. Yes, sir. Heartiest congratulations, Dr. Abhishek. Yes, thank you. I request Professor Jina sir to proceed with the next session.
So thank you. After this very interesting multiple choice question and immediate winner and presentations, now we'll move to the next session and next speaker. It's a very interesting topic, as I told you earlier, approach to a child with recurrent infections. So now I invite Dr. S.P. Jadhav to deliver his speak. He's the director of the pediatric hemato-oncology and bone marrow transplant physician of Medanta Hospital, Gurgaon. So Dr. Jadhav, please.
Thank you, Dr. Ganesh and Deccan Hematolink organizers for giving me this opportunity to be here and delivering this important talk on approach to child with recurrent infections. So I believe there are a lot of pediatricians and other clinicians, physicians here. So I hope this talk is useful to you. I have nothing to disclose. What we will discuss is, I will introduce the topic and then I'll take you through few case scenarios and few of the primary immunodeficiency disorders. So recurrent infection in a child, first of all, always rule out acquired immunodeficiency, that the immune system is wrong because of some acquired problem. It's not primary immunodeficiency, that's far more common. So always rule out HIV, that's the first thing if the child is coming with recurrent infections. Leukemia can be another problem, diabetes, nephrotic syndrome, post-splenectomy child getting recurrent infections, post-chickenpox or post-COVID, the immune system can be knocked down for a bit and you may get some bacterial infections post-mumps, measles, etc. also. So always rule these things out. And sometimes if the child is on chemotherapy or immunosuppressed post-bone marrow transplant, heart transplant, liver transplant comes in your clinic, then it's an entirely different ballgame and you possibly should refer back to or do a shared care with the clinician involved in the care of immunosuppressed patients. But once you have ruled out acquired causes, you should focus on ruling out primary immunodeficiency, and B cell defects will present with recurrent bacterial infections and immunoglobulin levels will be handy, should be checked. T cell defects will present with viral infections and fungal infections, so you may do lymphocyte subsets where you will do CD4, CD8 and NK cell counts. Combined immunodeficiency where both can be affected, and neutrophil defects, sometimes neutropenia per se, or you may have chronic granulomatous disease, Shediac-Higashi disease, leukocyte adhesion defects, etc. Or complement defects can also present with recurrent fevers. So this is normal hematopoiesis, which we all know. And if you look at what stage is the problem, like at the top, if there is a problem in your stem cells, then it could be a reticular dysgenesis where you will have neutropenia and you have a severe combined immunodeficiency. You don't have T lymphocytes and B lymphocytes. So the child can present with recurrent infections plus neutropenia. If the defect is only in the lymphocyte progenitor, that's the second line on the left side, that can be severe combined immunodeficiency. You are not making any lymphocytes. So you're not making any T cells, B cells, NK cells, that is like ADA deficiency. Or there can be other combinations where you may have B cells present but T and NK are minus. I will just show you in my coming slides. Then if the defect is in the mature T cells and mature B cells, they are there but they are not working, it can be Wiskott-Aldrich syndrome. If there is absent thymus, it can be Dijorge syndrome, which can lead to T cell defect. Then similarly, there can be B cell defects where it can be X-linked A-gamma globulinemia. You don't have B cells at all. Or you have some B cells, but they are not switching to proper mature B cells, so it can be hyper-IgM syndrome and other immunoglobulin disorders. Similarly, there can be neutrophil defects, congenital neutropenia, and other disorders. So this is the most famous picture of David Vetter, the bubble boy who lived for about 12 years of his life in a bubble. So this child was born with severe combined immunodeficiency in 1971 and did not have a matched sibling donor available. So he lived in there was no other treatment available at that time. There were no mud transplants or others available. So the parents kept him in a bubble for 12 years and he could escape infections. Usually severe combined immunodeficiency patients die within a year or two. And after 12 years, he had a transplant. Unfortunately, after transplant, he got EBV virus-related lymphoproliferative disease or lymphoma and died of that. So this shows that these children who have no immune system, they need a lot of care. And early referral for transplant can save their lives. Robert Good was the first physician who performed a transplant for primary immunodeficiency disorder in 1968. And that was a child who had that was a child who had transplant at the age of 4 months from one of the siblings who was fully matched sister. But they had lost 11 boys in that family with severe combined immunodeficiency. So it's a fatal disorder. Early diagnosis, early referral can save lives. There can be various combinations. So you should always order your immunoglobulin levels. They will be low in a case of severe combined immunodeficiency. And you should do a lymphocyte subset analysis where you will look at CD4, CD8, NK cells, and B cell numbers. So there are various combinations. If your T cells are absent, B cells are present, and NK cells are absent, that's the commonest type of immunodeficiency, gamma chain defect. It is usually happens in boys only. It's an X-linked disorder, and that's the commonest type of severe combined immunodeficiency. Then other combinations are also there. So this child, 7-month-old child, presented from Iraq to us with severe peeling of the skin, recurrent chest infections, had been hospitalized multiple times in the home country, investigated, had very low B cell numbers and T cell numbers by flow, and NK cells were present. So it was T minus B minus NK cell present, severe combined immunodeficiency, and he had a RAG1 mutation on genetic analysis. This was how the child looked. And this is typical skin peeling and erythroderma in severe combined immunodeficiency, also known as Omen syndrome or leaky skin. So these children can be very sick. And this is mainly a mutation defect in RAG1 and RAG2 genes, where this is an incomplete mutation and they're still making some lymphocytes, T lymphocytes, but they are not functional and they are causing autoimmune problems in the skin and causing all these problems. So bone marrow transplant is the treatment for severe combined immunodeficiency, and that should be offered as soon as possible. Coming to the next commonest cause of primary immunodeficiency in children is HLH, or hemophagocytic lymphohistiocytosis. So in your clinic, you will have patients who will present with fever, and fever is ongoing, not settling, high-grade fever, and you do a CBC, you find cytopenias, that platelets are dropping, TLC is going down, hemoglobin is going down. Always think of HLH as one of the top diagnoses or differential diagnosis in your scheme of things. It may be infection, but infection can also trigger hemophagocytosis. And then you will order the set of investigations. Serum ferritin is the most important. It's a low-cost test. Always order serum ferritin in a patient with persistent fever and cytopenias. And ferritin more than 5,000 gives you a hint that it could be HLH. There are certain diagnostic criteria to diagnose HLH. Out of these 7, if 5 are present, you can say that patient has HLH, or there is a genetic mutation that it's a genetic immune defect and that can be the cause of HLH. So it can be acquired or it can be genetic HLH. So basically what happens is that in our immune system, in a normal person, you have these perforin and granzyme granules in the T lymphocytes and NK cells, natural killer cells, which have to mature, polarize, dock, priming, and then fusion. And then when the T lymphocytes they have to kill the target bacteria or foreign body. They release these. There is a degranulation of these granzymes and perforin, which destroy the bacteria and kill the bacteria. So if there is any mutation in one of the genes, then you cannot kill that virus or bacteria, and the T cells keep on proliferating, releasing IL-6, and they stimulate the macrophages. They become very hyperactive, and these macrophages secrete ferritin, which is very high. And macrophages in the liver get hyperactivated, they damage your liver, cause deranged LFTs. So whenever you have HLH, hemophagocytosis, your LFTs should be done and they will be raised bilirubin. Direct hyperbil might be present, or you may have raised enzymes also. And it can resemble a liver failure sometimes. These are the genetic causes. So whenever, if it's a child and you haven't found any acquired cause of HLH, then rule out the genetic cause by doing a mutation analysis by NGS. The principles of treatment of HLH are steroids to control the inflammation. Sometimes to control the activated immune cells, you can give etoposide, chemotherapy, and you have to eliminate the trigger, whatever infection is there, treat that. If it's a familial cause, genetic cause, then bone marrow transplant is required. If it's a relapse case of HLH, transplant is required. If it's a CNS involvement in HLH, transplant is required. Wiskott-Eldridge syndrome is the third commonest primary immunodeficiency which you see in India. This is again a disorder seen in boys. It's an X-linked disorder where eczema, skin eczema is present, and recurrent chest infections are there, and they have low platelets, thrombocytopenia. Sometimes before they get skin problems, they can present as ITP in your clinic or just low platelets, or even at birth in neonatal period, they may present with thrombocytopenia. As soon as first week of the life, they may have very low platelets. So bleeding problems can be the other thing. They can have melena, etc. IVIG is required, and eventually bone marrow transplant is required for these patients. B cell defects. Again, depending on which part of B cell maturation there is a mutation, that would lead to a certain type of B cell defect. So if the defect is at BTK gene, then it leads to X-linked A-gamma globinemia. If it's further beyond, then it can be hyper IgM syndrome, hyper IgE syndrome, or common variable immunodeficiency. So this child, 11-year-old girl, presented 5th in the order and consanguineous marriage, had history of itching all over the body, skin and mouth lesions since 6 months, and this is her skin. You look at the mouth. These are the herpetic eruptions, which is very, very complicated, not going away. She has molluscum contagiosum and viral herpetic lesions. She had recurrent chest infections. CT scan showed bronchiectasis, and these are her nail dystrophy. White cells were 16,000, eosinophilia was present, 22% eosinophils. And IgE levels very, very high, 22,000. So this is hyper IgE syndrome, autosomal recessive. So DOCK8 mutation was done, which was found to be positive, and this was a genetic cause for this recurrent infections in the chest and these skin problems. CGD is another common disorder which presents with your neutrophils are unable to have oxidative burst to kill the bacteria. There are a lot of neutrophils, they can't kill the bacteria. And these patients get recurrent chest infections, bacterial infections, they get aspergillus infection in the bones or in the chest. And simple dihydrorhodamine test, DHR test by flow cytometry can pick up that if cells have oxidative burst or not, and if they are lacking, it can be CGD, chronic granulomatous disease. Bone marrow transplant in 792 children have 80% plus survival. This is EBMT data, so highly curable. Hepatic tumor presented in a hospital where the child was operated, the hemangioendothelioma was removed, and later on the child kept on having fever and pus discharge from the site. They looked at the CBC, the TLC was normal, 12,000, 13,000, 14,000. In the PAC, nobody looked at the differential, that neutrophils were just 1%. And post-surgery, patient had pus discharge. We did a bone marrow, it showed myeloid maturation arrest. It was congenital neutropenia. We did a mutation analysis, ELANE mutation was picked up, and this was managed with high-dose GCSF, and the child is doing very well. Other neutrophil defect could be in GATA2 mutation. So this is again a rare mutation, Amberger syndrome. This girl presented with lymphedema, deafness, and neutropenia. So this is a combination which can be MDS type of picture because of GATA2 insufficiency. There is a spectrum. This is a new disease. These patients may present with immunodeficiency. They may present with aplastic anemia. They may present with MDS. They may present with leukemia. And there is a spectrum or monomax syndrome where the monocytes are missing in the DLC. Monocytopenia is there. Shediac-Agassiz syndrome, this 3-year-old boy presented with recurrent chest infections, hypopigmented patch, multiple hospitalizations needing ICU stay as well. Family history not significant. Genetic disorder was Shediac-Agassiz, and this is how he looked. So typically giant lysosomes are seen in the neutrophils in these patients, and they can have albinism as well, Shediac Agassi, and it's a lysosomal storage disorder, so the neutrophils cannot kill the bacteria, your lymphocytes don't work properly, they tend to get EBV infections, and that EBV can cause fatal HLH, and they can die from that. Yeah, I'm finishing in one more slide. WHIM syndrome is another thing which can present with warts and hypogammaglobulinemia and myelothexis. Here the neutrophils are stuck inside the bone marrow. They cannot move out, and that's the problem. They get recurrent infections. So in conclusion, recurrent infections always rule out immunodeficiency. Primary immunodeficiency, history taking is very important. If somebody has died in the family with recurrent infections, it can be genetic disorder. Examination, skin is a good reflection. They may have a lot of skin problems. Diarrhea can be another thing. CBC is important. Lymphopenia, neutropenia is a trigger. Low immunoglobulin levels is another trigger. Lymphocyte subsets can be very helpful. Ferritin, if it's high, it's helpful for suspecting HLH. Triglycerides, dihydrorhodamine test to rule out CGD, CH50 for complement deficiency, NGS for doing genetic analysis to pick up mutations in the family, and for the counseling for the next pregnancy is very important. Early diagnosis can save these children with bone marrow transplant, especially in severe combined immunodeficiency. I'll finish here. Thank you.
So thank you, Jadhav, for illuminating and very clearly describing the conditions which are very peculiar related to the recurrent infection in the child. They are underdiagnosed, and the pediatricians and clinicians, they never look for these conditions, and that the incidence is always underdiagnosed. But I'm sure there will be a lot of questions, but anybody have any doubt, questions, they can discuss with you in the lunch time, because it's already time, we are already late. Now the organizers are ready for the inaugural, so we will close this session here. Now over to the organizer for inaugural meeting.
Thank you, sir, for that enlightening speech. Your words have surely sparkled our imagination and ignited a passion for exploring new frontiers. Now I request Dr. Ravi Kumar, sir, to come onto the stage and take this program forward.
Good afternoon, everyone. Thank you, Lavanya. On behalf of the entire Yashoda family, I would like to extend a warm welcome to all the distinguished faculty, delegates, and senior members of management who have come for this conclave on hematology advances called the Deccan Hematolink 2024. I request everyone to please be seated for the next 15-20 minutes until we conclude this inauguration program. Yashoda has a legacy of more than 3 decades. And over these 3 decades, it has evolved from a 50-bedded nursing home to a major healthcare chain with more than 4,000 beds under its brand. And during this journey, we have seen that the complexity of healthcare has been rapidly increasing, not only in the aspect of the way the diseases are presenting, but also in the complexity which is needed to treat the patients. So, as a healthcare provider, we have ensured that we partner with doctors from reputed institutes so that we can provide the best of the healthcare to the patients. To support them, we have always invested into the latest and the best technology, provided good patient care services, and created an infrastructure so that these complex diseases can be treated in our hospital settings and also augment the patient experience in the hospital. This institute that we are all seated is an example of what I have mentioned. Yashoda High-Tech is one of the largest quaternary care centers in the country with 2,000 bed capacity. And we have instilled a lot of features so that we can provide a very good patient experience and help them recover much faster. by creating rooms where there is sunlight which comes in. The air conditioning is totally treated, even the fresh air which is drawn for the air conditioning is totally treated and pressurized so that we can prevent infections and aid towards quicker recovery. We have got a lot of systems, like we have provided escalators until the OPD so that their waiting time is reduced. We have created a lot of equipment which is one of the best in the country and maybe the only installation like MR Linac, Da Vinci Xi system, so that we can provide the advanced care to the patient. I would like to share a small video depicting the various features instilled into this unit. Kindly watch. So this was a humble attempt to project what all features we have instilled into this unit. And one of the things that I would like to mention next is that oncology is one of the most rapidly growing specialty in the healthcare. This is because the incidence, the diagnosis, detection is rapidly increasing, and the treatment modalities for the same have been being rapidly advanced. So one of the issues that we see is the side effects of treatment is one of the challenge when it comes to oncology, let it be chemotherapy or radiotherapy. So we have installed over here MR guided radiotherapy, MR Linac, which is the only installation in the country, with the attempt that we should provide a world-class care to the patients who are suffering from oncology and minimize the side effects of radiotherapy from this. So please kindly watch this video.
Welcome to Yashoda Hospitals, a trusted name in healthcare for over 30 years. We are committed to your health and well-being, providing world-class care with compassion and expertise. Introducing a revolutionary advancement in cancer treatment, MR Linac, our newest addition in the fight against cancer. Being a pioneer and leader in cancer treatment, Yashoda Hospitals now brings you the world's best and India's first MR Linac. A revolutionary breakthrough, MR Linac is the world's first fusion of a linear accelerator and a high-resolution MRI, changing the grounds of medical imaging and radiation therapy like never before. Discover a groundbreaking approach to seeing and treating the ever-moving and ever-changing. Through intelligent and pioneering technology, we bring you a solution that offers crystal clear vision like never before. Next generation of Linac technology that offers an uninterrupted 360-degree rotating gantry and integrated workflows to unlock the potential for precise treatment in any direction. Live target imaging and 7 dimensions of information enabling real-time visual tracking and seamless treatment adaptation. The use of AI technology further enhances accuracy and effectiveness, resulting in reduced side effects and improved quality of life for patients. This groundbreaking technology is now available at Yashoda Hospitals, High-Tech City. Experience the future of healthcare today. At Yashoda Hospitals, our highly skilled doctors, nurses, and support staff deliver exceptional care. Trust us with your health because at Yashoda Hospitals, your well-being is our priority.
So this was a small video trying to show the features of the MR Linac. We have treated more than 200 patients on MR Linac, and our team was successful in bringing down the margins to 1 to 3 millimeters. And our future endeavor is try to see if we can reduce the side effects like fatigability, not just organ damage which are adjacent to the tumor. So this is what is one of the attempts that we are trying to do, get the best of the technology which is available in the world so that we can give good service to the patients who are suffering from cancer. One of the offshoots of cancer was hemato-oncology, and it is rapidly evolving where even non-cancer diseases are being treated by hematology specialists. And we are very proud to have Dr. Ganesh with us, who is our senior consultant hematology, who is very passionate in trying to improve this specialty and deliver the best care to the patients. As I mentioned earlier, we have always invested into the infrastructure to support these complex treatments. And with this endeavor, we have created one of the largest hematology bone marrow transplant units in South India. And here I would like to present a small video showcasing that facility. Thank you. Now we will go to the next part of the inauguration program. I would like to request Dr. M.B. Agarwal, President Mumbai Hematology Group, Professor and Head Department of Hematology, Bombay Hospital, Institute of Medical Sciences, Mumbai, to please come onto the stage. I would also request Dr. Vikram, Director for Hematology at CMC Vellore, to please come onto the stage, sir. I request our Director, sir, Managing Director, Dr. G.S. Rao, sir, Director Medical Services, Dr. Lingaya, sir, to please come onto the stage. Dr. Ganesh Jaishetwar, to please come onto the stage, sir. It is our tradition to begin anything auspicious with lamp lighting. Now I request the dignitaries on the dais to please come forward for the lamp lighting.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Now I request Dr. G.S. Rao, sir, and Dr. Lingaya, sir, to please felicitate Dr. Agarwal. Now I request Dr. G.S. Rao, sir, and Dr. Lingaya, sir, to please felicitate Dr. Vikram. Thank you, sir. Now I request Dr. G.S. Rao, sir, to please speak few words addressing the gathering.
Thanks everybody for coming to this conference. All the faculty members and all the delegates. Hello? Hello? Yeah. Deccan Hematolink, Dr. Matthews. I think he is the first hematologist I met in my life. Maybe a few decades back. Dr. Agrawal, Professor Agrawal, Dr. Lingaya, Dr. Ganesh. We are very happy to see the luminaries of this branch of sciences and all the senior doctors who has come here. We welcome you also. I have few issues which I would like to share with you. I am a old timer, 74 plus. So old timers will tell only old stories. You have no choice. This is meant only for youngsters. Our country is not a rich country. Our country is a developing country. We have more of poor people rather than the rich people. Why I am saying this is, though this hospital looks rich, that is a different issue. But you see, 30-40% of our very poor people in our country cannot afford our treatment. Okay, we accept it. But there is a huge middle class which also partially can afford your treatment. Why I am saying this is, majority are extremely good in their talent of treating patients, but I want you to understand the families behind your patients. Everybody is interested in life. Everybody says, "Sab, jo bhi hai, whatever expenses we would like to bear it, please do it." That is out of their love for the patient, love for their children, they will tell this. But I want everybody to think of the cost of the treatment before you give it. Even if before you advise. We do a lot of liver transplants, we do a lot of lung transplants, we do a lot of heart transplants. We sit with the doctors and tell them, please don't advise transplants who cannot afford, because whole of their life, whatever they are surviving, they will think, if I had money, I would have gone for a transplant. So don't advise if they cannot afford it. That's first thing, because it will give a mental trauma, mental torture to the patients. And majority are good in their subject. Yes, X is good, Y is good. Something else is little not that good. But if it is very cheap, please try that drugs. Investigations and drugs are costing a lot of money to the patients. Instead of writing all the investigations, can you try to write some investigations, try to find out the diagnosis if possible. If not, then you can write go for. Otherwise, many times I have seen writing full page of investigations. I know seniors can do that because they know what to write, what not, but juniors can try for this. Even drugs also. You should know the cost of the drug. If there is any way you can save money of the patients, please save it. Why I am saying this is, in 1980s, I think, 80, 81, I was in Austria, in some huge hospital, where that system is different. The whole thing is paid by the government of that country. Vienna. Vienna is the capital and Austria is there. I studied their pediatrics. Then at the end of the day, we had a meeting. Then, the director of that organization said, GS, how do you think is the care of our medical care compared to your country? He just was trying to pull my leg. He's a German. I said, sir, any day, we are better than you for the amount of money what we are spending. He did not understand. He said, can you elaborate? I said, you are spending at those days, 6,000 Austrian shillings per day per patient. Whereas we are probably our healthcare at that time maybe not even 60 rupees per day per patient. So it is always comparison with the money and the treatment. You can say, is it money more important than life? No, it is not. But if you don't have money, what you can do? You cannot help it. We are not America, we are not insurance country, we are not European countries. I want you to keep this in mind in your daily regular practice. That is my request. I am talking in a different forum where I think Ganesh will say, "Arey bhai, ye kya baat kar rahe hain?" Ganesh, true, it will cost more, but if there is any chance where you can treat with a little bit of pocket friendly, I'll be very happy. Thank you very much for attending. And I appreciate Dr. Agrawal ji and Dr. Matthews who came. They are the giants of your specialty. They came here. I really thank all of you for coming here. Thank you, sir.
Thank you so much, sir, for reminding us of our responsibility. Now I request our Director of Medical Services, Dr. Lingaya sir, to please speak a few words.
A very good afternoon to all of you. I welcome all of you for this wonderful program organized by Dr. Ganesh ji. Patron of this program, Dr. G.S. Rao garu. He is Managing Director of this hospital. We, as Dr. Ravi told, we started our journey with 30 beds from Somajaguda, but first our super specialty hospital is in Malakpet. That time, Dr. G.S. Rao used to tell me, we wanted to have a world-class hospital quality care to be given to the patients. So his dream fulfilled with this constructing this hospital, and we are providing world-class care to the patients here. He is very humble and simple. He goes to a nurse, a technician, anybody who is efficient, does a good work, goes to the chamber and greets them. That is his greatness. So we are all proud and pride to part of this organization. Dr. Agarwal, HOD, Hematology, Bombay Hospital, and Dr. Vikram Matthews, Chair Director of CMC Vellore. I congratulate and appreciate Dr. Ganesh and his team for conducting this program. Hematology, a specialty which is growing with leaps and bounds. There is no second thought about it. If I take you people, most of people are young people, if I take you people to 50 years back when we did our house surgency, oncology means death. There was no this thing, there was no much hope. But now, everybody thinks that oncology is nothing but we can be cured properly, prevented properly. So that is the perception of the people because of a lot of work done by the many people. One of them is Dr. Chatterjee, J.B. Chatterjee, who is the father of Indian hematology, who started first department in Calcutta. Yashoda Hematology, one of the largest in the country, and we have good infrastructure, equipment, but those things are not enough. The manpower is the most important. We have Dr. Ganesh and other hemato-oncology with us in our group. All of them, they are doing the best. The team, not only hemato-oncologists, but the team, hematopathologists, HIPC, nursing department, nursing people, all are contributing for this growth of the hemato-oncology. Our third hospital we have started in 2004 at Secunderabad. So that time we thought which specialty we have to increase, which we have to enhance the. So the necessity in that time, the states, both Telangana and AP were combined, Andhra Pradesh state. So that time we have seen oncology was the most important department which was not developed properly in the in that state. So Dr. G.S. Rao thought over and he has inquired with many people. There are many good treatment modalities. So we focused on the oncology, and first dynamic IMRT was brought to Secunderabad Hospital, and that time Dr. Director of the Tata Memorial Hospital, she came here, directly she came here and she wanted to see the that IMRT machine. So she went to the Tata and they procured this thing for them also. Then in oncology in 2011, we procured RapidArc, which is one of the first thing in the country. And then recently, I think Dr. As Ravi told, we have MR Linac, which is the one of the best adaptive radiotherapy machine. So in oncology, we are pioneers in this state and in the country to provide a better treatment to our patients. Regarding that Ganesh, he's a down-to-earth person, meticulous, takes up his patient very careful, very care. He has saved many lives. Even our own doctors, families, who went to different hospitals, different doctors, and when they told that we cannot do anything much for this patient, he did stem cell transplant, and they are alive now. So we are very, very happy with his work and his team. I have attended National Health Summit on Violence Against Hospital Healthcare Workers in Delhi, organized by the IMA. In that program, Dr. Sanjeev Singh, Medical Director of the Amrita Hospital, Hyderabad, he was talking on navigating unmet expectations. Topic was given to him. So he talked that, and he ultimately, in conclusion, he told that I admitted my mother in the hospital. I told to the doctors and other people to take care of her. They said, okay, we'll take care of her. They have treated her, and this is discharged. After some time, his mother-in-law admitted in the hospital. So he used to go every day there, talk to the doctors there. When doctors come to the patient, they used to talk to them, and then sisters, what injection they are giving, most of the time he spent with the patient. So he's telling that, he told that every hospital should be mother-in-law treating type of hospital to meet the expectation of the patients. Next was our topic. I was chairing one session. Dr. Atul Kohar was the speaker. This thing, the effective communication and patient education. In that I told, proudly I can tell you that we may not have, I am not confident that we have mother-in-law treating type of hospital, but we have mother-in-law treating type of consult with us. So one, Dr. Ganesh is among them, one among them. So with, he is one of the best hemato-oncologists of the country. I hope and pray that he will be the one of the best in the world also. Thank you very much.
Thank you very much, sir. Now I request Dr. Agarwal, sir, to please speak a few words to the gathering.
Well, the respected dignitaries on the dais, Dr. Ganesh, friends, a lot has been spoken. I don't know what else to speak. Moving away from individuals and the quality of care that your hospital is offering, and now many corporate hospitals are offering, I will just point out one deficiency that I have faced throughout my life. One which I have tried my best to fill in the gap. One is teaching medicine. Everything else requires money. Teaching doesn't require money. It only requires that you have to educate yourself to teach something. So keep yourself upgraded. Have the best of the information that has surfaced yesterday. Use it for your patient care. Use it to teach your students and colleagues. And tradition is teaching should be free. I always believe in that. Make it as concessional as possible. Make it as free as possible. We've tried that best to do it in Mumbai. It should be done all over. I missed this when I was a student because there wasn't any hematology. There were no teachers in hematology. There was no post-graduation in hematology. There was no network. There was no computer science. Books were not available. Library had dearth of material. There was no way how to access. When you went to the teachers didn't have time to tell you anything. Or they didn't want to part with the knowledge because this was professional secrecy. So I think that is something you can do free of cost. The second area I want to touch is the emergency care. you may have the best of the emergency care, but in Mumbai I see that the best of the emergency care is not the best. Sunday, holiday, mid of night, Saturday half day, patient brought to the emergency, he has an access to the most junior person. Very often life is lost because a diagnosis was not made in time, and a stitch in time saves 9. That is true. So invest in the residents taking care of the E-system, the E-ward, the E-department, with the best of the knowledge and sincerity, because that is the person who needs the best of the care at that moment and the best of the skill at that moment. Thank you.
Thank you, sir. You have raised very pertinent points. On that, I would like to just mention that Yashoda has always been making academics as a core for the clinical practice. The academics has been led by our Director for Medical Sciences, Dr. Lingay sir, has started many colleges, nursing colleges, paramedical courses. We have not ventured into medical colleges though. What I would like to say is academics, we have always been partnering with our doctors so that we can spread our experience, gain from their experience and try to serve the community. After this hospital has started itself, we have done more than 122 academic programs in this, where more than 500 faculty, national and international, have come. And definitely, sir, we shall continue and try to spread knowledge so that we can overall impact the community better. And we shall always keep your words regarding the care for the patients during off hours and other things, sir. Now I request Dr. Vikram to please come and speak a few words.
Morning, everybody. Thank the organizer, Dr. Rao, for having me here. Dr. M.B. Agarwal, our teacher. It was very heartening to see this facility. I think it's almost 2 decades ago I met Sir and he was talking to me about hematology, and I said, where it's likely to go. I'm so happy to see that you all have grown. And I think Sir has already touched on access, high quality and access. These are sometimes in India, antitheses to each other, and it shouldn't be like that. And I think efforts have to be made to have universal access and equity as far as possible. High-end technology is very important. By high-end technology used appropriately and in the right situation is important. It's a responsibility that we have. I think in many ways these institutions have really brought care that was otherwise difficult to access in India. And so I think it takes many people to partner to develop and bring all levels of healthcare to the country. Sir told you a mother-in-law joke, but I think I'll tell you an orthopedic joke. So when I talk about high-end technology and use, so there was a survey done in an orthopedic conference about a surgical procedure on the spine, which would take away pain. It was a chronic pain, and you could do the surgery and your pain would go away. So they did the survey and said, how many of you all would do this surgery if this was a patient? So 90% said, yeah, I would do it. How many would do it if it's your mother-in-law? They said 80% they would do it. How many would do the surgery if it was your wife? 50% said they would do it. How many of you would do it if you all had this problem and it was less than 5%? So that's sometimes where surgery is. And this was published, and all the orthopedicians had a hard time when they went home. They had to respond to their wives reading this publication. So that's a little bit of where sometimes high-end technology and interventions can go. It's different when it's others, and it's different when it's yourself. But I'm sure this is a learning process. And in this light, I'd like to talk about education and learning. Dr. M.B. Agarwal is somebody who, for many of you all who may not be hematologists, has really brought hematology to the forefront in terms of as a specialty, as something that is recognized in the country. 3 decades ago, nobody really understood hematology or what hematologists did. It was a little bare area. So a lot to be grateful to you, sir, for all that you have done for hematology. And I wish Ganesh and his team all the very best. And of course, all of us are here to be with you and partner. And I think this is a common vision and mission. Thank you so much.
Thank you so much, sir. I would like to state over here that Yashoda as a organization, as you would have heard from our managing director, is always conscious that India is a price sensitive market, and though we have created a facility which is a 5-star, some people call it 7-star, but we have ensured that the pricing in this unit is the same as what it is in our Malakpet, which is the oldest hospital that we have started, or Secunderabad or Somajiguda, so that we can give the facilities to more people and make them comfortable with the pricing aspect. Now I would request Dr. Ganesh to please come and give his vote of thanks.
It is indeed an honor and privilege to have Professor M.B. Agrawal sir and Dr. Professor Vikram Matthews here for this August gathering, enlightening about the various aspects of hematology for eminent clinicians from our region. I also like to thank the management of our prestigious Yashoda Hospital, Dr. G.S. Rao sir, Dr. Lingaya sir, for providing us enormous opportunity to continue the educational pursuit across our state. As Ravi Kiran sir has mentioned, more than 100 conferences over last 1.5 years. It's a remarkable feat in itself for our vision to spread the education across various specialties in this state. Also, I would like to thank all the eminent physicians, pediatricians and clinicians who have spared today, skipping their work on a Saturday. We are really grateful to have you here, and we hope at the end of this academic endure, everybody will feel worth spending these 2 days for academics in the field of hematology. Thank you, one and all.
Thank you so much, Dr. Ganesh. Now we will conclude the inauguration program. Thank you all the dignitaries for sparing your time. I request Dr. Lavanya to please take it to the next part of the academic feast.
Now let's move on to session 2 quiz. Scan the QR code. Here comes the question 1. Pick up a false statement regarding thrombocytopenia in chronic liver disease. E is the right answer. Next question. Pick up a false statement regarding the platelet transfusion. D is the correct answer. And third questions. Recurrent viral infections in children are due to. The correct answer is B. Next question. All are causes of lymphadenopathy in children except. The correct answer is D. Next question. All are causes of pancytopenia with hypercellular marrow except. The correct answer is D. The next question. Aplastic anemia can be associated by all except. The correct answer is C. Next question. All are the causes of pancytopenia in elderly except. The results will be announced after that. The answer is D. The results will be announced post-lunch. Now I request Dr. Sugunaka Reddy sir, pediatrician, Sunita Children Hospital and Vaccination Center, Hyderabad, to host the panel discussion on pancytopenia.
Good afternoon, Dr. Ganesh. May I request Dr. Ganesh to be the moderator of this session on pancytopenia? Over to Dr. Ganesh.
Thank you, sir. So we have now panel discussion on pancytopenia. Once again, this full hall is a testament to the enthusiasm about hematology from our region. So I really thank on behalf of Yashoda Hospital and Deccan Hematolink to all the esteemed delegates. So we have a galaxy of panelists, both physicians and pediatricians. So Dr. Vishwadweep Khushu is a hematologist from Nagpur. Dr. Sudarshan Reddy, sir is a senior physician at Yashoda Hospital, High Tech City. Dr. Somnath Gupta, senior physician, Yashoda Hospital, High Tech City. I request all the panelists to please come on the dais. Dr. Ramesh Kurumila sir is a professor medicine, Warangal. Dr. Intizar Mehendi, pediatric hematologist from Bangalore. Dr. Dilip Nandamuri sir, senior physician at Yashoda Hospital, High Tech City. Dr. B. Venkateshwar Rao, senior physician, High Tech City, Yashoda. Dr. Vijay Ramanan sir is a senior hematologist from Pune. Dr. Ankita Sen, hematologist from Kolkata. And Dr. Vikas Dua, pediatric hematologist from Delhi. So I welcome all the distinguished panelists. So I'll kickstart about the facts in our day-to-day practice about pancytopenia. We all know about pancytopenia is a common clinical issue for this august audience. Most of them are physicians and pediatricians. So about 2 to 5% of our outpatient consultation, depending upon the type of practice. Out of this, 1 to 3% are severe, necessitating hospitalization, and after exhaustive evaluation, up to 20% can remain idiopathic. So the punchline is essentially you have to deal with the patients of pancytopenia on day-to-day basis. Now, this is the definition, to be precise, separation of all the three lineages. And this is, if you look at the epidemiology of pancytopenia, it differs as per the geography. For example, you see in developed nations like North America, infections constituted 2/3 pancytopenia cases, whereas in a developing nation like India, aplastic anemia, which is something uncommon in the Western hemisphere, is quite common, and you can see in the pediatric population almost 1/5 aplastic anemia in this journal of Topical Pediatrics 2005, whereas in adults, again, it was little higher. Again, as I mentioned you earlier, there can be a referral bias. So again, when we think of pancytopenia, it is always easy to think the causes algorithm-wise, separate them out depending upon the root cause. So you can separate the pancytopenia cases into 3 different categories. Pancytopenia because of bone marrow replacement, either malignant or non-malignant conditions like infections being the dominant, disseminated infections being the commonest one. Bone marrow failure, it can be either immune, nutritional deficiencies, or infections again. And destruction or sequestration in the spleen can also lead to pancytopenia, the commonest cause being splenomegaly of chronic liver disease. Again, other rare conditions like consumptive coagulopathy, DIC, APML, autoimmune disorders, malignancies. So I'm going to share cases comprising of both pediatric and adult subsets. I'll start with first case. This is a 45-year gentleman presenting with symptomatic anemia in the form of generalized weakness, tingling numbness of hands and feet of 1 month duration. On leading questions, he mentioned he has loss of appetite leading to significant weight loss and associated with history of increased frequency of loose motions of 1 month duration. Now, if you look at the hemogram, there is pancytopenia. Okay. So you can see the all the 3 lineages are suppressed, and there is macrocytosis, MCV. This is the hemogram report. MCV is 119 femtoliters. RDW is high, 26. Normal range is 11 to 14. And there is reticulocyte count, which is low for hemoglobin of 5.9. So what do you think the clinical picture can be suggestive of? I'll start with Sudarshan, sir.
So with neurological symptoms, generalized weakness and macrocytosis, along with reticulocytopenia and increased RDW, mostly megaloblastic anemia, possibly nutritional, Dr. Ganesh.
Yes, sir. Thank you so much. So this was the clinical presentation, hyperpigmented knuckles. This was the oral examination as I highlighted. This is a peripheral smear, hypersegmented neutrophil, more than almost 7 nuclear lobes. So hypersegmented neutrophils are when there are more than 5% neutrophils, more than 4 or more nuclear lobes, or any neutrophil more than 5 nuclear lobes. And you can see the RBC size is large. And this was the hemogram. Dr. Malik Arjun has nicely elaborated how to read hemogram. Beyond numerical values, the histograms is also important. And you can see here in the histogram, compared to a normal RBC, which is shown in the orange, this person's RBC is in the black. So this was a classical case of megaloblastic anemia. So again, just like an ECG for a cardiologist, imaging like endoscopies for gastroenterologists and CT, MRI for neurologists, cell counter generated hemogram is a very vital tool to understand the various etiologies underlying not just pancytopenia but vast hematological conditions and also non-hematological conditions. And as I mentioned, the histograms are also important. They can give a very vital, valuable clue, and somebody who is master in reading the hemograms, 80-90% of your differentials can be very easy. So coming to B12, so I will request Dr. Somnath sir. So in the patient like this with a clinical history and hemogram suggestive of megaloblastosis, do you order B12 and do you rely your diagnosis if the B12 is high, do you rule out megaloblastic anemia?
Usually in this megaloblastic anemias, when we correlate with B12, 50% of the patients have a low normal B12 or at least normal B12. Even after that, they have this megaloblastic anemia. So other than correlating with B12, it is better to correlate seeing a picture, peripheral smear, where we see a macrocytic picture. MCV will be more than 80, 85, 90. In few we see 100, more than 100. And also we can correlate with lactate dehydrogenase, LDH, which will be more than thousands. And of course, there are other tests which we can see like homocysteine levels, but we usually don't do. But MCV, LDH, if even after B12 normal, if MCV and LDH are high, then we can, with the clinical signs, we can correlate with megaloblastic anemia.
Thank you so much, sir. So again, as Dr. Somnath sir highlighted, megaloblastic anemia with normal or supranormal B12 levels doesn't rule out the possibility of megaloblastic anemia. The clinical picture, hemogram and well-read peripheral smear, and as sir mentioned, supportive LDH in thousands, barring hematological malignancies and acute hepatitis, you don't see such high LDH across. And this was a nice paper published few years back, and you can see these are all diagnosed megaloblastic anemia cases, and you can see almost 30–40% of the patients have normal or supranormal B12 levels in a proven established megaloblastic anemia cases. So Dr. Ankita, apart from megaloblastic anemia, what are the other clinical presentations? Dr. Ankita is not there? The non-hematological manifestations of megaloblastic anemia.
So apart from hematological, there are mainly the neurological complications. And as you have rightly shown here, the subacute combined degeneration. Patients may present with ataxia, some of them may have psychosis. And these are a bit of the rare complications that you're showing here, but yes, this may also be presented.
So again, as Dr. Ankita highlighted, non-hematological other system manifestations, and this can be very crucial. So now, Dr. Ankita, how will you evaluate? So do you, in a proven case of megaloblastic anemia, you start them on parenteral B12 and iron and folate supplements. So do you stop your diagnosis and just supplement, and or how do you approach such cases of megaloblastic anemia?
Right, so we need to see the reason for the deficiency in the first place. And like in all cases, it may be because of less intake or less absorption or increased destruction. In our cases, we'll rely on the diet. So if in most of the cases, commonness would be vegetarian diet that is seen in our country. Apart from that, the decreased absorption cases would be the GI causes. So apart from testing for one of the most commonest associations, the pernicious anemia. So we send for antiparietal cell antibody and intrinsic factor antibodies. A quick referral with our gastro friends is also important because there may be conditions such as Crohn's or other thing impairing the absorption.
Thank you so much. So again, as Dr. Ankita highlighted, so etiological workup, not all megaloblastic anemias are nutritional, and leaving the diagnosis just as megaloblastis is not appropriate. Sometimes these patients keep on coming repeatedly, and particularly certain geographic pockets. This patient happened to be from Kurnool. So we did work up, an anti-intrinsic factor antibody was positive. Now, Dr. Vishwadeep, what are the implications of these diagnosis underlying megaloblastic anemia?
So the important point to note is now we have a diagnosis, but even before we check for intrinsic factor antibody, history essentially becomes important, as ma'am said, because sometimes patient can, if the clinical picture is not fitting, you should always ask for if we are missing something. It might all sum up to one thing like patient is vegetarian, but still somebody is again having recurrent B12 deficiency or nutritional deficiency. You should always rule out whether he is losing from somewhere, especially in a male patient. Some patient can have PNH and cause loss of hemoglobinuria, can cause again deficiency of the same things. So if antibody is present, then oral supplementation will not help. So they require parenteral supplementation by B12. and they have increased risk of upper GI malignancy. So screening is more important in those patients who have antibody positivity. Parietal cell usually is not required. Intrinsic factor antibody should be checked in all the patients. The patients whom you suspect that he's not a vegetarian, why he should have B12 deficiency, and no other causes there, which is very evident. They might require deworming also in some situations.
Thank you so much. So that's a very essential point. Again, investigating, because intestinal helminthosis as a cause of megaloblastosis so rampant in some pockets in our practice. So rather than investigating, as a rule, we always, all pancytopenia patients, we give 2 doses of albendazole, and most of the times it is non-toxic and useful strategy. And as Dr. Vishwadeep mentioned, etiological workup is very essential, and I had seen over last 12 years in my practice at Yashoda, Hyderabad, that there are certain geographic pockets in our Deccan region, in our Telugu regions, particularly Kurnool, Nandyal and Anantapur. These are the pockets where incidence of pernicious anemia apparently seems to be high. Patients coming from this region, we do every 1 out of 3 or 4 megaloblastic anemia patients from these regions turn out to be pernicious anemia with either anti-intrinsic and anti-parietal cell antibody positivity. The implications are because these patients will require lifelong parenteral B12 supplements and annual GI endoscopic surveillance. Because of the atrophic gastritis, their incidence of GI malignancies is quite high. So again, just like this cartoon, megaloblastosis is not a diagnosis in itself. You have to work up to find out the root cause of megaloblastic anemia. So again, for eminent physicians, useful tips: pancytopenia with jaundice, commonest megaloblastic anemia, and as Dr. Vishwadeep mentioned, PNH. Pancytopenia with coagulopathy, acute promyelocytic leukemia, again rare, but DIC again can be seen in clinical practice. Now, switching on to second case, this is a 39-year lady who has come from Karimnagar, generalized weakness, fever 2 weeks, bleeding from gums, nose, ecchymotic patches all over the body, 3 days. And look at her hemogram, she has pancytopenia, platelet of 40,000. So I will ask Dr. Vijay Ramanan sir, how will you approach this case?
This patient has pancytopenia with PT-pDTK, both which are deranged. So first thing a physician would think is probably a DIC which is setting in. But the fibrinogen is pretty low. For a DIC, the fibrinogen is usually a secondary phenomenon. So this looks like a primary fibrinolysis. And there are various disorders in our hemat field where DIC can set in at a different stage in advanced leukemias or advanced lymphomas. But primarily, this is the first presentation, so I will have a very high suspicion for APML, which is like a medical emergency for us.
Thank you, sir. So we did coagulation profile right at the first consult, because you can see for a degree of thrombocytopenia 40,000, her bleeding was disproportionately high. All mucocutaneous bleed for a platelet count of 40,000, which don't usually see. So that's the reason why we ordered coagulation profile, and she has coagulopathy. And as sir mentioned, the pathologist called us telling that there are some abnormal cells called as promyelocytes, which are the largest cells on the peripheral smear, not seen in the normal healthy patients. If they are there, there is always abnormal, and they are the largest cell with flower petal nucleus with granulocytes, and this concludes the diagnosis as one of the most deadliest blood cancers, acute promyelocytic leukemia. Again, for certain strange reasons, acute promyelocytic leukemia patients come to us in crops, winter season, and again from certain geographic pockets, Karimnagar, Adilabad and Mancherial. These are the, I might have treated more than 300 APMLs over last 12 years from Karimnagar, Mancherial and Adilabad. So again, as sir mentioned, so this is a hematological emergency, because the coagulopathy can be catastrophic, but this is most rewarding blood cancer with cure rates more than 80–90% in the current era. So urgent hematology referral for patients presenting with pancytopenia with such medical emergencies. So these are the, to name a few, patients with pancytopenia with febrile neutropenia, neutrophil count less than 500 with high fevers, severe symptomatic anemia, severe symptomatic thrombocytopenia, pancytopenia with DIC, pancytopenia with abnormal peripheral smear like this case, either abnormal cells like blasts or suspicion of microangiopathy with cystocytes, possibility of severe aplastic anemia, possibility of HLH, and metabolic emergencies associated with pancytopenia, like symptomatic hypercalcemia, hyperkalemia, and hyperuricemia. This is always evidence of underlying hematological malignancy. Remember, hematological malignancy can present with leukocytosis, can present with leukopenia, or can also present with normal counts. So again, these are the disorders where our collaboration and early hematology referral can save many lives. As shown here, these are the cancer survivors and cancer triumphants. So this is all possible because of the collaborative teamwork with all the eminent physicians from our region. Now again, coming to the third case, this is a 9-year girl, symptomatic anemia, severe anemia requiring multiple transfusions, 3 weeks. She has also symptomatic thrombocytopenia in the form of mucocutaneous bleeds, and she also had symptomatic leukopenia with fever, with productive cough, and facial pain. And look at her hemogram, all the 3 lineages are severely suppressed. So I will ask Dr. Intezar, who is a pediatric hematologist, how will he approach such cases?
So this is an acute presentation of symptomatic anemia requiring transfusion in a young girl, and mucocutaneous bleeds, that means the platelet counts will be low generally. Fever associated with productive cough, because of the low counts there is some infection. Facial pain most likely because of oral thrush or mucositis. CBC is straightforward severe pancytopenia, and reticulocyte count is 0 there. So I think our clinical diagnosis will be aplastic anemia. Irrespective of the age of presentation, careful history and clinical examination to rule out congenital inherited bone marrow failure syndrome is also important here. And we will have to start urgent management of supportive care, platelets, PRBC transfusion, IV antibiotics, but side by side also do the workup for the aplastic anemia to find out if it's an acquired versus inherited bone marrow failure syndrome.
Thank you so much. So severe pancytopenia in a young girl. Again, you can see the MCV is high, RDW near normal, and for a severe anemia, 5 reticulocyte count is 0. That suggests it's absolutely hypoproliferative anemia. That means severe pancytopenia with hypoproliferative anemia is an indication to do bone marrow. This was her presentation. You can see oral thrush, eroding lateral half of the tongue. This is acute medical emergency with severe pancytopenia, and because of her presentation, we did bone marrow. And for the sake of understanding, I put a normal bone marrow slide on the upper side, and this is this girl's bone marrow. It shows completely replaced with fatty cells. This concludes the diagnosis as aplastic anemia. With the platelet neutrophil count of less than 500, less than 200, this fits into the category of very severe aplastic anemia, which is a medical emergency. And to our nightmare, she also had grown. She was spiking high. We did the blood cultures, and she has grown MDR E. coli. Again, how will you manage this case, Dr. Vikas?
As we know that this patient has got severe aplastic anemia, we need to see whether it is idiopathic or it is inherited bone marrow failure syndrome. So at the first go, you send NGS panel for inherited bone marrow failure syndrome, and along with that you send stress cytogenetics, because stress cytogenetics would come early and inherited bone marrow failure panels may take some time. Now, if we are sure that we are not dealing with an inherited cause, then we have 2 options: either to give this patient immunosuppressive therapy in the form of ATG with cyclosporin, or you can offer transplant to these patients. In case it comes out to be inherited bone marrow failure syndrome, then the option of ATG with cyclosporin is out, and you have to offer a transplant to this patient.
Thank you so much. So again, severe pancytopenia, MDR E. coli sepsis on board. I am sure as an eminent physician, you will agree with me. MDR GNB sepsis ICU mortality for immunocompetent persons is 50% or so. For a very severe aplastic anemia, almost negligible neutrophils, it is almost a certified death sentence. So we have to do something urgent. So we stabilized her with transfusions, antibiotics, granulocyte transfusions. We did HLA typing. She was the single daughter in the family. We did emergency first half mass transplant with father as a donor. Unfortunately, after 35 days of transplant also, her counts were persistently low. Dr. Vijay sir, what will you do in such cases?
Well, this looks like there are 2 ways to go from here. If she is stable, probably think of a second graft. And if she is unstable, then probably add all other out-of-the-box things which you could add probably.
Yes. So again, in haploidentical or half-match transplant, various complications. One of the common complication is possibility of graft rejection. Again, this happened in this unfortunate girl. There is the graft rejection chances can be 5 to 10%. So she rejected graft, and this is again another second death sentence. So we did second emergency half-match transplant, switching the donor to my mother as a donor, and she succeeded. And to cut the long story short, you can see the story of January 2017 to recently January 2023. Almost 4 years, 7 years, she is completely cured and leading as a normal healthy child. So again, medical emergencies like this, timely interventions like bone marrow transplant can be really life-saving. Understand, a girl with very severe aplastic anemia, MDR E. coli sepsis at diagnosis, and the only thing which could have saved her was bone marrow transplant. And even though the first bone marrow transplant has failed, innovations, modern transplant facilities and techniques can also make the second transplant feasible, and the end result is in front of you. She is completely cured and leading a normal life. So take home message from this case is, I had shown first case and second case, we didn't try to do bone marrow for pancytopenia. So what are the conditions in patients with presenting with pancytopenia? Do we need bone marrow for all patients? So bone marrow is mandatory for patients with pancytopenia who have abnormal cells in the blood, who have leukoerythroblastic picture that suggests something is infiltrating the bone marrow, or severe pancytopenia with or without reticulocytopenia, you need bone marrows. And extremes of age, as Dr. Vikas highlighted, inherited marrow failure syndromes, and in elderly patients, MDS, these are the common possibilities, so we should do bone marrow to rule out that. So again, as I highlighted, hematology, hemato-oncology, very rewarding results, cure rates more than 80-90%, and these are very much salvageable patients. So timely interventions and timely collaborative teamwork with hematologists is the key for such successful outcomes. Going on with the fourth case, this is again a renowned surgeon from Gulbarga, 74-year surgeon, symptomatic anemia, transfusion dependent 3 months, and look at his hemogram and his reticulocyte count. So Dr. Ramesh, 74-year gentleman with such pancytopenia, how will you evaluate?
So looking at the history, old age patient, that is geriatric patient, symptomatic anemia. So first we have to think of common causes of pancytopenia. Common causes of pancytopenia in old age is usually pancytopenia and megaloblastic syndromes, that is the megaloblastic anemia, that is the very commonest cause, and it is also a treatable cause. Patient, if you give the cyanocobalamin, patient will recover completely. And other possibilities in this case is bone marrow malignancies like myelodysplastic syndromes and multiple myeloma you have to think of in this patient, and myelofibrosis also you have to think of why this old age and the 3 month duration, short duration. And the other possibilities and third possibilities is bone marrow malignancy, blood cancers you have to think of, that is leukemias you have to think of in these patients.
Thank you so much, sir. So again, pancytopenia, as I highlighted, when a patient presents with any anemia, what is important is RBC indices and reticulocyte count. So rule of thumb, unless and until proved otherwise, so any anemia with high RDW and reticulocytopenia, you are dealing with nutritional anemias. If MCV is less than 70, high RDW with low reticulocyte count, it is iron deficiency anemia, unless proven otherwise. High MCV, high RDW with reticulocyte count low, it is megaloblastic anemia unless proven otherwise. So again, as sir mentioned, so this was the picture. There were abnormal cells. The hematopathologist called us telling that there are circulating abnormal cells. You can see nuclear neutrophil, and there are some immature myeloid series cells, macrocytosis, and we did the bone marrow, and what you see here is that this is the largest cell in the bone marrow, megakaryocyte. Normally the megakaryocyte nucleus is like popcorn. There are 3 distinct lobes, so this is multinucleated megakaryocyte. This concludes the diagnosis as something called as sir mentioned, myelodysplastic syndrome, very much treatable condition. So he was treated with simple lenalidomide and darbepoetin, and his hemoglobin is hovering around 12-13 with absolute normal quality of life, and this surgeon is back to his surgeries as he used to do before. So take home message from this case is pancytopenia in elderly. As sir mentioned, nutritional megaloblastosis, extremes of age common, and other hematological conditions like MDS, hematological malignancies like leukemia, myeloma should be considered and might need bone marrow evaluation. Going on to case 5, this is again 11-year girl, fever, with no localizing sign symptoms and symptomatic pancytopenia requiring multiple transfusions. On examination, she only had hepatosplenomegaly. She has already visited multiple super specialty hospitals in Hyderabad. So how are we going to evaluate such case, sir? Venkateshwar Rao, sir.
So looking at this case, 11-year-old girl, female with generalized weakness and fever that is of more than 3 months duration. First thing, it looks like a fever of unknown origin, we say more than 3 weeks. Okay, I have the blood picture now. And here it is showing pancytopenia, ferritin high, LDH is high, triglycerides are high. So with this thing, any cause of pancytopenia can be explained, but the most important thing here, ferritin and LDH that if we see is high, we need to consider one diagnosis is HLH here, which is very important, and again a hematological emergency. So with PO with hepatosplenomegaly and pancytopenia.
Thank you so much, sir. So again, this girl has fever of unknown origin, hepatosplenomegaly, pancytopenia, nothing was coming out, so we did this biochemical test, and ferritin more than 3000, you should have a high index of suspicion for HLH. Again, HLH is not a diagnosis all the time in itself. It can be primary, secondary. You need to rule workup to find out the underlying causes. It can be infections, malignancies, or inherited HLH, which requires bone marrow transplant. So this is the criteria nowadays. You don't need to remember these criteria. You have all smartphones, smart apps. Just put the values within 10-20 seconds. You can get the values, the probability of any particular disease. So this girl fitted into HLH, possibly post-infectious, because all the workup with imaging, everything was negative for underlying possible hematological malignancies or other autoimmune conditions, or the genetic profile for genetic HLH was negative. So again, HLH is a very crucial diagnosis because both over and under treatment can kill the patient, and collaborative teamwork is important because imagine for severely pancytopenic child who is spiking high around the clock and no localizing sign symptoms, adding such profound immunosuppression like dexamethasone, cyclosporine, etoposide can either save the child if your diagnosis is correct, can kill the child if the child has pancytopenia of other etiology like infections and all. So that's why you need a teamwork. So we started this girl on this immunosuppressive therapy after ruling out all other possibilities, and you can see her hemoglobin, platelet, WBC, neutrophil count nicely improved, and these are the therapeutic options. So under such dire circumstances nowadays, our awareness, orientation about these rare possibilities has increased, particularly in ICUs and other specialties. So we have to think differently in the given clinical appropriate scenarios. My last case, 46-year lady, rheumatoid arthritis with symptomatic anemia requiring multiple transfusions 2 months. She also has recurrent sinopulmonary infections, fever associated with night sweats of 6 weeks duration. And look at her hemogram. There is pancytopenia, moderate, with some abnormal lymphocytes. Dr. Vishwadeep, how will you approach such cases?
We have already seen the blood picture. The HB, there is pancytopenia with relative lymphocytosis, and those showing atypical cells, which are large granular lymphocytes, which are very typical of LGL, but we have to rule out secondary causes like reactive LGLs. But this rheumatoid arthritis is a predisposing history here which we have. So LGL is very common, so we'll do flow to make sure, and followed by TCR rearrangement to see whether it's a malignant clone or just reactive LGLs.
Yeah, thank you. So background, autoimmune disorder, symptomatic pancytopenia, fever, recurrent sinopulmonary infections, and abnormal lymphocytes. So possibility of hematological malignancies. So this was the workup. This patient has 4 centimeters splenomegaly. Bone marrow biopsy was done because of the abnormal lymphocyte. Bone marrow biopsy confirmed, and immunophenotyping confirmed the diagnosis of T large granular lymphocytic leukemia, which is again a very much treatable, curable condition. Treatment is simple, immunosuppression for 6 months, and this lady is now on tapering immunosuppression with complete resolution of her symptoms. So again, take home message, Pancytopenia with splenomegaly, commonest chronic liver disease, but India being a tropical hub, infections, common infections, autoimmune conditions, primary, secondary myelofibrosis and rare lymphomas in context where you see such abnormal lymphocytes should be kept in mind. So just a spot case to Dr. Ankita. So this was a case labeled as chronic liver disease by hepatologist and was sent to hematologist for transfusion dependent disproportionate anemia, and this was her clinical peripheral smear picture.
Yes, so we should rule out myelofibrosis or any myelophthalmic anemia, basically anything infiltrating the marrow leading to this sort of a blood picture. So as you said, in the background of persistent requirement of transfusions, this is an ideal candidate for bone marrow examination.
Thank you so much. So as Dr. Ankita said, this was a case wrongly labeled as CLD. We did the bone marrow, and this you can see compared to the previous bone marrows, it's completely C-wave form, extensive fibrosis. In fact, we also did the liver biopsy. There was extensive fibrosis. This was a reverse portal hypertension of primary myelofibrosis, and with this correct diagnosis, this was found to be that JAK2 mutation positive. We started the patient on targeted therapy, JAK2 inhibitors along with erythropoietin, and this lady is now completely healthy with complete resolution of spleen and with hemoglobin hovering around 12 to 13 with absolute wonderful quality life. So we are all Telugu movie lovers. We all know this Why Kattappa Killed Bahubali, the biggest Telugu cinema suspense, fetching highest revenues for Bahubali 2. Medicine is a wonderful science as well as a beautiful suspense, because each patient brings them with them the suspense, and we have to really dig out the puzzle to come to a correct diagnosis. And as our teacher used to say, the more we ask ourselves, the more wise we become. So again, this is I think this is the last case, 28-year lady, generalized weakness, fever, oral thrush, short duration 10 days, and this lady from her early childhood has history of febrile convulsions. So whenever she develops fever, her family physician starts her on anti-epileptics. The family physician, after attending one of such conferences, thought levetiracetam is the safest drug, so he started her on levetiracetam after the onset of fever, and within 10 days, this is her picture, hemoglobin 9.8, WBC 600, platelet 1 lakh. So Dr. Dilip, what is your...
Yeah, this is a young lady presenting with weakness and fever, oral thrush, and on levetiracetam. Hemogram is showing anemia with hemoglobin of 9.8 and severe leukopenia with neutropenia. But here platelets are preserved at 1 lakh. So at in this case where reticulocyte count is 1.5% and MCV, we should suspect of agranulocytosis, possibly drug induced, but levetiracetam as such doesn't say that it is causing agranulocytosis, but still it's better for the young lady coming with this presentation to go for early bone marrow biopsy and see what are the causes for that.
So this was her presentation, oral thrush, again eroding the palates because of severe neutropenia, and as sir said, we did bone marrow, it showed maturation arrest, that suggesting it was a case of agranulocytosis. We did extensive infectious workup, it was negative. As sir mentioned, although levetiracetam is very rarely known to be associated with drug-induced agranulocytosis, but in this case that was the most possible cause. So we stopped levetiracetam and started this lady on GCSF, counts improved, and the oral thrush resolved and she become better. So again, in a country like ours, any Pancytopenia cases, common etiologies first, infections and drugs. So these are the list of exhaustive list of drugs, most notably antibiotics, anti-epileptics, anti-thyroid drugs and antipsychotics. And again, a spot case, polytrauma case with Pancytopenia. Anybody from the audience, any clue? Audience or distinguished panelist on the dais, anybody? Perfect, thank you so much. So you nailed it. So actually polytrauma with, you can see thoracotomy tubes for possible hemothorax, and you see blood oozing out from the thoracotomy tubes, and the blood oozing is so intense that the bedsheet is completely soaked with the blood, and you can see on the thermometer is showing subnormal temperature. So this was a case of DIC with pancytopenia. So again, as I mentioned you earlier, infections common causes should always be kept in mind. So this is the flow chart for pancytopenia. I will not go through it, but careful history with well-read hemogram and peripheral smear can lead you to correct diagnosis in vast majority of your pancytopenia patients. Again, many flow charts. So again, before we conclude, teamwork is the key for handling all such hematological conditions, and I like to ask Dr. Vijay sir to conclude the panel discussion by clinical tips to all the eminent physicians here while evaluating cases with pancytopenia.
First is proper history. Dr. M.B. Agarwal said we have forgotten probably taking history. We look at our patient, ask for fever, bleeding, and dyspnea. These are three things for 3 cell lines. Second is examination is very important. Whether the liver is enlarged, spleen is enlarged, whether the lymph node is enlarged. And last, I mean, once you've gone through that, if just the spleen, not the liver, not the node, then you get a different thought process altogether. Then simple investigation, as you said, of retic, LDH. We use uric acid, ferritin also to get the PNH in it. And we use the immature platelet fraction too often now. So to get an idea of whom to get onto a bone marrow in next 24 hours. So that's the usual algorithm that we follow.
Thank you so much. So again, as sir mentioned, pancytopenia cases with or without organomegaly lymphadenopathy differentials vary, and the presenting history, well-read hemogram, and the history related to the cause of pancytopenia, and this is the history points which are useful. So definitely looking at all these pancytopenia patients, you will agree with me that for patients with hematological conditions, you need a different approach comprising the clinical evaluation supplemented with lab evaluation. Definitely this change in approach can really get most of our patients a better chance of cure and survival. So with that, I conclude my panel discussion. I thank all of you for your patient hearing, and I thank all my eminent panelists for bringing out all the important clinical as well as evaluation tools for evaluating patients with pancytopenia. Thank you. With that, we conclude our panel discussion, and we also conclude this session. I request all of you to please join for lunch, and also in the evening today, slide. We have a evening networking gala dinner at Hotel Westin, 7 p.m. onwards. I request all the eminent delegates and faculties together to join this networking gala dinner at Hotel Westin, 7 p.m. onwards. Thank you so much. Thank you, sir. Thank you. Thank you, sir. Thank you, sir. वो सब अभी दोपहर के बाद लंच को हो गया।
Otherwise, I have a connector if you want. You have? అండ్ రెండో నాకు ఇంకొక మాట చెప్పండి, దాని అంటారు ఇక్కడ మనకి వైఫై ఉందా కనెక్షన్? బికాస్ ఫర్ ద పోల్ టు బి ఫాస్ట్ ఎనఫ్ యూ రిక్వైర్ ఎ గుడ్ కనెక్షన్. మ్యాట్ లింక్ అని కూడా ఉంది మనకి. అసలు బట్ ఇఫ్ ఇట్ ఈస్ వర్కింగ్ దెన్ దట్స్ ఫైన్.
Yashoda at rate 23 లేకపోతే ఏముంటుంది? Yashoda 1 2 3 capital Y. Yashoda capital Y. ఓకే అన్న. ఇది ఏందన్నా ఎస్ఎస్ఐటి హెమటోలింక్ హెమటలింక్. ఓకే ఓకే. No, I'm mute.
Becomes green, then
Yes.
Good afternoon, everyone. Continuing further, I, Dr. Shweta, Senior Registrar, Hematology Department, heartily welcome everyone to Deccan Hematolink 2024. There is one announcement. I request all the chairpersons and speakers of pre-lunch session to gather at faculty desk. I repeat, I request all chairpersons and speakers of pre-lunch session to gather at faculty desk. Moving on to session 3, I would like to invite our chairpersons, Dr. Naveen Polavarapu, Senior Consultant Gastroenterologist, Endosonologist at Yashoda Hospital, High-Tech City, Dr. Mona Lisa Sahu, Consultant Infectious Disease, Yashoda Hospital, High-Tech City, Dr. D. Nagender, Chairman, API Telangana, Dr. Raja Rao, Honorable Secretary, API Telangana. I request all the chairpersons to address this session.
Blood cancer circular.
कर दिया मैंने.
Good afternoon, everyone. We'll start our post-lunch sessions now. We'll start with the first topic in 2024, blood cancers are curable without chemotherapy. And speaker is none other than Dr. M.B. Agarwal, who is the president of the Mumbai Hematology and also professor and head of the Mumbai Hospital Institute of Medical Sciences, Mumbai. So over to you, sir.
Thank you, chairpersons, and thanks, Dr. Ganesh, for this second opportunity to speak to you. The subject is, in 2024, blood cancers are curable without chemotherapy. Once again, big thank you to Hyderabad, big thank you to Ganesh. Cancer, snare it, burn it, poison it. That is surgery, radiotherapy, or chemotherapy. Second World War in 1942, use of chemical gases was the origin of chemotherapy. Chemotherapy kills cancer, no doubt about it. There are lots of celebrities who are survival of cancer because of chemotherapy. 5 of them are here, and there are many more. However, despite chemotherapy, some succumbed. The challenges of chemotherapy are the side effects of chemotherapy, and they are not few. It's inconvenient, requires a central venous catheter, port, or PICC line. There's a prolonged absence from the family and friends. You are jobless. There is suppression of the immune system and infections. The toxicity involves nausea, vomiting, alopecia, cytopenia, need for blood transfusion, bleeding, line infection, and at the end, second cancer. So the quality of life is significantly impaired when you treat cancer with chemotherapy. So what is replacing chemotherapy? Ask Ayushman Khurrana's wife Tahira how it is to win the cancer without chemotherapy. And that is the story of novel methods of curing cancer, the story of 21st century. And we will consider few aspects of this: the targeted therapy, the differentiating agents, the immunotherapy, anti-angiogenesis compounds, antimicrobial agents, and above all, the precision medicine. Surgery in 1800, radiation in 1900, chemotherapy from 1942, now targeted agents from 2000, and immunotherapy today is a long way in conquering the cancer. Let's start with the first one, the targeted oncology. I'll stick to blood cancer because that's the only cancer I'm concerned with. Is blood cancer curable? Well, milestones in hematology show you that blood cancers from fatal disorders have become curable diseases. And if you look at the increase in the blood cancer survival rates, it's the maximum out of all the cancers, one on the left side, as against, say, bowel cancer, one on the right side, and all others in between. It all begins with chronic myeloid leukemia. Chronic myeloid leukemia is a story of discovery of this translocation, what's called Philadelphia chromosome. CML was treated by splenectomy. The median survival was 3 years, and it didn't increase by 1 day. Splenectomy was replaced by radiotherapy, mean survival 3 years. Got replaced with toxic chemotherapy like busulfan, survival 3 years. Replaced with gentle chemotherapy like hydroxyurea, survival 3 years. First breakthrough occurred in the form of interferon, a biotherapy, when the median survival increased to 5 to 7 years. And then came the breakthrough, the bone marrow transplant, which is a type of immunotherapy, as we will soon see, which cured 50% but killed 50%. And then happened the magic. And this magic is Gleevec, imatinib, the magic bullet, discovered on 28th of May 2001, and the Time magazine wrote that this is what probably we were looking for. The credit goes to Brian Drucker, working for Sema-Gegi at that time, now Novartis, who pointed out that it's the fusion of 2 genes, the BCR-ABL, which is in the genesis of chronic myeloid leukemia. A single translocation, a single gene disease. It was probably retrospectively easy to conquer, because you just needed to block that one site where ATP is, and he did that with the help of the small molecule imatinib. Rest is history. In these 20 years now, we are option 1, 2, 3, 4. From imatinib to nilotinib to dasatinib to bosutinib, we have a number of small molecules which can control CML. Above that, there is the fifth molecule, ponatinib, which works on most of the resistant cases of CML where the first 4 fail. And the last nail in the coffin is this drug called asciminib, once again from the house of Novartis, just going to be released in this country in 1 week's time, which can take care of when all the BCR-able translocation molecules fail. Survival of CML from 1993 to 2024, we have moved from 8% to 92%. And today, we can say that a CML patient survives to the same extent than a normal individual in the population. However, what this young girl is thinking is how long she has to take these molecules. So the goal in 2024 is not just to live with imatinib or with asciminib, but to get cured and stop all these agents. And that is achievable in 50% of patients of CML today without transplant. So CML has become a biological cure, and you are off all the treatment every alternate patient. Changing gears, the other chronic lymphocytic leukemia, which was considered a beautiful leukemia, is chronic lymphocytic leukemia. It was considered beautiful leukemia when I was a student because the median survival was longest, and many patients didn't need treatment for a long time. Ultimately, at the end of the day, it was fatal, which is not acceptable in 2024. So chronic lymphocytic leukemia, the story was wait and watch. When you become symptomatic, chemotherapy, chlorambucil, and then a stronger chemotherapy like fludarabine, and then immunotherapy, rituximab, and then joining them and having FCR, and then curing some with bone marrow transplantation. Then came the magic, and this magic was in the form of ibrutinib, a small molecule which is a BTK inhibitor. And everything changed. Look at the results of chlorambucil in the blue curve and the ibrutinib in the red curve at the top. Now a patient of chronic lymphocytic leukemia can be made to live forever and ever, just like imatinib makes a patient of chronic myeloid leukemia live forever and ever. As if that was not enough, one knew that CLL is a disease of accumulation of cells because these cells don't die. Any cell that is abnormal must undergo apoptosis, and that is something nature. When that nature fails, apoptosis does not occur. It's all because of the anti-apoptotic protein called BCL2. And the success came in the form of venetoclax, the BCL2 inhibitor, which made this cell die by apoptosis. Well, 1 + 1 is 11. Today, you have protocols where ibrutinib, the BTK inhibitor, is linked with BCL2 inhibitor, 2 oral drugs taken for 1 year. Half the patients become what is called minimal residual disease negative. And the treatment is over, and you are free from the treatment. You may not be cured, you may relapse, but that is after years. As if that was not enough, there is a third wonderful, powerful agent, and that is in the form of monoclonal antibody, the second generation called obinutuzumab. And link all three together, the obinutuzumab, ibrutinib, and venetoclax. Even in a relapse refractory patients, 88% of patients get into CR. So that is the success story of your second chronic leukemia, the chronic lymphocytic leukemia. Changing gears once again, Rebecca Scullett and her book, The Immortal Life of Henrietta Lacks. How one woman's cells change scientific thinking forever is the main theme of this book written by Rebecca. Henrietta Lacks, who? About the immortal life of Hela. Her name was Henrietta Lacks, but the scientists know her as Hela. And you in your pathology read about Hela cells. Henrietta was a poor black tobacco farmer with ovarian cancer whose cells were taken out without her knowledge in 1951. And these cells became one of the most important tools in medicine, vital for developing various vaccines, cloning, gene mapping, IVF, and many more. Hela cells have been bought and sold by billions, yet she remains virtually unknown and her family today doesn't even have money to live and survive. Rebecca Skloot made her immortal. She is a freelance science writer, 51-year-old as of now, born in US in 72, specialized in science and medicine. Her first book, The Immortal Life of Henrietta Lacks, becomes one of the best-selling books of 2010 to 23. Acute myeloblastic leukemia is the next disease to talk about. Unlike CML, where there was a single gene to be attacked, and the CLL, you have a disease which is pathogenesis-wise, mutations after mutations, and the end result after probably 70s and 80s of mutation is you get acute myeloblastic leukemia. It wasn't very easy to think of a targeted agents without chemotherapy to conquer this particular disease. We have had a partial success. 1/3 of the patients of acute myeloblastic leukemia have FLT3 mutation, and we have molecules which target FLT3. 10 to 15% of patients are mutant for IDH1 and 2, and we have got molecules that target IDH1 and 2. One thing that has remained unconquered is the AML with TP53 mutation, which happens in about 6 to 10% of patients, and we don't yet have a breakthrough. Erlena Ventrop and her dog wrote the book Heal. The book Heal describes the truth which many of us do not know, that the man's best friend, dog, is extremely susceptible to cancer. 50% of dogs after the age of 10 years develop cancer. And this is because they lack a tumor suppressor gene called PP53. On the other hand, elephants don't get cancer. And the reason for that is they have 40 copies of this P53. From no copy to 53 copy, and man is in between. So dog invariably dies of cancer, elephant almost never dies of cancer, and the man often dies of cancer. And this is all story of TP53. Lee and Fromeny, both from US, Lee a Chinese scientist and Fromeny a Israel scientist, both described the syndrome called Lee-Fromeny syndrome, where there is a 25-fold increase of risk of cancer in the family, and that is also autosomal dominant. As a result of which there are families like this where different type of cancers occur in different generations, and the chance of succumbing to that is almost 100% because they have a problem with their TP53, which is the gene to prevent cancer. Sue Armstrong wrote the book P53, the gene that cracked the cancer code. And now the scientists are working to break this particular stigma by developing inhibitors of P53. One of them is MDM2PP1. And the day will not be very far, where probably even in my life or in your life, there will be a breakthrough to control and conquer this TP53 mutated leukemias and cancers. So much about the targeted agents. We move on to the part 2 of my talk, which is related to differentiation strategies. The general concept of chemotherapy is to hammer and kill the cancer cell. And therefore you have anti-DNA molecules, alkylating agents, etc., etc. The policy of differentiation strategy is not to kill the cells, but to differentiate it to become a normal cell. So a myeloblast of acute myeloblastic leukemia should mature to become a neutrophil, and for this you require small doses of continuous therapy. Less is more is the principle of differentiation therapy. If you look at the studies from the ancient Indian medicine, the Ayurveda, the book written by Aparna Chattopadhyay, Charaka, father of medicine, Acharya Sushrata, the father of surgery, the German type of medicine, homeopathy, and the Chinese medicine, which is made up of herbs, shrubs, and heavy metals. The difference between a good medicine and a poison is that of dose. The same drug which kills you because you were trying to kill the cancer, when given in small doses continuously, could conquer by differentiating that cancer cell to a normal cell. And the classical example is acute promyelocytic leukemia. It's a leukemia which is once again due to fusion of two genes, the PML and RARA shown to you in green and red. Once this was discovered, probably there was ways and means to control this cancer, and this time it was by differentiation. Arsenic, which is a poison, which is a metal, was discovered by Chinese as a medicine. And this poison, together with another important drug called all-trans-retinoic acid, which is a derivative of vitamin A, when put together, allow the APL to become normal cell, and the cure rates of 85 to 90%, or the highest cure rate in acute myeloid leukemia subtype. The second disease that has benefited from differentiating the cells is myelodysplastic syndrome. Unlike APML, myelodysplastic syndrome is not because of one mutation or one gene change. There are hundreds and hundreds of genes which are mutated or translocated or fused. So conquering MDS has never been easy. But differentiation policy has paid. And in last 20 years, we have seen drugs like azacitidine, decitabine, the group that is called HLA, first injectable, then on your right side, oral drugs, which differentiate a bad cell to a normal cell and allow these patients to live for much longer. Now we even have oral azacitidine right in this country, which can be used in this fashion. So the policy of second part of my talk was less is more, differentiation works. And that's wonderful. Part 3 of my talk is something, the story of the day, story of tomorrow, and probably the one which is going to change the whole medicine, and it has changed medicine. Oncology will never be what it was before, and chemotherapy will be probably a big bye-bye because of the immuno-oncology that has come up in last 20 years. What is immunotherapy? A therapeutic approach that uses humoral or cellular element of the immune system to fight the cancer. Siddharth Mukherjee, who? An Indian-born American physician and oncologist, wrote the book, The Emperor of All Maladies, quite popular amongst the medicos, and many of you must have read this book. Time described it as one of the most influential books in last 100 years. The New York Times called it as one of the best works of non-fiction. Born in Delhi in 1970, studied biology at Stanford, D.Phil from Oxford, MD from Harvard. A trained hematologist, medical oncologist, did the research to find the link between normal and the cancer cell and achieved world fame by writing this book, The Emperor of All Maladies. This brings you to childhood acute lymphoblastic leukemia. The treatment of acute childhood acute lymphoblastic leukemia differs from all other cancers because this is the longest chemotherapy you ever use. You give induction for 4 weeks, you give consolidation for a few weeks, and then you give a maintenance therapy for 2 to 3 years. Why? The principle is that by chemotherapy you have a log kill, and by log kill there is no zero. The last cell of the body has to be killed by body immunotherapy. And by giving a long maintenance therapy, you are keeping that small cell left in the body to the small number so that body immune system can conquer it. That is probably something which one has to consider while using immunotherapy for various diseases. Today, childhood acute lymphoblastic leukemia is another huge success story with 80 to 90% of children getting cured. Unfortunately, the same was not true for the adult acute lymphoblastic leukemia, who still succumbed 2 out of 3. And then came this major breakthrough in the form of monoclonal antibodies. Kohler and Milestone get the credit. In 1975, published a proficient way to produce monoclonal antibody using hybridoma technique. The first monoclonal antibody was against CD20 antigen, rituximab, which is a household name. It was approved by US FDA in 1997 for human use. And this begins a new chapter in the treatment of cancer. Both of them went on to get the Nobel Prize in 1984. Both of them are alive, and you see their modern picture on the right side. Not only that, the monoclonal antibody can be further exploited to give a very targeted therapy to the cancer cell by joining an antibody with a chemical, a drug, what is called ADC, the antibody drug conjugate, so that the drug can be selectively delivered only to that cell which has got that antigen against this antibody. So there is a monoclonal antibody, there is a drug, and there is a linker. Hodgkin lymphoma, is the beneficiary this time of ADC. Traditionally, Hodgkin lymphoma has been a highly curable disease. With simple protocol like ABVD, we have been curing 70 to 80% of patients of Hodgkin lymphoma. However, because Hodgkin lymphoma is a cancer of young people, they live for 30, 40 years. At the end of the day, what do they get? Is shown in the blue curve, the yellow curve, and the red curve. They can get second cancer. They can get cardiovascular problem because of the ABVD that they have been exposed to. And of course, the recurrence of Hodgkin can occur. It took 40 years to go beyond ABVD, but ultimately, we see the light at the end of the tunnel, and that is brentuximab vedotin and ADC. This has given us higher cure rate in Hodgkin lymphoma, which was already curable in very high percentage of patients. Same is the story of non-Hodgkin lymphoma. The commonest non-Hodgkin lymphoma is a diffuse large B-cell lymphoma, nicknamed DLBCL. CHOP was the standard treatment, then came R-CHOP, which is immunochemotherapy, and then there was further advance in which the R-CHOP got replaced with another drug, which is an ADC, and that is polatuzumab vedotin, popularly known as Polaris, just launched in this country 1 year ago. Further increase in cure rate of DLBCL. So with brentuximab, further increase in Hodgkin, with polatuzumab, further increase in the cure of DLBCL. Changing gear, we talked about humoral antibody and its exploitation to conquer cancer. Now let's see the master immunotherapy, the T-cell immunotherapy. Many people may feel that bone marrow transplant is like kidney transplant. Your bone marrow has failed, say aplastic anemia, you replace the stem cell. But in the field of leukemia and cancer, it is not a replacement therapy, it is an immunotherapy. When you replace a stem cell, besides producing hematopoietic cells like red cell, white cell, and the platelet, it produces a new immune system. And those T lymphocytes which are produced will produce a graft versus leukemia or graft versus lymphoma or graft versus myeloma effect and cure you by an immune effect. So cellular therapy in the form of bone marrow transplant was the first immunotherapy on this front. What is new? The new and knocking the door, not at the moment available to you and me, left and right, but already there in the Western world, and maybe next year you will have it in your hands, for various diseases, what is called BiTE antibody, the bispecific T-cell engager, which is an antibody which on one side joins to the T lymphocyte of the patient's body, and on the other side to the cancer cell, brings the T cell to the cancer cell to kill the cancer cell specifically, and that's the story of bispecific antibody. An OPD treatment, and which is with fantastic results. The classical example is in adult acute lymphoblastic leukemia, a drug called blinatumomab, which is an antibody against CD19 and the T cell CD3. All of you have read in the newspaper, if not in scientific literature, about CAR T. It's a household name because last 5 years that is a success story. What is CAR T? Take the lymphocyte of the patient, engineer it in vitro, create a receptor for the cancer cell and transplant it back. So it's an auto transplant with gene therapy. And CAR T today is something which has made big name in 3 diseases in hematology: acute lymphoblastic leukemia, myeloma, and lymphoma. And of course, it's going to be there for probably all the diseases tomorrow, because you can't think of a better immunotherapy than taking out the T cell, making it specific to the cancer cell, and putting it back to the person. In between, there was another discovery called checkpoint inhibitors. The credit goes to these two, the Japanese hero Honjo and the American Ellison. They went on to get the Nobel Prize in 2018. And the checkpoint inhibitor is another success story for those few patients of Hodgkin lymphoma who were left unconquered. And this is the story of nivolumab, which is a checkpoint inhibitor. And what you see in this picture is a relapsed refractory Hodgkin on the left side, and with nivolumab monotherapy, this is the picture on the right side. And she's free of treatment for last 3 years. So hematopoietic stem cell transplant to monoclonal antibody to bispecific T-cell engager to antibody drug conjugate, and then immune checkpoint inhibitor. We're not talked about adoptive cell therapy and the tumor vaccine because they are just knocking the door of the clinicians. Maybe in a year or 2, we will add that to our basket. Part 4 is about the tumor microenvironment. A cancer cell survives because the microenvironment is not hostile. If you can make the microenvironment hostile, the cell will die. Say, for example, a myeloma cell survives in the bone marrow because it likes that atmosphere. It gets its all nutrition from that microenvironment. Tom's River is the book written by Dan Fagin. Talks about Tom's River. Tom's River, it's a story of a town that was plagued by pollution from its surrounding industries. The town is called Tom's River and it is situated in New Jersey in US. The chemicals from the surrounding factories polluted the town from the year 1952 to way past 1980. Investigations revealed that the town became a location for cancer cluster and affected the lives of thousands of people living there permanently. Tumor angiogenesis is another science. Cancer develops its own blood supply to survive. It's not only for the solid tumor, but even for the blood cancer. A myeloblast in the bone marrow or a myeloma plasma cell in the bone marrow develops its own blood supply to survive. Judah Folkman is the person who thought of developing anti-angiogenic molecules to cut down the blood supply of a cancer cell. He worked with shark and the shark cartilage and produced various kinds of drugs which are anti-angiogenic drugs, which have been helpful, and a drug example put over here is a widely used anti-angiogenic compound, bevacizumab. Bart Barloghi is a big name in the field of myeloma. In a small place in US, Arkansas became very popular, known because of the birthplace of Clintons. But for the hematology community, it's because of the Bart Barloghi. A huge center of myeloma had a biochemist working with him on the left side, whose husband on the right side, cardiac surgeon, at the age of 42, developed myeloma and within 3 years became refractory to all the modalities of treatment that's available. She was told that he is going to now die in 6 months. She read about a drug called thalidomide, which when given to the pregnant woman in the first trimester, resulted into the phocomelic babies, babies without arms and legs. And she thought that if this drug can do this to the healthy babies, then it should have potential in the treatment of cancer. She went to Bart Barloghi and asked to give thalidomide to her husband. The rest is history. These have become an extremely important, very powerful compounds for treatment of multiple myeloma. Today, multiple myeloma treatment has become chemotherapy free. What you see on the left side is what we did as student. What you see on the right side is what a modern student is doing for the treatment of myeloma. There is no chemotherapy whatsoever, and the median survival of myeloma from mere 2 to 3 years has become 10 to 15 years, and 20% of patients never get a relapse. They are biologically cured. I come to the fifth part of my talk, and that is related to microorganisms. Though many cancers we don't know the genesis, we don't know the etiology, but in hematology, in some cancers we know. For example, H. pylori causes a low-grade mild lymphoma of the stomach. Hepatitis C virus causes a low-grade lymphoma of the spleen called splenic marginal zone lymphoma. There is an alpha chain disease in the Mediterraneans, which is a small intestinal lymphoma due to an organism called Campylobacter jejuni. All these cancers can be conquered by giving antimicrobial agents against H. pylori, against hepatitis C, against Campylobacter jejuni, and so on. So knowing the etiology is important in conquering blood cancer. I come to the last part, and that is probably, which is a huge breakthrough, is Small Truth in the Small Doses, written by Clifton Leaf. There are 5 monkeys over here in the picture. Can you make out who is the one? And if one monkey comes to your balcony today and the second one on the next day, can you differentiate? You can't, because phenotypically they look alike. But genotypically each individual is different. In human, from the race, you can make out that these 5 groups probably are ethnically different. But if you take one Chinese from another Chinese, an Indian cannot even make out whether they are different people or same people. We looked at horoscope for ages to differentiate between individuals. And the banks and the legal system used the thumbprint because no 2 people had the same thumbprint. The scientists have used the precision medicine. The book written by Laurel Powell, Let's Get Personal, is based on this. So what's new? New is the molecular hematopathology. Use the techniques like FISH, PCR, sequencing, next generation sequencing, and split each disease into 1,000 subtypes based on the precision medicine. We come back to the example of AML. Who is FLT3 mutated? Who is IDH mutated? Who is TP53? Is just 3 examples out of 100 types of AML that one can talk of. So today, no more you will treat all the patients of AML with a particular 7+3 protocol or HMA plus Ven. You will go into their genotype and have targeted agents to conquer this disease. The message is never miss a targetable mutation, because that gives you a pinpoint treatment with least toxicity. These 6 books, The Truth in Small Doses, Storms River, P53, Emperor of Melodies, Heal, and The Immortal Life of Henry Lex, should be either on your bookshelf or at least in your institute library. Computer today puts you to the knowledge library. You have assembled here to listen to experts and give you some knowledge. The same you can have at your home, sitting in front of your computer in your free time. So this should be your luxury, this should be your passion, to have knowledge and knowledge and knowledge, which is at your fingertip, where you don't have to go to conferences, you don't have to go to the libraries. Embrace your computer and the knowledge, and you will be the richest in the knowledge and treating your patients in the best way. Thank you so much for this opportunity. This is my last talk to you. Thank Ganesh for this opportunity, coming all the way to Hyderabad, participating in this beautifully organized meeting. I haven't witnessed anything like this before in my 40 years. Congratulations.
Thank you, Dr. Agarwal. Your topic is more excited and novelty rather, even for our professionals like practicing for the last 40 years. I think you can write a novel, you can write a book on this one. You can definitely get a Nobel Prize, I hope. Because it was so dramatic and explanatory. For the people in the audience, I also think that they are all excited and about this thing, but we are skipping the questions because we are running behind the time. So you can just interact with Dr. Agarwal over a cup of coffee or tea. We'll go to the next topic.
For the next talk, we invite Dr. Vikram Matthews. Okay.
I request all the chairpersons and speakers to gather at the faculty desk. Thank you.
Dr. Vikram Matthews is the director of the CMC Vellore Medical College, and he shall be speaking about hematologists as life saviors.
Yashoda Hospitals welcomes our guest of honor, Professor Vikram Matthews, Director, prestigious Christian Medical College, Vellore. Professor Vikram Matthews has an illustrious career with his educational qualifications from Christian Medical College, Vellore, and also he did his postdoctoral fellowship from the prestigious Washington University, St. Louis, USA. As a reputed physician scientist, Professor Vikram Matthews has been involved in research and management of patients with leukemia over last 20 years. Professor Vikram Matthews has enormous achievements. He has more than 150 high-impact peer-reviewed international publications with more than 8,000 citations. He is recipient of numerous prestigious national, international orations, awards, and felicitations. In fact, Professor Vikram Matthews has done the breakthrough in acute promyelocytic leukemia management with simple drug arsenic trioxide, which has turned APML from the deadliest blood cancer to the most curable blood cancer in the current era. He was the first one to propose single agent arsenic trioxide as curative treatment for the deadly blood cancer acute promyelocytic leukemia. His pioneering work has been published in the world-renowned journals like Blood and Journal of Clinical Oncology. What is unique about Professor Vikram Matthews is, despite being busy as the director of the prestigious CMC Vellore, which has 3,400 beds, Professor Vikram Matthews continues to be at the forefront of clinical services at the prestigious Department of Hematology and Bone Marrow Transplant at Christian Medical College, Vellore, and he is an astute clinician, researcher with pioneer in bringing the innovative scientific developments across the globes to our patients in India in real time despite his administrative busy engagements. We welcome once again Professor Vikram Matthews and really thank him for gracing us by his esteemed presence for Deccan Hematolink 2024.
Oh, I see. I see. Okay. Thank you so much. Thank you so much, Ganesh and the organizers for inviting me. I'm truly humbled by that introduction. Never had an introduction like that in my life. Quite managed to embarrass me. But thank you so much. I hope I don't disappoint. This is post-lunch, and Dr. M.B. Agarwal has taken the fire out of my talk because we did not talk to each other, but we covered more or less the same areas in some ways. But I'll try to give you a slightly different perspective, and I'll try to give it real in the sense of I've never done a topic like this, hematologists as saviors, as lifesavers. So this is very unique topic itself. But I'll try to talk about contributions that have happened that have changed hematology, and in a big way, how we in our small way have contributed and how India as a country has contributed, more important. So I think when we talk about therapy, we have to keep in mind low-cost effective therapy and high-end therapy. These have to balance. These cannot be contradictions and dogmatically opposite to each other. What is needed, and I'll talk to you, unfortunately, a repetition a little bit about the CML and the Aplastic story. I'll try to give you slightly different perspectives. I'll talk to you about the importance of being honest and with our own data. I think it's very important to recognize our problems if we want to have solutions. And in terms of innovations going into the next areas, I'll talk a little bit about CAR T-cell. So when I talk about low cost and excellence, these are two kind of often, unfortunately, different arms of a weighing scale. On the one side, you have cutting edge research, high standards, very high quality, and practically inaccessible to everybody. And the other side, you have poor quality, poor standards, easily accessible, but not really good. Surely we should do something to balance this out. And that is where, equitable healthcare access and equity in healthcare is kind of important. So I'll talk about CML, and all my topics will be related to how can we bring about this equity. Now, Dr. M.B. Agarwal made my talk a lot easier because he already introduced you to the concept of Philadelphia chromosome and how when you have two genes that are exchanged between chromosome 22 and 9, you end up with a novel protein called BCR-ABL. And that's what results in chronic myeloid leukemia. It's also important to remember, and many of you all here may directly or indirectly be involved in research, how research institutions and basic scientists are so critical. They're all putting together little jigsaws. You don't know how this jigsaw 20 years later is going to make a change. In the 1960s, Nowell and Hungerford, sitting in the basement in their hospital, sat and figured out that there was this change in the genetic chromosomes when the time when technology was not even available. They had no idea, but see how this evolves. 20 years later, 10 years later, Janet Rowley comes along and says, this is not just a movement of chromosomes, this is an exchange of chromosomes, and defines BCR-ABL. And much later, another 10 years later, people actually discover the sequence of this protein and say, this is the protein that can result in CML. And then, of course, Brian Drucker comes along and produces a molecule that can bind to that protein and completely shut it off and change the story of CML for so many patients, which is incredibly dramatic. And for many people who are very young in this audience, you have no idea what I'm talking about. Dr. M.B. Agarwal already went through the treatment of CML and what it was. All these agents that he went through, many of them did not change the natural history. The only one that did was a bone marrow transplant, which was expensive. Very few people had a HLA match sibling. And to be diagnosed with CML when you were 30, 40 was like a death sentence. you cannot imagine, people would walk in and you had to find a donor within the first year because the outcome was best if you transplanted within the first year. I think if there are people old enough to recognize these slides, you are truly old. You must start recognizing you are truly old because the youngsters have no idea of this slide. This is the natural history of CML as it was defined. Once you were diagnosed CML, you had a chronic phase that lasted 3 to 5 years, and then you died. That was the history. Because after that, doesn't matter what you did, you would progress to accelerated phase, you would progress to blast crisis, and then the outcomes were extremely poor. Today, students may not even see this slide because the natural history has completely changed with that humble beginning of Nowell and Hungerford. Don't forget Nowell and Hungerford in this story in the 1960s and what they contributed to basic science research. They found this novel protein and they created a molecule. Brian Drucker really created a molecule that can bind to this protein and prevent phosphorylation. If you look at life in many ways, whole of life is not about love and war. Life is about phosphorylation and dephosphorylation at a cellular level. And all of us, everything about life, your memory, the wonderful memory of the dinner you had yesterday is about some cells being phosphorylated, dephosphorylated, electrical circuits going around in a particular pathway. It's a little humbling to stop and think about it. But here you have a new oncoprotein that when this chimeric protein, BCR-ABL happens, it is constantly turned on and keeps on phosphorylating proteins, and the cell keeps proliferating, and that's why you get chronic myeloid leukemia. And the molecule that he discovered essentially went and locked into this protein where it phosphorylates proteins that come into it, and then shut off the phosphorylation, and the cell would actually correct itself, undergo differentiation, and die. And this graph has already been shown to you. This is where we were just a few decades ago. You know, if you were diagnosed with CML, your survival was like at 5-6 years was 8%, almost everybody died. Today, when a patient comes to you with CML, when a patient comes to anybody with you with diabetes or hypertension, does anybody panic? Not really. You say you got diabetes, take a medicine, your life goes on. Today, CML is exactly like that. A patient comes with CML, you tell him you take a tablet, and you know, for the most part, 80%, 90%, your lifespan is not different from a person who has not been diagnosed CML. Yes, there are a few side effects, etc., but you continue to lead an incredibly common life. It is just astounding. In my lifetime, I've seen this change, and today, you know, the registrars or residents really, you know, diagnose CML is no big deal. You know, you talk to a patient, you start tablets, and the patient is fine. Now, I'll take this a little bit further, and I encourage students in this audience to read this review article on the chronic myeloid leukemia and reminiscence. And so this is a story where, even though what I've reached the story till now, it's fantastic, but for the most part, it still remained on this end of very high excellence. This thing, you have to really move around to point it. Okay, anyway, but you know, you have to, it really bothered on the extreme of very high quality and very poor accessibility. So in 2001, these molecules came out, nobody could access it. So you had this fantastic technology which could practically make people's disease controllable, and nobody could afford it, even in the West. Okay? And this is where the generics came in India, and generics are the ones that really were the game changers. And this is not just in CML. Even if you take HIV, when the drugs came out, it was not available. Today, the generics from India account for 80 to 92% of all HIV drugs made in the world. It's an incredible achievement. And in CML, again, you know, the generics that made the difference, where today there is not a single patient in India who cannot afford these therapies, either through government schemes or through private schemes. So it's an incredible equity in terms of distribution of healthcare in the area of CML. And 100% of patients are treated. The arsenic trioxide story, Dr. M.B. Agarwal already told you how difficult it is to treat AML. It's a very expensive disease to treat. And APML as well was a very difficult disease to treat in the early 1670s. We knew how to treat it. The cure rates were very high. Nobody could afford the treatment. And when you started treatment, there was a high risk of mortality from early hemorrhage. And this is when our own experience with arsenic trioxide started. We used to have people in what we call the pre-ATRA era, before all-trans retinoic acid became standard of care, and then in the post-ATRA era, young people who would relapse with us, and we would send away on palliation saying, that's all you can do, we anticipate few weeks of life, and they would come back 6 months back to us completely well, absolutely normal. And there was a consistent story among them. They all went to Dehradun, met Balandro Vaidya, who used to give them a therapy which we knew was rich in arsenic trioxide. And they came back. Around this time, in 1996, there was a publication from China that showed that arsenic trioxide works in APML. So this is the background to how we actually started manufacturing arsenic trioxide. Arsenic trioxide is a fascinating molecule. It's a molecule that's been in the pharmacopoeia for the longest time in the history, for more than 2,000 years. It's been used for all kinds of things, from syphilis to, if you want to have good skin, people used to eat arsenic trioxide. And we know that arsenic trioxide is a non-specific cellular toxin. What I mean by a non-specific cellular toxin, if I take a certain toxin and give enough of it, I'll kill anything. But in APML, arsenic trioxide was not just a non-specific cellular toxin. A high dose of arsenic trioxide will kill all cells. But at the appropriate dose, it selectively kills malignant promyelocytes. And we know the basic mechanisms. I'm not going to go through this in detail. We know that arsenic binds to the oncoprotein called PML-RAR. It brings about polyubiquitination and degradation in the proteasome. And it actually restores what is called the PML bodies after the degradation of the PML-RAR. In 1997, we actually started manufacturing arsenic trioxide in CMC, in our own pharmacy, and we initiate the study. There are lots of people that go to make a story. There's a sister, Teresima, who used to work quietly in the pharmacy. Nobody knew she existed. She used to make this, 6 months. We did all our standardization studies, and there was, it's just a small project. And this is the first patient who actually went on arsenic trioxide in CMC on 20th January 1998. Dr. Alice Kurula headed the thing. We had a protocol which had 2 cycles of consolidation and then 6 months of maintenance. And what happened was, with this therapy, not a single patient of APML we did not treat. We tried treatment in everybody. Before, we were treating about 10% of our patients. Today, when we started the study, everybody was treated. And in good risk patients, the results were very good. In high risk patients, compared to the chance that you would die in a few weeks' time, 70% were being cured. So it was really a big movement forward. It was a very well-tolerated regimen, and there's a lot of body of work that has gone on to this, looking at toxicity, looking at long-term survivals, because in the early days, there was a lot of criticism, questions, is this ethical? When you have a treatment that can cure 90%, but nobody can afford it, nobody asks that question. But you're 90%, 95% can be cured, how can you give arsenic trioxide? And these are the questions that we had to answer. And this drug is very well tolerated. There's no cytopenia. After the first 2-3 weeks, the entire treatment is outpatient, unheard of in leukemia in those days. Patients came, got an injection, and went home. Their fertility was preserved. This is a young population. So this was really, really amazing. But the most amazing part was the cost. It was an incredibly inexpensive therapy. This work gained a lot of attention and was, in a small way, instrumental in moving arsenic trioxide from relapsed refractory cases to upfront therapy. It was, I'm talking about 1998, it's in 2013 that the randomized trial from the West, which kept on in the papers, if you read before 2013, kept saying how arsenic trioxide should not be used, it should be standard combination chemotherapy, etc., while they were actually doing the clinical trial. And the trial came out, without going into the details, they showed that actually arsenic trioxide plus ATRA was superior to conventional chemotherapy. And today, the standard of care is arsenic trioxide and ATRA as upfront therapy in APML. So it has been really a long journey. This is our own real-world data using a combination of arsenic trioxide and ATRA. As the world moved on, we moved on as well. And without going into the details, we have excellent survival in the per protocol treated patients on the study in terms of long-term survival. And the beauty of this is the cost. The cost of arsenic trioxide is very low compared to conventional chemotherapy. After the initial induction, which can be a little expensive, most of the treatment is outpatient, and the chances of cure are incredibly good. So again, you have a therapy which 100% patients can actually can afford it. So this gives me an interesting story about the cost of arsenic trioxide, because we were so involved in it. In 1997, when I was producing arsenic trioxide, the equivalent cost, if I were to convert it in dollars, was 50 cents for 10 milligrams of arsenic trioxide. Okay? After 1 or 2 years, because of legal issues, we had to stop manufacturing it, and we transferred it to Intas. And it became about $8. It costs about 400 rupees for 10 milligrams. Can anybody in this audience guess? Because about 4 years later, Memorial Sloan Kettering just patented arsenic trioxide out of the blue. And what's the cost of arsenic trioxide in the West? Can anybody take a guess in dollars? $600 for 10 milligrams. So the paradoxical situation where arsenic trioxide is the most expensive therapy in countries where it is patented. The patent does not hold in India, and therefore we have arsenic trioxide as the least expensive therapy in India and most of the other countries where the patent does not evolve. So some amount of cynicism about research and patents, I think, is healthy. So our own detailed resource cost analysis of how these drugs work, without going into the details, it tells us that it was the least expensive, very cost effective in comparison to conventional therapy to treat APML. And the most important thing is 100% of patients today can access therapy. Of course, if patients come very sick, with IC bleeds, etc., then their prognosis is not so good. These are some of the faces to the data. There's a lot of patients who have gone through this therapy, and a big thank you to them. This work is moving on in our laboratory to acute myeloid leukemia, and so I would encourage you to watch this space. This is some pictures from my own lab, where we are working on using mitocans with arsenic trioxide in the treatment of AML, and we hope to start a clinical trial fairly soon. We hope to replicate the same results in the context of acute myeloid leukemia as well. There's lots of people who go to make research and laboratory work exciting. These are some of my students in the laboratory, and many of them have done tremendously well. Some of them have moved on to much bigger and better jobs as well. I'll talk a little bit about the thalassemia major story. And as most of you all know, we are sitting in a center that does transplants regularly. And a transplant, for the most part, is where you are basically replacing the hematopoietic compartment in an individual with somebody else's. And unlike a kidney or a liver transplant, the donor is not really losing something. It's just like donating a unit of blood. So anything which is a somatic, like leukemia, lymphoma, or germline, like in thalassemia, where the hematopoietic compartment is affected, conceptually, you can replace it with the donors. That's the principle. So you need a donor. At our center, we do a fair number of transplants, 322 in 2022, and that's gone up further in 2023. For thalassemia major, at this point, all the talk of gene therapy around the corner, it still remains the treatment that is the only curative treatment that is widely available. The broad risk factors are liver size more than 2 centimeters, presence of liver fibrosis, inadequate iron chelation. And if you had none of these, you are called class 1. If you had all of them, you are called class 3, and the rest were in between. And we know from international literature, large bodies of data, that approximately 90% of patients with class 1 would have thalassemia-free survival, going down to as low as 58% when you were class 3. Now, if you look at patients in many of our own centers, these are 2 patients, liver size more than 3 centimeters, 2 centimeters, both have inadequate chelation and different degrees of fibrosis. Fibrosis can vary from just bridging portal fibrosis, just a periportal fibrosis, to bridging fibrosis. If you ask a transplant physician, he'll straight away tell you patient 2 is going to do badly compared to patient 1. But as far as the classification goes, they're all class 3. So this is where, when we looked at our own data in CMC, we recognized that there was a subset of class 3 who did very badly. It was almost unethical to do transplant in this group. It was important to recognize this group. And just age and liver size as 2 parameters, a cutoff of 7 years and liver size of 5 centimeters, would help us to distinguish this. Once you distinguish and identify a poor prognostic group, what's the next thing you want to do? You want to improve their outcome, right? And so this is something that we did. This work was subsequently validated by multiple international studies which demonstrated the importance of age and liver size. And we went on to show that, at least at our center, using a triosulfan-based conditioning, that even in the class 3 high-risk group of patients, we could actually improve the outcome significantly compared to our historical controls. So the outcomes really dramatically improved. And thalassemia major is another one of those stories where, when you transplant them early and when they come back to you much later, it's very, very gratifying. This is just a family, just to illustrate, father, mother. One of them is thalassemia major, post-transplant 10 years, the other is the donor. In reality, you can't look at them and say who is the patient and who is the donor. So if you transplant these children early, it is really, really gratifying, and they lead a completely normal life. We also work with the government. There's Coal India Limited, and there's a Ministry of Health Welfare program that supports patients for thalassemia transplants at about 8. Now there is many more centers that are included, and you can enroll onto either through the Thalassemia Society or through the individual centers, where we are able to offer these kind of treatments across the country to people from many parts and societies where they would have had challenges accessing this therapy in the past. And I think it's constantly important to keep challenging algorithms. Doesn't matter whether it's transplant, doesn't matter therapy, what is relevant and context specific to us. And I've just illustrated 2 slides. When you talk of conditioning regimen, everybody talks about myeloablative conditioning in a young AML. Our own study this time, just put out an ASH this year, without getting into details, demonstrates fairly conclusively large number of patients that fludarabine melphalan as reduced toxicity conditioning is as good as our flu-bu conditioning. So this is something that, again, in a country where you have high amount of regimen-related toxicity and complications, we're always looking at steps and strategies to improve our outcomes. I'll finally talk a little bit about CAR T-cell. We're still a long way to go in this. I'll just illustrate some of our own data, and which kind of replicates what people see in the world. This graph over here is illustrating the survival post-allogeneic transplant in patients with relapsed ALL. The top graph, which is a fairly good survival for relapsed ALL in patients who relapse late and undergo a transplant. The graph below is patients who relapse early after ALL treatment, and even after achieving remission undergo transplant, the survival is less than 10%. So we are looking at a group of patients with a terrible outcome. So CAR T cells, as Dr. M.B. Agarwal already pointed out, is almost like the best of both the adaptive and of the humoral and the cellular immune systems. Antibodies are very effective in recognizing an antigen, but they're not so efficacious in bringing about kill. T cells are incredibly efficacious in kill, but they're not so specific. And what you're doing here is basically you're putting through a lentivirus an antibody to be expressed on the surface of the T cell, which will recognize an antigen of your interest and get activated. So for example, in ALL and BL, you put in a vector that expresses a CD19 antibody on its surface. When this T cell now recognizes a cell which is like an ALL or lymphoma cell that is presenting CD19 on its surface, it gets activated and it kills the cell. Very effective. I think there are 2 components in a CAR T cell that one must remember. One is the vector manufacturing, which has to be industry driven, and the other is the CAR T cell manufacturing itself, which can be done at site. And it's an incredible success story. So this is Emily Whitehead, an early relapsed ALL. She was one of the first CAR T cell recipients, and this is pictures of her taken every year after she received the CAR T cell, and it continues even today. Now the common theme about CAR T cells is very effective therapy, fantastic. Remember your CML story, remember your APML story, all these drugs that are coming out today, fantastic, high quality, accessibility is practically zero. And that's not where we want to be, because they're all industry driven, centralized manufacturing. Even in the US and the UK, it's anywhere between $0.5 to $1 million for one shot of a CAR T cell. So there's a lot that needs to be done. And I told you the story about HIV and CML. I'm fairly convinced that cell and gene therapy is the next frontier that we need to address, and India, I'm sure, will be the source of CAR T cells and gene therapy in the future. Our center itself, we have focused on decentralized manufacturing, that is actually manufacturing the CAR T cells at our site. We work with Milteney, we get the vector from them. We have a GMP facility, a class 10,000 facility, where we use a fully automated closed system to manufacture our CAR T cells. We've published our validation runs, and I'm not going to go into the technical details of this, but the entire system, after you lock the system, is automated from moving the cells, separating the CD4, CD8, activating the T cells, transducing them, expanding them over 9 to 12 days, and you get a product. And our detailed costing analysis tells us that we can do this for less than 25 lakhs, in addition to the cost of the vector. So there's a significant move in the cost, and I'm fairly confident that as more players come up in India, that this cost will actually drive further and further down, because there will be indigenization of not just the vector, but also of all the elements that go into manufacturing CAR T cells. So we finished our phase 1 CAR T trial with 10 patients, and we plan to move soon into our phase 2. The details of the CAR T product is a fresh in, fresh out product. So within 9 days of harvesting from a patient, we are able to infuse the product. And there's a process of what we call release criteria. Patients are admitted in the hospital. For the most part, this therapy is very well tolerated. Of the 10 patients, we had 1 patient, 4 lymphomas and 6 ALLs. One of the lymphoma patients died of progressive disease on the lowest. It's a phase 1 study on the lowest cohort, on the lowest cell dose. All the 6 ALL patients, relapsed refractory, are MRD negative and doing well at this point in time. Of the remaining 3 patients, 1 was a partial response, the other 2 was a complete response. So let me just illustrate 1 patient to you. This is a 59-year-old man, post-auto stem cell transplant to DLBCL, that is diffuse large B-cell lymphoma, refractory. He's on palliation but was in good performance score. We took him into the second cohort in the WellCard study. And what you're seeing on the images on this side is the pre-treatment PET-CT scans, which show you that large mass. This is at the base of his neck, and this is the front of his neck. Huge masses that were there before the CAR T cell was infused. And adjacent to that are images, and here below are the images 28 days post-CAR T cell. Believe me, in my lifetime in relapsed refractory Hodgkin's lymphoma, immaterial of what chemotherapy I've given, I have not seen responses like this. Now, don't go away thinking CAR T cells is magic. It doesn't cure everybody. Even in the relapsed refractory setting, 30-40% is the long-term survival. And many people use in the ALL setting as a bridge to an allogeneic transplant. So there are many questions that it's not very clear where the algorithms are. We're not very clear where the exact answer, what's the best way to use CAR T cell. But in lymphoma, we know that about 40-50% of these relapsed refractory patients are potentially cured of their disease. So these are exciting times, and I'm sure that just as we did with other diseases, we will work towards getting equity and equitable access to healthcare and equity in distribution of these therapies. So in summary, I would say cost-effective care and excellence in medical care don't have to be opposite ends of the spectrum. It takes a lot of people to work together to bring it to a common ground where it is possible. And it takes innovation. You need to work with a number of people. Education, service, and research are integral. Just service without education, without research is not good enough to achieve these questions. So I think it's absolutely integral. And when I say research, I'm not talking sitting in a laboratory and doing something in the test tube. You know, everybody who works as a clinician, who's collecting data, with a lot of commitment and putting the data together, analyzing it and saying how I can improve, that's research. You know, there are so many levels to research. It's very important that you own your own data. And what I mean by that is whatever your data, believe your data. It is absolutely critical to own it and believe it. There's no other way to progress and go forward. You know, if you don't have good demographic or baseline data and all the 3 diseases that you're trying to improve on, then it's going to be very difficult to answer it. There is a world of need there that needs transformational impact. One of you could be the spark. Who knows? One of you could be the next Drucker or maybe somebody else who can bring about these changes. So what is our calling? To share the pain of people, to respond and serve with love, to be the change we want to see. Can I have a minute more, please? So I'll end with a prayer of St. Ignatius of Loyola. Dearest Lord, teach me to be generous. Teach me to serve as you deserve, to give and not to count the cost, to fight and not to heed the wounds, to toil and not to seek for rest, to labor and not to ask for reward. Save that of knowing I am doing your will. I'll stop there. This is our new campus. I hope to be able to invite you all at some point to see our new campus. Thank you for your attention.
Thank you, Dr. Matthews, for your illustrious and elaborative. Luckily, one of my patients who underwent transplant at your center is still with me, coming for follow-up. Maybe we'll talk at some other time. So, as usual, because of the lagging behind time, we are postponing the question hour. Anybody who wants to interact with Dr. Matthews can do it at the coffee club. Thank you. We'll go to the next topic.
After 2 wonderful talks by Dr. M.B. Agarwal and Vikram Matthews, sir, we call upon Dr. Kasi Vishwanathan for the topic of thrombophilia and pregnancy. He is a senior consultant hematologist at Meenakshi Mission Hospital, Madurai.
Professor Vikram Matthews to hand over the quiz winner, Dr. Ravi Kaladhar Reddy sir from Kurnool. Second set, quiz 2. Yes, sir, coming, sir. Heartiest congratulations, sir.
Good afternoon, everybody. At the outset, I would like to thank Dr. Ganesh for inviting me and asking me to deliver this talk. And the audience have heard, and I am also inspired by the talks given by Dr. M.B. Agarwal and Dr. Vikram Matthews. I don't know why Dr. Ganesh has put me behind those two giants. Anyway, I will try to give justice to my topic. Topic is thrombophilia in pregnancy. The outline of my talk is as follows. Introduction, inherited thrombophilia. I'll talk about antiphospholipid antibody syndrome and touch upon CAPS. An estimate of age-adjusted incidence of venous thromboembolism ranges between 5 to 50 times higher in pregnant women compared to non-pregnant females. The incidence of VTE is 1.2 per 1,000 pregnancies. It is 0.6 antepartum and 0.6 postpartum. The postpartum period is actually much more riskier than antepartum period in terms of the risk of thrombosis. About 50% of VTE is associated with the inherited thrombophilia, and pulmonary thromboembolism accounts for 9% mortality in the pregnancy. So we all know the reasons for hypercoagulability in pregnancy, the venous stasis, endothelial injury, and the hypercoagulability which we see because of the changes in the coagulation system. So there are general risk factors specific to pregnancy, both in antepartum as well as postpartum. Antepartum, we have multiparastate, varicose veins, IBD, UTI, diabetes, any hospital admission more than 3 days, obesity, and age more than 35. In addition, in the postpartum, if there is a cesarean section or a postpartum hemorrhage more than 500 ml, eclampsia, pre-eclampsia, stillbirths, and preterm birth before 36 weeks of gestation, and smoking and hypertension are additional risk factors. So where do we see the thrombosis? Mainly venous thrombosis. It can be DVT, pulmonary thromboembolism, cortical vein thrombosis, Pancytopenia thrombosis. Arterial thrombosis is very, very rare and predominantly seen in antiphospholipid antibody syndrome, and it is not seen in inherited thrombophilia. So cause of thrombophilia, it can be inherited or acquired. Inherited, the most common thing are these 5 subtypes. This factor V Leiden mutation and prothrombin gene G20-210A variant, which accounts for 50%, and the other 3, protein C, S, and antithrombin deficiency, which accounts for about the rest of the 50. These defects account for 50% of maternal venous thromboembolism. The inherited thrombophilias are not a single disease. They are not all are not equally responsible for thrombosis. There are some high risk abnormalities, which includes antithrombin deficiency, homozygous factor V Leiden mutation, homozygous prothrombin gene mutation, or a compound heterozygous factor V Leiden and prothrombin gene mutation. The low risk is protein C and S deficiency, or a isolated heterozygous factor V, or a isolated heterozygous prothrombin gene mutation. Now, those things which are not significant include MTHFR, hyperhomocystinemia, and elevated factor VIII levels. So this is the incidence of thrombosis in the various groups in pregnancy. Age, as I mentioned before, is an important risk factor. Less than 35 years, there is less incidence. More than 35 years, the incidence is much higher. Among all these defects, antithrombin deficiency has the highest risk, which is about 6.1% when they are younger, and 9% when they are more than 35 years. When we look at the factor V Leiden heterozygous prothrombin gene mutation, heterozygous mutation, or protein C or S deficiency, the overall incidence is less than 1%. So that's why they are called low risk prothrombotic conditions. Whom do we test for inherited thrombophilia? Patients with a personal history of venous thromboembolism without a prior thrombophilia testing, and patients with a first degree relative, a parent or a sibling with a high risk inherited thrombophilia. So how do we give prophylaxis in such people? All high risk patients, we should give prophylaxis starting in the first trimester, and we should continue the anticoagulation for 6 weeks postpartum, and in the low risk patient who have had previous venous thromboembolism, we should give them anticoagulation. Low molecular weight heparin is preferred. It's once daily. We have to stop it 12 to 24 hours prior to delivery and restart 4 to 6 hours after vaginal delivery. If it is a cesarean section, we can restart after 6 to 12 hours provided there is no unusual bleeding postpartum. And there is no need to give prophylaxis in the low risk patient without a prior episode of venous thromboembolism, because the absolute risk is only 1%. So you have to treat 100 people for the entire 9 months to prevent one thrombosis. So it is not necessary. So coming to acquired thrombophilia, I will mainly restrict to antiphospholipid antibody syndrome, because that is the most common thing which we encounter in pregnancy. The other are not so relevant in pregnancy. I will talk about the pathophysiology, clinical manifestation, diagnostic criteria, and obstetric antiphospholipid syndrome and catastrophic antiphospholipid syndrome. APS is a rare immune-mediated hypercoagulable disorder characterized by the presence of antiphospholipid antibody with a clinical feature of venous, arterial, or a microvascular thrombosis. Some may have adverse pregnancy outcomes. It can be primary or secondary. Secondary is usually associated with other autoimmune disorders, SLE being contributing 30% to the secondary APS. In the prevalence in US, about 17 to 50 people per 1 lakh people have antiphospholipid syndrome. APS can cause recurrent pregnancy loss, and it can cause stroke, MI, and DVT. So it has a myriad of thrombotic lesions, both venous as well as arterial. The pathophysiology, there is a genetic predisposition. We all know there are certain HLA class 2 antigens which predispose them to develop autoimmune disease. Similarly, antiphospholipid syndrome is an autoimmune disease, and there is usually an environmental trigger or a second hit by a bacterial, viral, or parasitic infection. The main culprit is the B cell which produce the antiphospholipids, and there is a contribution by the inflammation by mononuclear cells and monocytes, which activate the complement. Complement is an important component in activating the causing injury to the endothelium and activating the coagulation pathway, resulting in thrombosis. Clinical manifestation can vary between venous as well as arterial thrombosis. So coming to the definition, this is the definition published in 2006, which has clinical criteria 2, which is either thrombosis, both arterial, venous, and a pregnancy morbidity, and laboratory criteria, which is one should be positive of the 3. So we should have one clinical criteria as well as one laboratory criteria, whereas the present criteria published by the American Rheumatology Association as well as the European Rheumatology Association in 2023 not only includes venous and arterial thrombosis, macrovascular thrombosis, and pregnancy complications. There is a myriad of microvascular complication which can cause nephropathy, pulmonary hemorrhage, myocardial disease, and adrenal hemorrhage. And there can be cardiac valvular damage in the form of valve thickening and valve vegetations, and it can cause thrombocytopenia. So laboratory criteria remains the same. We should have one clinical criteria and one laboratory criteria, and it should be positive and 12 weeks when we repeat it 12 weeks apart. Coming to whom should we check for antiphospholipid antibody: unprovoked thrombosis, unusual sites, recurrent thrombosis, young patient with arterial thrombosis, when a patient has a combined arterial venous thrombosis, unexplained sudden onset multi-organ failure due to small vessel ischemia, and pregnancy morbidity. These are the indications for testing APS. What are the antiphospholipid antibodies? There are a lot of antibodies. The 3 things which are most important, which we do it clinically, is the lupus anticoagulant, anticardiolipin antibody, and the anti-beta-2-GP1 antibody. The tests are dilute Russell viper venom test. It's a clot-based assay. We have 3 steps: screening, mixing, and confirmation testing. And I don't want to go into the deal because of the want of the time. And the antibodies are done by ELISA testing, anticardiolipin antibody, and it's not APL, it is anti-beta-2 glycoprotein 1 antibody. Both IgG and IgM are done. If the titer is more than 40, it is considered moderate. If the titer is more than 80, it is considered high titer positivity. Not only it has diagnostic importance, these antibodies also, the antiphospholipid antibodies have a prognostic impact. If all 3 are positive, it is called triple positivity, and they have the maximum risk of the adverse event in form of vascular thrombosis as well as bad obstetric outcome. If it is isolated LA positivity, it has intermediate risk prediction, And IgG antibodies are much more important than IgM, because IgM can be a transient phenomenon after a viral infection, and that's why we have to repeat it after 12 weeks to make sure it is a persisting antibody and not a transient phenomenon after viral infection or drugs or something else, some other reasons. Coming to obstetric APLA, it should have, the criteria is more than 3 consecutive unexplained pre-fetal deaths, that is less than 10 weeks, or early fetal deaths between 10 to 15 weeks, more than 1 fetal death between 16 weeks to 34 weeks, or they have severe preeclampsia or severe placental insufficiency with or without fetal death. So how do we manage? If there is a previous thrombosis, therapeutic anticoagulation is needed, 1 mg per kg of Clexane twice daily, plus low dose aspirin. If it is recurrent pregnancy loss, prophylactic low molecular heparin, which is once a day, and low dose aspirin. If it is only premature delivery and no fetal normal fetus, you just give aspirin, no need for low molecular heparin. Of course, if they undergo section for delivery, prophylactic low molecular heparin is needed. If only antibodies are positive but no clinical features, then low dose aspirin is enough. If it fails after you give the heparin and low dose aspirin, what do we do? Hydroxychloroquine is an option. It reduces the anticardiolipin antibody, and there is a combination of low molecular heparin, low dose aspirin with prednisolone and IV immunoglobulin, which has been shown to be beneficial meta-analysis. And again, if it is a triple antibody positivity, the success rate is only 30%. If it is only a single positivity, success rates as up to 80%. So when we, whenever we have these antiphospholipid antibodies under thrombosis, these patients needs to be on indefinite anticoagulation, and the drug of choice is oral vitamin K antagonist. And DOACs are in fact contraindicated, and it causes increased risk of arterial thrombosis. And for the arterial thrombosis, we should target a higher INR, therapeutic INR between 3 to 4. Antiphospholipid syndrome can cause severe eclampsia and HELP syndrome, and delivery of the fetus will lead to resolution of the eclampsia and the HELP. However, about 1% of APS patient can develop catastrophic APLA. CAPS should be considered a differential diagnosis in all severe eclampsia and HELP syndrome. CAPS and HELP syndrome can coexist. I'll just give a case. A 23-year female, primey, who was pregnancy was complicated by severe HELP syndrome, had a triple positive antiphospholipid antibody, delivered prematurely at 33 weeks in view of the severe HELP syndrome, and was discharged on day 10 postpartum, BP normal, creat normal, platelet count normal. And 2 weeks later, she presented with cough and breathlessness. She had hypertension, pulmonary edema with occasional hemoptysis. Creatinine was markedly elevated. CT chest showed evidence of pulmonary edema, and we think it could be pulmonary hemorrhage. Ejection fraction has dropped to 35%, and hemoglobin was 6.5, and platelets were down to 60,000. Peripheral smear showed cystocytes, and ANA was negative, ruling out the associated SLE causing the nephropathy. The diagnosis was catastrophic APLA syndrome, started on steroids, heparin, and plasmapheresis, and she improved. So CAPS is a clinical presentation of multisystem disorder which can affect the kidney, heart, lung, CNS, and other organs, and which is due to microvascular as well as macrovascular thrombosis, and it is associated with inflammatory cytokine response. Rapid iteration of in the course, clinical course, if not detected early and initiated on therapy, will lead to mortality. Even with the best therapy, the mortality is 50%. So CAPS can be the presenting manifestation of antiphospholipid syndrome. It's not necessarily that in 50% of patients with CAPS, it will be the first manifestation. Prior to that, the patient will not be known to have an antiphospholipid antibody. A clinical clue is if there is a TMA, the schistocytes are also seen in CAPS, is suspected in pregnancy, plasmapheresis should be initiated, and urgently we should done awaiting ADAM-TS 13 level. If it is low, will suggest TMA. If it is normal, it can be HUS, atypical HUS. If there is a positive antiphospholipid antibody, it could point to a catastrophic APLA syndrome. So diagnostic criteria, it should involve 3 organ systems with a small vessel occlusion confirmed by histology and the presence of antiphospholipid antibody. That is definite CAPS, whereas probable is there are only 2 or 3 organ involvement, but no histological proof or no laboratory confirmation is possible, because it may be the first episode, you don't have 12 weeks apart to confirm antiphospholipid antibody persistence. And when we have a patient The triple therapy is the management of choice. There is no randomized control trial. There is no, it's all based on experience of the experts. And three components are anticoagulation, steroids, and plasmapheresis with or without IVIG. And in difficult cases, adding on rituximab or eculizumab, which is a C5 monoclonal antibody, can be beneficial. There are case reports, small case series of adding rituximab, and the response rate has improved from 50 to 75% when we add on rituximab. To conclude, thrombophilia in pregnancy is a major cause of morbidity and mortality. High risk inherited thrombophilia include antithrombin deficiency, homozygous factor V Leiden or prothrombin gene mutation, or a compound heterozygous factor V and prothrombin gene mutation. APS with thrombosis or recurrent pregnancy loss needs low molecular heparin and low dose aspirin. Newer domains of microvascular thrombosis, cardiac valve, and thrombocytopenia are added to the APS diagnostic criteria, and HELP and eclampsia can coexist with catastrophic Aplastic syndrome. Thank you all for the patient listening.
In the want of time, we shall not taking the questions later over the coffee. And after the talk on thrombophilia and pregnancy, we shall be delving into more of hematology and gynecology. Coming to the top, now is the panel discussion on peripartum coagulopathies and bleeding. For this, we would like to call upon the moderator, Dr. Uday Yanamandra.
Thank you, moderator, for inviting us, and thanks, Dr. Ganesh, for giving this opportunity. Can I have chairs for the panelists, please? Or the panelists are going to sit in the front? How are we going to have that?
They can put up on the chairs.
Yep.
We call upon the panelists. Dr. Sunil Debadwar, Dr. Sajia Gulshan, Dr. Manoj Toshniwal, Dr. Rama, Dr. Vandana Hegde, Dr. Anita Kumaya, Dr. Krishna Veni, and Dr. Tarkeshwari.
Thank you, ma'am, for doing the job. Okay, I can see the slumber in the auditorium. Okay, post lunch, too much of glucose into the brain, and awaiting coffee or a cup of tea. I think I will request a raise of hands for all those people who are gynecologists here in the auditorium, please. Gynae related, gynae ops, raise of hands, please. None? Okay, okay, fine, good. How many medicine and medicine related? Wow, okay, fine. And how many of you who do not belong to gynae or medicine sitting here? Raise of hands. Okay, so what are you people into? Pediatrics. And here, few of you, any other people other than pediatrics? Okay, fine. So we'll make sure that we'll entertain you adequately, don't worry. Okay, till the time they are arranging the chairs, let's have some light talk to make sure that everybody gets up from their sleep. Okay, now you see a 30+ sign there. Okay, so by looking at this 30+ sign, which movie junior artist do you recollect from Telugu movies? Wonderful. They deserve actually the iPads, not for the cushions. Okay, so 30 years industry ikkada. Anyway, the Yashoda story and my medical journey story almost go parallel, hand in hand. Both of us, like from the time Yashoda got established, my medicine journey started. So both of us are 30+ now. So I can also proudly say 30 years industry ikkada. So can I request the panelists to come onto the stage, please? Okay, I request you to kindly scan the code, please. Because the way we are going to run this panel discussion is you are going to give the answers, and based on those answers, the panelists are going to say why you are right or why you are wrong. So I request all of you to kindly scan the code. You are putting questions? And these are not your questions, sir. These are other questions, normal questions, yeah. No, sir, there is this thing already. these are special prizes from directly from Dr. Ganesh. So, yeah, can the people scan this? Okay, so this was the first question. So this is just like runner to see whether your scan code is working or not. Yeah, write the answers. Let's see that your scan codes are okay. Come on, he's not NTR. It's shame for people who are writing this as NTR. Okay, chalo. I think with this introduction, we can start off the story. So, with the previous 2-3 lectures, which you have heard about, high voltage lectures from Dr. M.B. Agarwal, followed by we had lecture from Vikram Matthews, sir, both doyens in the hematology circles. Then we had an introduction by Kasi sir, Vishwanathan sir, on talking about the thrombophilias in pregnancy. So I've got a group of elite panelists here. We have a group of hematologists and gynecologists come obstetricians who are going to answer, in which Dr. Manoj Toshniwala and Dr. Anita were not able to come. So we have rest of the people here. Yeah, you have the mics. So just to introduce safe motherhood, though many of you in the audience are not from gynecology, but a lady comes to your life as mother, sister, wife in multiple roles. Safe motherhood is one of the important rights of a woman. And maternal death is a failure of the society. Actually speaking, irrespective of what specialty you belong to. So they are supposed to be guaranteed a safe motherhood, and that's our responsibility. So the current talk, what Dr. Ganesh has put in, is primarily aiming at that. And we are going to deal this in 3 sections: postpartum hemorrhage, bleeding other than postpartum hemorrhage, and then coagulation disorders. And I'm going to have it bilingual because I rarely get an opportunity to talk in Telugu. Okay, so I'll do that. So first, I would request any of the gynecologist or the obstetrician here. Ma'am, how would you define a postpartum hemorrhage?
Quantitative definition would be a vaginal delivery with more than 500 ml blood loss, or a cesarean birth with more than 1000 ml blood loss. But otherwise, any amount of blood loss causing hemodynamic instability in the mother would be postpartum hemorrhage.
Excellent. So as rightly brought out, so anything which actually disturbs hemodynamic status of a lady would be a postpartum hemorrhage. Now, you know what, on a lighter sense, you know, postpartum hemorrhage is like a blood loss is like beauty. Beauty is in the eyes of the beholder. So for every husband, the wife ఎప్పుడు కూడా ఎక్కువగా అందంగా కనబడదు, పక్క వాళ్ళ వైఫ్ ఎక్కువగా అందంగా కనబడుతుంది. ఇన్ ద సేమ్ వే ఫర్ ఎవ్రీ గైనకాలజిస్ట్, వాళ్ళు చేసిన సర్జరీలో బ్లడ్ లాస్ ఎప్పుడు ఎక్కువగా కనబడదు, పక్క వాళ్ళది ఎక్కువ కనబడుతుంది. సో ఇన్ ద సేమ్ వే వెన్ యూ ఆస్క్ ఎ గైనకాలజిస్ట్ హూ ఈస్ ట్రీటింగ్ అ పేషెంట్, అరే హార్డ్లీ కుచ్ కहाँ गया था blood types, but you ask the anesthetist or the other gynecologist, they will tell you how much is the blood loss. So for estimating blood loss, we need to have some criteria. So you can have visual criteria, which are always wrong. Okay, you can have hypotension, you can have tilt test, you can have tachycardia, and you can have urine flow to reflect the dynamic status. So we have a rule of 30. So 30% blood loss, rise of heart rate by 30, rise of respiratory more than 30, systolic BP down by 30 millimeters, urinary output less than 30, and hematocrit drop more than 30 would be labeled as that. So now we would want people to answer. In fact, one of the panelists can take this on. What percentage of your patients, ma'am, generally you see PPHs? Okay, 9%. Ma'am, so ma'am, anyway, we are hematologists. So from your side, 9% is high, low, moderate. What is it?
Ideally, it should be below 5 because
Okay,
we deal with the high-risk pregnancies who come with a lot of complicated medical disorders. In the unit which we work is 9, and the other units are less than 5%.
Ma'am, so does this percentage for a novice like us vary depending upon corporate versus government hospitals?
I don't think so, because universally we have a very good guidelines by the government of India, and all of us follow the active management of the 3rd stage of labor and even the 4th stage. It's nothing like that.
Sure. So these are some of the figures which I pulled out from the internet. So the number of PPH across the world and the number of maternal deaths which occur due to PPH. So can I have another gynecologist? Like the outcomes of PPH, are they variable despite of the best medical efforts? So, okay. So ma'am, what's your take on it? So how do you feel that the outcome of PPH, does it differ based on the type of the medical efforts, despite of the best medical efforts, still you find PPH, and what are the reasons, and how do you feel in the society you can curb this? Or what are the challenges basically?
That definitely, as she's working in a tertiary unit, she does have a slightly higher percentage of cases. But we need to understand that over here, when you tell best medical effort, also depends on the infrastructure, the skill of the operating person, and the experience that they have handled the number of cases. So most of it, when you come to India, I think that is where we lack, that we are still working on improving our MMR. Okay. So that definitely depends on the medical efforts and the infrastructure.
Okay, ma'am, great. So let's take upon a case and we can have the next gynecologist. Ma'am, sorry ma'am, I'm not aware of the names, please pardon me. Okay, so a 32-year-old pregnant woman, G3P2, undergoes a routine cesarean section. Shortly after delivery, she starts experiencing excessive bleeding. What is the most likely cause? Now the audience answered it as uterine atony, and ma'am, anyway, you can just elaborate on this.
Yeah, it is most of the time it's uterine atony. That is the most commonest cause of the PPH. And sometimes it could be the placenta that is not being separated, especially if they are having the cesarean section for a previous section and the placenta is adherent, then sometimes it could be the adherent placenta. So most common cause is the uterine atony.
Okay. And ma'am, how do you people handle such situations when you have uterine atony?
So as soon as the baby is delivered, we ask the anesthetist, and most of the time they do it even before we say. They give the 5 units of oxytocin IV. Okay. And if it is a normal delivery, we give it 10 units of oxytocin IM. And if the bleeding is not getting controlled, then we go for the oxytocin infusion. That is 40 units in 500 ml of saline, and we run it at the rate of 125 ml per hour. And even with this, if it is not getting controlled, then we go for the tranexamic acid, because now we are using it most often. And if it is still not settling, we go for the carboprast, that is 250 micrograms IM. We can give maximum up to 8 doses, but if it is not settling in 2 doses, if it is a normal delivery, we try to take them to the theater. Yeah. And the other methods are, we have the misoprostol, and which works very well. Again, we can give about 1,000 micrograms per rectally. And now, recent days, we have the carbitocin, that is the most effectively working, and it is not affected by the heat, because the rest of the things can be affected by the heat. So now we are using in the PPHs where they are not responding, we go for the carbitocin as well.
Okay, yeah. So primarily it's uterotonics,
yeah.
From A to Z, whatever you have said.
Yeah.
They are all uterotonics that you give. So if the uterotonics fail, then what next?
So now, means in our setup here, we go for usually the balloon, that is the Bakri balloon, which works very well with applying the mechanical compression. And now the research evidence is coming with regards to factor 7, but obviously the cost is one of the factor, that is we are not able to use it routinely on the patients, because each one dose of it is costing around 35,000. And obviously the availability is also not much in like government hospitals and all. And here also I think it's difficult to get it. And so that is one of the things. If that is not helping, then we have to go for the surgery. Like we go for the compression sutures, like a Beelin suture. And if it is not helping, we go for stepwise devascularization, like uterine artery ligation and internal iliac artery ligation. And if we have the facilities like tertiary unit like this, we can directly wheel them for the embolization as well. If none of this works, then the last resort is for the hysterectomy. But obviously, we have to look at the parity of the patient and affordability. And if you are making the decision of the hysterectomy, sometimes we have to make this decision early, because patient will deteriorate very quickly. And whenever we make this decision, always we take the other consultant for the second opinion before we make that decision.
Sure. Thank you, ma'am. That was like a typical final MBBS answer where you gave all the points crystal clear of how to go about it. So that was really, really nicely brought out. So this was MMR of what it is in India. It's coming down, but we want it to further come down. And as ma'ams were pointing out, so this is where the government wants it to be below 70, whereas AP and Telangana already are less than that, but there are multiple states which are actually above that, and we want it to be lower and lower. And one of the important reasons for a high MMR happens to be postpartum hemorrhage, and the major reasons, as was already brought out by the panelists, are uterine atony, placental debris, abnormal placentation, and uterine inversion. So, ma'am, for the students or for the people, can any other gynecologist take on? What are the 4 T's that you generally look for in these patients? So, can anyone take on that? Yeah, ma'am.
The 4 T's are, T is for tone, T is for tissue, trauma, and thrombin. So tone is uterine atony, T is retained products of placenta, trauma is if there's any cervical tear or vaginal tears from which it's bleeding, or thrombin is because of DIC or any other condition.
Excellent. So these are the 4 T's that are supposed to be kept in mind. So now this has already been answered, so I'll just skip that and go to the next one, wherein ma'am has already explained that surgical interventions happen to be one of the major way of managing these after the uterotonics fail, and the various types of surgeries ma'am has already told: removal of residual placenta, the balloon, the suturings, and various other things. So despite of all these things, we still have got high number of PPH. And so now the question comes, what are those patients where we define the people as having severe PPH?
Hypertensive disorders of pregnancy, jaundice complicating pregnancy, the liver disorders, and renal pathologies, and hematological conditions. These are all at high risk. And also we have grand multiparity and previous repeated sections with adherent placenta. So there is a risk assessment which has to be done at booking, and every trimester you have to review your risk assessment, and you should have the red flags when the mother comes for birth.
Ma'am, thank you, ma'am. So these are the various risk factors for identifying those people who have a high risk for PPH, and this is how we define it. Now, this has already been discussed, wherein we have got recombinant 7A. Now, can I have one of the hematologists answer this? So, where do you feel to put recombinant 7A in the management of PPH? Because we all use it for different purposes. This is a new indication which has come in actually. So, where do you put this actually based on the data that you have for the management of PPH?
Hello.
Yes, sir.
As we know that uterotonics have the first line treatment for the PPH management, but many of the times they fail. So whenever the uterotonics and all surgeries fail, then we have a role of a NOVA7 or eptacoag alpha, the recombinant factor 7.
Great. And sir, would you like to slightly elaborate on the various studies on it?
There are these randomized studies are available.
Yeah, so there are 2 studies. One is a RCT which has been done, which led to its approval. And second is the real world data also we have now, wherein which shows that basically that these patients are helped by giving recombinant 7A. But as rightly brought out by the panelists, cost is a major factor, and the amount of money which is involved and the availability. But it can be used for all causes of PPH. The summary is that, and around 44% reduction in the invasive procedures, and without no additional thromboembolic phenomena. So the people should not be worried if we give a NOVA7 to these individuals or factor 7A, there will be a higher risk of thrombosis. It doesn't occur that way. So there is no additional increased risk of thromboembolic events. And this is a summary of all the data that we have. And these are the various studies which have been published from our country on how this helps. So it can be given upfront even without undergoing. So at the level of uterotonics, at the level of the ligatures, or at the level of surgery. So it can be given as first line, second line, and third line. It can be given at every line of management. So that's something new which has really come up, and it can be really life-saving, and particularly those places where you do not have additional expertise for taking up for urgent invasive procedures. Okay, now let's come up onto some heart-to-heart questions. Ma'am, so all the obstetricians sitting here, what are those conditions where you'll give a call for a physician? We understand that you don't like us very well, but still, so what are those places where you will call a physician to manage your cases?
Sir,
We are the people where we are also not liked because we have in-house physicians. 5 of them work in Fernandez. We have hematologists who are on call. So we always seek their help. In the beginning itself, when it is a thrombocytopenia complicating pregnancy persisting, so we do refer to them and we have a plan of management. So
ma'am, so you brought out thrombocytopenia. So in the situation of bleeding and coagulation, that's one place where you definitely seek the help of a hematologist or a physician. Any other situations, ma'am?
Sepsis.
Okay.
Yeah, all medical disorders like cardiac we have, and we plan it in the beginning itself what type of uterotonic we have to use after birth. So all high risk conditions are at risk of postpartum hemorrhage. We do involve the physicians. Hematologists, they don't visit so often to our hospital's maternity unless it is an institution where they are there always. So we send the mothers to them and get their opinion. Like we have inherited thrombophilias as well as we have thalassemia, sickle cell disease. These are the mothers where we ask for the help.
Very good. Wonderful. Ma'am, you wanted to say something?
Bleeding disorders and thromboembolism. So most often, I think you are involved from the beginning to the end because we start off with the anemia and we start off with like a lot of problems, as Madam said, sepsis, coagulation disorders, DIC. And I think when we have the DIC, definitely we need to be there, call you at that time, definitely.
Yeah. So one point which I agree with all the panelists, out of all the subspecialties of medicine, one which is closest associated with gynecologists or obstetricians is hematology. Because whether you see anemia, which is the commonest problem, thrombocytopenia, or you look at the various other additional complications which can occur like HELP, eclampsia. So the hematology definitely gets included in that. So having a good hematology friend for a gynecologist is one take-home message for everyone. So now, how many of you, ma'am, still perform a BT or CT on today's date? No? Wonderful. So that's the next take-home message, that this is obsolete. We don't use it for fitnesses. We don't use it for anything. So it's something which we should not be doing. So now next, getting on to, so let a patient not having PPH is having systemic bleeding peripartum. So let's go on to that to look at a case. There was a primigravida. She develops DIC after delivery with persistent bleeding from various places, from suture sites and other places, and thrombocytopenia present. What condition is most likely associated with this presentation? Can we have the audience keep polling in the meantime? Okay, whoever has opted for APLA, please understand, APLA primarily presents as thrombosis. APLA, though you have a raised PTT, it's a laboratory misnomer. It does not lead to bleeding generally. So it's not APLA. So anything else? Okay, wonderful. Yeah, fine. So good. So with that understanding, let's go to the another case. A 32-year-old primey, eclampsia, IUFD, delivered by LSCS. So no excess bleeding during LSCS, but 2 days after that, she develops high-grade fever, large ecchymotic spots, and oozing from stitches. I borrowed this case from Dr. Ganesh only. So the patient has a anemia, leukocytosis, thrombocytopenia, raised creatinine, deranged PT, deranged APTT, low fibrinogen, high FDP, ultrasound showing retroperitoneal collections, the urine examination showing plenty of RBCs, indirect hyperbilirubinemia, blood culture showing GNB. What is the possibility that we are looking at? Yeah, anyone? Yes, ma'am.
Maybe it's thrombocytopenic.
Ma'am, leukocytosis present also simultaneously.
It's probably sepsis, DIC with sepsis because of the IUFT. It could be the cause because of the gram-negative picture.
Sure. Wonderful. Now, can I have one of the hematologists come physicians to answer what should be the next medical management for this patient?
Whenever DIC occurs, we have to look for what is the cause of the DIC. The first most is the sepsis, or then we have to look. We have to treat with higher antibiotics. We have to look for any retained products of conception is there or not. Then only first is main is the treatment of the cause, and along with the medical management of the DIC.
So, what medical management would you be advising these patients?
Transfusion support along with antibiotic support.
Okay, so as DIC is commonly known as, this is what it is, and we can have multiple causes of DIC. So he has rightly brought out that treatment of underlying cause is the first thing that is need to be done in DIC. Whatever you do other than that, it is not going to help. So identifying the cause and treating the cause is important. So for that, we need to know the cause. So can I have one of the gynecologists bringing out the cause of DIC in your patient population? So what are the general cause of DIC that you people see generally?
It can be preeclampsia, eclampsia, IUFD, abruption, sepsis, like septic abortions, then AFLP, amniotic fluid embolism.
Perfect. So these are the various causes which can be seen in the gynae patients. So now getting back to the hematologist, now the gynecologist says, "मैं तो नहीं विश्वास करती है DIC है. ये तो patient is okay. This is some thrombocytopenia." So what scoring will you use generally to say that the patient has got DIC or not?
Usually follow ISTS scoring for these points: INR prolongation, fibrinogen, D-dimer, and platelet levels. And then we characterize it as whether it is actual DIC or not, as impending DIC.
Wonderful. So we have a scoring. Now, the closest differentials, as gynecologist said, could be TTP versus ITP. So as a hematologist, how would you tell them that this is ITP or TTP or DIC? So some clues.
Usually for an ITP patient, the patient does not look very sick. They have thrombocytopenia. Then the coagulation disorders are the PT, APTT, like in this patient is very deranged. The fibrinogen is low. So those things are not there in ITP. Patient may also have a previous history of ITP, or it may have developed during the pregnancy itself. Then from differentiating from TTP, you have obviously the patient will be sick, there'll be cystocytes present on the peripheral blood, the bilirubin will be raised, the coagulation profile will be normal. And DIC, of course, is a systemic disease where you have some underlying cause, and we've already been highlighted by the other panelists. And all the three, your PT, APTT will be deranged, the fibrin degradation products will be high, and of course, the patient will look very sick. And the treatment, of course, we need to differentiate between these three conditions, because the treatment that we do is quite different from in each cases.
Yeah, wonderful. So has been very rightly brought out. So one take-home message for all physicians: please don't start diagnosing patients as ITP for the first time beyond 3rd trimester of pregnancy. So it's generally a red herring. So as madam rightly brought out, there should be a previous history, or generally it should be present from the beginning. So then that goes in favor of that, not very sick looking. TTP, DIC very close to each other. Cystocytes are something which can easily differentiate both of them, and the coagulation parameters.
Dr.
So
Uday, 2 minutes more.
Yeah, sure, sir. We are about to finish.
Yeah.
So those are the ones. Now, these are the various complications which can occur because of the DIC, wherein you can have all these problems which can occur. These are the various signs and symptoms. The patient can either present with severe bleeding, can present just with skin oozing, can present with shock, or can present with multi-organ failure. And now coming on to the management in a gynecological case, can one of the gynecologists quickly allude on that? How do we manage in gynae patients the DIC? So based on the fetal status and the other things.
As the hematologist said, we need to identify the cause and address the cause first. If it's IUFD, we need to deliver. And simultaneously, we need to stabilize the mother, secure the IV line, send the blood parameters, arrange for blood and blood products, and simultaneously do the delivery.
Wonderful. So one most important thing that you need to understand in this is the transfusion protocols. So generally, when DIC patients have to be transfused, you generally follow 1:1:1:1. So that's something which is very important. Or the easier way is to transfuse whole blood, because whole blood as such have got the proportions intact. So those are the ones which needs to be done, whereas the various aspects of the thing. Now last, coming on to the coagulopathy, here I'll quickly go on to only 2 aspects which I would like to know from the people, both from the hematologist first and then followed by the gynecologist. The choice of anticoagulants in the postpartum period.
For obstetricians, it is heparin.
Wonderful. Ma'am, unfractionated LMWH?
We prefer unfractionated because of the cost factor. If people can afford, it's LMWH.
Okay.
Other thing I wanted to tell is you should have a hemorrhage cart in the obstetric unit, and also you should have a bundle that is called PPH bundle, which has been developed by the FIGO. It's available.
Ma'am, very true.
Yeah, I agree with ma'am, and I want to add that DOACs are contradictory. Warfarin is also given.
Wonderful. So now the thing is, LMWH versus UFH, many of the hematologists or the gynecologists prefer to change just pre-delivery from LMWH to UFH. Can somebody elaborate on that? Why do you advise the people to do that?
LMWH is more longer acting than unfractionated heparin. You can switch before delivery 36 hours from LMWH to unfractionated heparin, and unfractionated can be stopped around 6 hours prior to delivery. That is one cause. Another is if there is any renal compromise that is occurring, then of course you have to switch to unfractionated.
Wonderful. So one take-home message is, nowadays is a era of epidural analgesia. No lady wants to go through the pain. So such situations, UFH reversal is easy. Once you stop it, the effect only lasts for 7 to 8 hours. So just before the delivery, it's preferable to shift UFH for all the said reasons and also for this. The last question, ma'am, duration of anticoagulation to the hematologists in patients with peripartum thrombosis.
So we prefer for at least 3 months, not more beyond that.
Okay. And for those people who are already diagnosed case of thrombosis, now coming for pregnancy, thrombosis in the previous episode and now coming for this?
At least 6 weeks. A minimum of 6 weeks you have to give postpartum. Yes.
So the point is, postpartum continuing the anticoagulation for 6 weeks is mandatory because the chances of thrombosis postpartum increases. So that highest peak of CVTs and the pulmonary embolisms and DVTs is around that particular time. So the 6 weeks period postpartum needs to be covered for the anticoagulation. So that's mandatory for those people who already have thrombosis. So with that, I would like to end here and thank all the panelists for actively participating and answering the questions. Over to the moderators, please.
Thank you.
Thank you, Dr. Uday, for conducting the panel discussion excellently. So I thank all the panelists for this thing. Any queries, you can interact with them individually. Now we'll go to the next topic. Common Hematology Consults in Pregnancy by Dr. Vinay Bora. I welcome Dr. Vinay Bora over to the podium.
No pocket. Maybe here.
Quiz questions, I think, 5 minutes. Okay, slide.
Just we will have the third quiz session. I request all the eminent delegates to be seated. We have total 4 quiz sessions. We have accomplished 2 till now. I'll finish the third one now. So can I have the slide deck ready? Please scan the QR code.
Okay, question 1. Pick up the true statement regarding CM. Okay, next question. Pick up a false statement regarding CLL. And the answer is F. Pick up a false statement. And the answer is B. Pick up a false statement. And the answer is A. All are hematological emergencies except. And the answer is C. Which one of the following is a high risk thrombophilia? And the answer is C. It's a clinical scenario. A 26-year-old primary gravida is admitted for vaginal delivery. She develops disseminated intravascular coagulation after delivery with persistent bleed and thrombocytopenia. What condition is the most likely associated with this presentation? And the answer is B. Another scenario, a 34-year-old woman, G4P3, has a history of postpartum hemorrhage with her previous deliveries. Which intervention is most effective in preventing postpartum hemorrhage in this patient? And the answer is C. That's the end of the quiz. Thank you everyone for participating. The winner will be announced later. I request the chairpersons to continue the session. Thank you.
Yeah, I request Dr. Vinay. He's a consultant hematologist and BMT physician at CHL Hospital Indore. Kindly take over.
Good evening, everyone. Thank you, Yashoda Hospitals. Thank you, Ganesh sir, for inviting me here. And of course, thank you for sparing your Saturday lazy evening for this academic session. So I've been asked to talk on common hematological issues in pregnancy. There are various hematological issues in pregnancy which women may develop, and we as a hematologist, or you may as physicians, are called upon to deal with these issues. There are issues such as sickle cell disease, thalassemia. There may be issues with platelets such as thrombocytopenia, thrombocytosis. Rarely, we have been seeing DIC for last 20 minutes. There are patients who will develop DIC, rarely HUS-TTP. Deep vein thrombosis can sometimes be seen in second and third trimester of pregnancy. Very rarely patients would present with pancytopenia during pregnancy, and unfortunately they are diagnosed to have aplastic anemia, acute leukemia. So in 10 minutes it is not possible to address all the issues. So I have selected two important issues which we as hematologists and you as physicians would be routinely seeing in clinical practice. So I would start with anemia. We all know that anemia is universal in pregnancy, and out of many causes of anemia, iron deficiency anemia remains the commonest cause of anemia despite iron supplements. Very important catch here, because the commonest mimic of iron deficiency anemia is thalassemia minor. If we go into little bit of detail, we all know that iron deficiency anemia and thalassemia minor present with microcytic hypochromic anemia. If we can diagnose thalassemia minor, detect it in first trimester, it would be a great help to the nation, because this is how we would prevent the birth of thalassemic children. Can we do it, looking at simple CBC sitting in our OPD? Yes. When we have microcytic hypochromic anemia, which most of the pregnant females would have on their first CBC, look at something called RDW. If RDW is normal, it is likely to be thalassemia minor. If RDW is on the higher side, it is likely to be thalassemia minor. Just to give you two examples of CBC. This is how CBC looks like. This is first female who is pregnant, has come up for routine antenatal visit first trimester, HB 8.1, by definition anemia. MCV on the lower side, we know that it is microcytic hypochromic anemia. When you look at CBC, immediately look at RDW. RDW is normal. This is first. Second, we have another lady whose HB 7.2, second trimester. Again, microcytic hypochromic picture, but look at RDW. RDW is on the higher side. So if we analyze these two CBCs, and this is how most of the pregnant females would present, normal RDW would have thalassemia minor, and more than normal RDW would have iron deficiency anemia as a probable diagnosis. Things may not be that easy. Of course, we have to confirm this with iron studies and HB electrophoresis. But looking at CBC, we can at least screen the patients who may need HB electrophoresis, because if this is done in first trimester, and if we can pick up thalassemia minor in first trimester, we may offer prenatal diagnosis and prevent the birth of thalassemic children, which is a burning problem in the country. You all know better than me that how we treat iron deficiency anemia, but some important facts about treating iron deficiency anemia in pregnancy, especially most of the pregnant females, when they are prescribed iron, oral iron, they would be non-compliant because of many gastric issues, and it is proven beyond doubt that alternate day iron therapy, oral iron therapy, is way better than daily iron therapy. There is absolutely no point giving oral iron twice daily, thrice daily in a desperate attempt to improve hemoglobin. In fact, body's physiology works in such a way that when oral iron is given alternate day, absorption would be better, rise in HB would be similar. We all know that IV iron is contraindicated in first trimester. Even if patient has proven iron deficiency, IV FCM, ferric carboxymaltose, is well tolerated in pregnancy. It is safe and can be safely used second trimester onwards. When it comes to using IV FCM, very important point that we should not prepare excessive dilutions of IV FCM. The recommended dilution is not more than in 100 milliliters of normal saline, even if you are using 1000 milligram of FCM, because if excessive dilutions are used, the infusion times will be prolonged. That would lead to a lot of allergic reactions, hypophosphatemia. There are patients who may develop convulsions with IV FCM. Otherwise, IV FCM is a wonderful drug, but we have to follow these precautions. Very important to diagnose thalassemia minor in first trimester itself, because this is how we would be able to offer prenatal diagnosis and prevent the birth of thalassemic children. From iron deficiency anemia, we have another problem, which is sickle cell disease. I don't know how common sickle cell disease is here, but I come from Madhya Pradesh, and in MP and Chhattisgarh, in fact, these are so-called sickle cell belts of India, where surprisingly, for us it is not a surprise, we get a lot of pregnant females who are diagnosed as having sickle cell disease for the first time in pregnancy. I'm not talking about sickle cell trait, I'm talking about sickle cell disease. So when we say sickle cell disease, we know that sickle hemoglobin HbS on HB electrophoresis should be more than 40% by definition, because these are the females who would be typically classified as high risk pregnancy. They would need special attention during pregnancy. Those females where HbS is less than 40, they are typically classified as sickle cell trait, and they may not need special treatment apart from the routine antenatal care. So we all know that hydroxyurea is a wonder drug for the treatment of sickle cell disease. In fact, those of you who have been dealing with sickle cell disease in pediatric patients, in adults, we all know that we start them hydroxyurea when HbS is more than 40% on first visit itself. But what about pregnancy? The conventional teaching, the classic teaching says that hydroxyurea has to be stopped as soon as pregnancy is diagnosed. But this may not hold true, because now we know that pregnancy is not an absolute contraindication for the continuation of hydroxyurea in sickle cell disease. It is not teratogenic. But there are problems with hydroxyurea. If use of hydroxyurea is continued for sickle cell patients during pregnancy, that may lead to fetal demise and low birth weight, and that is how nobody would like it, and hydroxyurea is stopped. So are there any patients in pregnancy who are pregnant, have sickle cell disease, where hydroxyurea can be continued? Yes, rare patients in second and third trimester who have repeated painful crisis, who have history of repeated admission, can be offered hydroxyurea after careful discussion. Very important, in pregnancy sickle cell disease, we have to continue low dose aspirin throughout the pregnancy, because this is not to prevent deep vein thrombosis or thrombotic complications, because sickle cell disease is one of the prothrombotic condition, but use of low dose aspirin would prevent preeclampsia and eclampsia. Otherwise, the sickle cell patients have higher risk of developing preeclampsia during pregnancy. Very important, adequate hydration. Patient would need repeated counseling to maintain adequate hydration. It is very important to maintain their hemoglobin more than 8 by using hematinics or say regular blood transfusion. Antibiotics, the threshold to use antibiotics in sickle cell disease pregnancy should be little bit higher, because otherwise these patients may succumb to sepsis because they have functional asplenia. Those patients who are admitted, repeated admissions with acute chest syndrome, DVT, pulmonary embolism, should be continued on primary prophylaxis with LMWH. Prenatal diagnosis is to be offered to those patients where partner has one of the hemoglobinopathies. It's a myth that iron cannot be given to sickle cell disease or thalassemia patients who are pregnant. In fact, if we want to prescribe them iron, we get their serum ferritin done. When ferritin is less than 50, we have to prescribe them iron. After anemia, very important part, which is thrombocytopenia in pregnancy. Thrombocytopenia, I would say, because I see a lot of patients who are pregnant and have thrombocytopenia, I probably consider thrombocytopenia as one of the physiological parameters in pregnancy. Thrombocytopenia of varying severity is seen in around 7 to 10% of all pregnancies. Out of these patients, only 1 to 2% would actually need a lot of hematological evaluation, because they will have serious underlying etiologies. We do not define thrombocytopenia in pregnancy as per routine definition. In third trimester, platelet count of less than 1.1 lakh would be thrombocytopenia. So that shows that physiologically also, as pregnancy advances, platelets would go down. Let us look at these two cases. We have first lady who is young preemie, 10 weeks, so first trimester, presents with severe thrombocytopenia. She is otherwise well, just some ecchymotic spots. Severe thrombocytopenia, platelets of 26,000. Otherwise, everything is well, no past history. Vis-a-vis, we have another lady who is multi, 25-year-old. She is in her third trimester. CBC shows mild thrombocytopenia, platelets are 95,000. So both ladies are pregnant. They have one common thing, and that is thrombocytopenia. So whenever these patients, they present to say hematologist, obstetrician or physician with thrombocytopenia in pregnancy, there are 5 questions which we should try to answer. If we answer these 5 questions, 90% of the diagnosis is done. First is which trimester patient is in. For example, if the patient presents with severe thrombocytopenia first trimester, ITP is likely. Last trimester, second or third, mild thrombocytopenia, it is likely to be gestational thrombocytopenia. Severity is very important. Anything less than 85,000, any severe thrombocytopenia rules out gestational thrombocytopenia. If we have their pre-pregnancy result, for example, patient who has been ITP before pregnancy, if they present with thrombocytopenia again, we know that it is relapse of ITP. Associated symptoms are very important. It doesn't take much to know that if pregnant lady presents with high grade fever, chills, rigor, especially during monsoon season, it has to be viral thrombocytopenia unless otherwise proven. Last, associated lab abnormalities. We have to look at CBC whether it is isolated thrombocytopenia or something like bicytopenia, pancytopenia, because ITP, gestational thrombocytopenia, which are otherwise common causes of thrombocytopenia in pregnancy, are ruled out when patient presents with bicytopenia or pancytopenia. So this is how causes of thrombocytopenia in pregnancy looks like. These are specific to pregnancy. The commonest is gestational thrombocytopenia, which otherwise follows a very benign course, and there are other causes which we have to look into when it comes to thrombocytopenia during pregnancy. Before jumping on and saying that pregnant patient has thrombocytopenia, it is very important to rule out something called pseudothrombocytopenia, because we may have platelet clumps because of EDTA, we may have large platelets on smear, so pseudothrombocytopenia has to be ruled out. So coming to platelet threshold, there is no magic number, but we are happy as long as platelets are more than 50,000 throughout the pregnancy. When it comes to term and diagnosing the disease, we would be comfortable when we would raise platelet counts beyond 50,000. Otherwise, first and second trimester platelet count of 50,000 are fine. Anyone presenting at any trimester less than 10,000, the cause has to be evaluated. IVIG steroids have to be offered to them. So summarizing thrombocytopenia, gestational thrombocytopenia is a diagnosis of exclusion, and it follows a very benign course. Most of the patients would not have postpartum hemorrhage unless they have coexisting obstetric issues. Platelet count of 50,000 is otherwise safe for normal vaginal delivery, and platelet count less than 70,000 we would not be comfortable advising spinal anesthesia. These patients may need general anesthesia. Other but rare causes which are otherwise important, such as TTP, HUS, and rarely there are pregnant patients who present with aplastic anemia, have to be ruled out when we rule out ITP and gestational thrombocytopenia. I think I've got 3 minutes left, so I would be just covering last, which is DIC, which we have seen in previous talks. DIC is a nightmare for treating obstetrician, hematologists. Whenever I'm called in for DIC, I say, oh God, why me? Because there are obstetric DIC can be a nightmare if not managed well. There are various causes like postpartum hemorrhage, preeclampsia, eclampsia, abruption, acute fatty liver of pregnancy, amniotic fluid embolism rarely can lead to DIC. Septic abortions are nowadays less, but they can lead to DIC. IUFD, if retained products of conception, if they are there in the uterine cavity, they can lead to DIC. It doesn't take much to diagnose DIC. We all know that patient who has appropriate clinical background presenting with bleeding and thrombosis would be diagnosed as DIC if the lab parameters are fitting in. What is the treatment of DIC? Treatment of DIC is step 1 would be stopping the triggering process. Unless the triggering process is stopped, DIC would not be controlled. But of course, shifting these patients to ICU, giving them adequate fluid, giving them required blood products would be very important. So it's a teamwork. Obstetrician, intensivist, hematologist would work in a team to manage DIC. We have seen that human blood can be fractionated into different components, and components like platelets and FFP cry would be used in the treatment of DIC. So what is new? This we have seen in previous discussion. This is not new, probably relatively new in the treatment of obstetric DIC, that is recombinant factor 7. We have APCC. These are double-edged swords because they may help, but irrational use may lead to widespread thrombosis and the outcomes may be detrimental. So I have been looking after obstetric hematology at the place where I practice, and just in one slide I would summarize that obstetric hematology, if managed well, is very rewarding. The sight of mother who has survived high-risk pregnancy with a newborn is priceless. Thank you so much.
Thank you, Dr. Vinay. You have 1 minute left for you. Any questions are allowed, because he has completed in time and still left 1 minute for your questions. Any obstetricians or physicians can have a interaction with him. If no questions, we'll conclude this session and we'll go for a tea break as per the
Yes.
itinerary given to us.
Thank you, sir. Thank you so much, and thank you for the, most distinguished audience. All power pack, difficult, more so postprandial, difficult to digest topics, but I can see all the audience glued to the screen. It speaks of their curiosity and interest in hematology. In that regard, we have the results of our third MCQ set. So there are two winners, Dr. Sai Sahul and Dr. R. Venkateshwarlu, sir.
We thank Dr. Ganesh and Yashoda Hospitals management for giving us an opportunity as a chairperson. Thank you, sir.
Thank you, sir. Let us have a short tea break for 15 minutes and join us for fourth session.
Request all the distinguished delegates to please come back in 10 minutes. We are short of time, so we'll try to conclude all the sessions by 5:30, 5:45, and post that we have a networking gala dinner at Hotel Westin. I request every one of the delegates to please join us for the dinner at Hotel Westin.
बात करता हूँ आपसे।
అదే రేపు మామూలుగా 8 వచ్చి మధ్యాహ్నం 2 ఓకే మధ్యాహ్నం కాలం అవుతుంది రేపు సందీప్ రాడు ఇప్పుడే హాస్పిటల్కి వెళ్ళాడు చూడడానికి వెళ్ళాడు నైటా చూస్తాను మీరు రావాలి సార్ ఇప్పటికే తలకాయ ఇప్పుడు తెల్లారుజాము 4 ఫోన్ ఇచ్చే సతాయించింది నా ఫోన్లో అప్పుడే ఫోన్ ఎదరలేదు అందుకే ఇక్కడ రాదు నేను అసలు ఇచ్చే మాకైతే ఆ సెట్ అవడానికి మాకు 9:30 10 అయింది కూడా అది యాక్చువల్లీ ఒకటి స్విచ్ ఉంది 10 స్విచ్ అది ప్రాబ్లం అందుకని చెప్పండి మనం పోయిన ఇదే వాళ్ళు తీయాలనుకుంటున్నాం డైలాగ్ సంజయ్ అమ్మాయి ఆఫ్ చేయలేదు
Let's start quiz 4. Scan the QR code. Everyone is requested to scan the QR code for quiz 4. Okay, the questions goes. First clinical scenario, a 30-year-old woman with a history of DVT is admitted for delivery. What is the recommended prophylaxis for preventing venous thromboembolism in this patient during the peripartum period? And the answer is A. The commonest cause of severe thrombocytopenia in pregnancy in first trimester is. And the answer is A. Low-dose aspirin is used in patients with sickle cell disease and pregnancy as a prophylaxis agent against. And the answer is D. All are treatments for MDS except. And the answer is C. All are All the treatment steps for transfusion reaction except. The answer is C. The cords of Billroth are located within the splenic. And the answer is A. All are features of severe aplastic anemia except. And the answer is C. That's all for the quiz. Winner will be announced later. Let's start our session 4. I would like to invite chairpersons Dr. Trilok Chandar, Professor of Medicine, Gandhi Medical College, Hyderabad; Dr. Bhavani Prasad Gudavelli, Associate Clinical Director and Head of Department Critical Care Medicine at Care Hospital, Hyderabad; Dr. R.K. Jena, Professor and Head at SCB Medical College and Hospital, Cuttack, to address this session.
The first speaker.
We have all people.
All the four, but first speaker.
Good evening all. On behalf of Association Physician of India, Telangana State Chapter, as a treasurer of APITS, I express my thanks to Dr. Ganesh and the organizers for having collaboration in organizing this conclave, that is Deccan Hematolink, and also thank Dr. Ganesh for inviting me to chair this session. So we are already beyond 1 hour late schedule. So we'll move on to the session on aplastic anemia management for clinicians. For that, I invite Dr. Ashish Dikshit. Can we have introduction slide? So, Dr. Ashish Dikshit is a consultant hematologist at Manipal Hospital, Bangalore. So, he is going to enlighten us regarding the aplastic anemia management. Over to you, Dr. Ashish.
And laser to this?
Yes, press and hold.
On the laptop. To the laptop.
Yes.
Good evening, everyone, and my sincere thanks to Dr. Ganesh, and I really admire the hard work that he has put entire this level of conference to organize. Really takes a lot of efforts, and I think it really deserves a lot of loud applause, because in a single day with so many sessions, giving an overall view of hematology is really commendable. The responsibility for me is mainly to comment on aplastic anemia. I'll just take you to the journey of aplastic anemia for another 10 minutes. The aplastic anemia, as the word says, is defined by the Pancytopenia, hypocellular marrow. It is in the absence of any abnormal head fat rate or a marrow fibrosis. So
The duration is not important. Duration can be 1 month, 2 months, 1 year, depending on that. But ultimately, the diagnosis of aplastic anemia is based on these features. So Paul Ehrlich was the first person who actually started looking at this particular abnormality in the bone marrow, but it was Dr. Shawford who actually coined this term of aplastic anemia. So this is a typical hypocellular marrow that you usually see. And if you look at the classification, it's broadly into two types. It's either hereditary or acquired. Acquired can be related to any of the secondary causes, related to either drugs, chemicals, irradiations, or viruses that may induce it. Primary or the hereditary type may be related to any of the hereditary conditions which are related to the hereditable causes. Most common of these is Fanconi's anemia, dyskeratosis, and a lot of others also that we know. These are rare conditions to come. So how do we classify? That was one of the question also. We decide based on the severity. So severe aplastic anemia is bone marrow cellularity less than 25% and 2 of the 3 criteria at least. So neutrophil count should be below 500, platelet should be below 20,000, retic should be either below 1% or absolute reticulocyte should be below 60,000. Very severe aplastic anemia is when neutrophils drop below 200, and that's where the risk of major infections keeps increasing. The non-severe, on the other hand, is anything which is coming over and above severe aplastic anemia or in between. Peripheral blood criteria is whenever this is not satisfied, regardless of the bone marrow cellularity, because if it is 20 to 30%, it will still qualify as non-severe if it is not in the category of severe aplastic anemia. If you look at the age, it's bimodal. You can have you see a very big peak early, which is predominantly related to genetic as well as acquired causes also. In addition, there is a second late peak that comes in around 50s and 60s, and that is where it is another reason. Most of these are acquired aplastic anemias that come. So there are two phases where the disease starts manifesting more predominantly. We look at the pathophysiology, what causes it. So first, let's go to the etiology as we discussed. Either it is a physical damage that can happen with the radiation, with the drugs, the toxins which are exposed. Benzene used to be one of the drugs that used to be causing severe aplastic anemia, or it can be immune mediated. One of the common feature for that is, or common predisposition factor is acute viral hepatitis, the non-A, non-B, non-C hepatitis. It's a known association and sometimes one of the common ones also with acquired aplastic anemia, or a constitutional genetic defect that may lead to a hereditary type. All these lead to a common pathology where there is a hypoplastic marrow. The treatment also differs based on what exactly is causing it. So the genetic ones mainly will be treated either by the androgens or by bone marrow transplant. On the other hand, the other types are usually treated on the basis of immunosuppressive therapy or bone marrow transplants. So this is simple way, but it is much more complicated than that. So if you look at this graph here, it's in continuity in terms of based on which particular immune system is affected. So this may be either a T cell defect or a B cell defect. If you look at the spectrum, the autoimmune hemolytic anemia is predominantly a B cell defect. As you move forward, then it is going more towards a mix of T and B cell disorders. So aplastic anemia comes in the middle. It is predominantly T cell mediated, but there are some features also which may overlap. And these diseases overlap with each other. So this may be with the myelodysplastic syndrome, PNH, HLH, which may also come along with that, and large granular lymphocytosis, which can be another condition that can be an association with aplastic anemia. So a lot of these are common intermixed disorders, and there is a predisposition to malignancy in quite a large number of these as well. So how do we diagnose? We look at the peripheral blood, we look at the peripheral blood bone marrow for diagnosis, we look at the karyotype mainly to look at if there is any sensitivity with the stress cytogenetics or no, and do a mutation analysis as well. Based on that, if everything excluded, we diagnose as acquired aplastic anemia. So how do we treat? The treatment is these 3 common modes. One, most common, bone marrow transplant. Second is immunosuppressive therapy with thrombopoietin receptor agonist. These are the new ones that have come. This is in combination with ATG, cyclosporin, eltrombopag or romiplostim. These are the two TPORA that is available. Now this triple therapy has made the difference in terms of outcome of these cases, particularly those who are not undergoing transplant. The third modality which we have been using for ages is anabolic steroids that has been around for a long time. So this is just an outline on how exactly aplastic anemia is diagnosed and managed. Once we have confirmed diagnosis, we first segregate whether it's a child or adult. Based on whether it is a child, particularly below 18 years, first management strategies go for a bone marrow transplant. In case a donor, sibling matched donor is available, if it is not available, most of us have started offering now haploidentical transplant or a 10/10 matched donor also in children at this age, particularly children below 10 years of age. We are going to transplant because the chance of immunosuppressive therapy working there is very less if it's an acquired aplastic anemia. Now, otherwise we go for immunosuppressive therapy. If there is no response, then we go for a transplant again. If it responds, then we continue with the observation. It may stay on for a longer time or it may relapse. In adults, on the other hand, transplant decision is based on what is their fitness. So if it is more than 50 years of age or more than 40 to 50 years of age, then bone marrow transplant is tough for quite a lot of these patients to tolerate. So their immunosuppressive therapy becomes a dominant modality. If it is a younger adult, you still want to cure this condition because the cure rates are reasonably high. So you will treat it first with the bone marrow transplant. If immunosuppression therapy has been used and it fails, then you go back to bone marrow transplant as a facility. So bone marrow transplant is a lifesaver in most of these acquired aplastic anemias, particularly those coming with the severe aplastic anemia. So why bone marrow transplant is so important? This is just overview about how the survival of aplastic anemia has changed. There is a data from 2010 to 2020 in International Bone Marrow Transplant Registry. If you look at a younger, children below 18 years of age, the survival is as high as 90% if you do transplant on time. And as we move down from sibling to other donors, it keeps dropping, but it's still good enough. If we go to the adults, the survival is relatively lesser, but it is still reaching more than 80, 90% in those scenarios as well. This is the data from European Bone Marrow Transplant Registries. What it emphasizes is the outcome keeps dropping as per the decade of the disease. So those in the younger respond best as the age advances. This is something to do with the biology of the disease and their tolerance to the bone marrow transplant to these cases as well. This is just a graph showing how the advances happened. First thing was ATG that came in very early, androgens along with that were used with the low dose steroid to reduce any reactions. Subsequently, we discovered cyclosporin works better. Then subsequently we identified, okay, we can add other drugs along with that. Sirolimus, MMF trials have come in. Rabbit ATG was tried as well, but subsequently we found that it is actually working much lesser compared to what horse ATG does. Now actually the horse ATG is being withdrawn, so that is a difficulty that rabbit ATG may be the only one. And then came eltrombopag, which is now being included as a triple therapy. So this is 3 drug combination. This is a trial by NIH. What came later is the outcome, the survival, and the 3 years, the overall response rate is as high as 90%. So that means even in those who do not undergo transplant, nearly 90% of them, you can expect a response if you start the triple drug combination therapy in these cases. This is just another comparison why in children we don't like to do the immunosuppressive therapy up front. This is a trial comparing the immunosuppressive therapy with transplant in children. If you look at it, the survival is entirely different when you compare it in those 2 scenarios. So yes, in children, you have to go for a bone marrow transplant. What are the limitations? This leads to partial response. There is a high risk of relapse. So almost 30 to 40% people may develop a relapse and may need therapy again. There is evolution to another clonal disease that can happen. PNH can develop in 15 to 20%. There can be development of leukemias, and there are worse outcomes if you do transplant later. There is a category called non-severe aplastic anemia that we just discussed. Again, treated the same way, but more by immunosuppressive therapy. You don't do a transplant in a non-severe aplastic anemia upfront. mainly because it doesn't justify the risk associated with that. Androgens we have been using for a long time. We believe that it is stimulating the bone marrow to produce more cells. In addition, it has lot of immunological mechanism of action also. We have to wait for at least 3 months to say whether it is responding or no. Most important is supportive care. That's where all the physicians come in, because if you don't give appropriate supportive care, then most of these cases are not going to do very well in terms of infection prevention, transfusion support as well. Just a word about Fanconi's anemia. This is typical Fanconi's anemia, short stature, low CTS. Now these cases, they require transplant early, but they still have a lot of limitations to do. We diagnose them by stress cytogenetics. Transplant is a curative modality, but again the outcome is not as high as acquired aplastic anemia that you see. Just to summarize, early diagnosis is key, and individuals younger than 40 to 50 with acquired aplastic anemia should undergo a transplant. A triple therapy is the one for all other patients who don't undergo a transplant, and outcome is very good if you do the right therapy at the right point of time. I'm just leaving this summary slide so that it is for everybody's view. This is just a nutshell of how to approach the disease and what all treatment modalities are available for us. Thank you very much. Thank you, Dr. Ganesh, and thank you, chairpersons.
Thank you, Dr. Dikshit, for completing your talk before time. I think because of the shortage of time, we will take the questions at the end of the session. Thank you. So our next talk is management of myelodysplastic syndrome for clinicians by Dr. Anupama Chakrapani. Over to Anupam, Dr. Anupam Chakrapani.
So, very good evening to everyone. So, after the whole day discussions of hematology, my topic given is management of MDS. So, MDS is a very complex topic. You can spend whole day discussing about what is MDS, how to diagnose and how to treat. So, my task is basically for the clinicians. I will not bore you with the data, graphs and anything. So, my idea is to make you aware when you are sitting in your clinic, when can you suspect that you are dealing with myelodysplastic syndrome. So basically myelodysplastic syndrome is a clonal disorder characterized by ineffective erythropoiesis or hematopoiesis, which leads to cytopenia, and there is very important or considerable risk of progression to myeloid leukemia. So MDS has a various stage of evolution. So at what stage you pick up the case in your clinic, that is very, very important for your management. So all MDS don't require treatment. Some MDS require very aggressive treatment. Some MDS require gentle treatment. So that is the whole idea to understand the myelodysplastic syndrome once come to your clinic. So what is the epidemiology? So this is the US data. So around 12,000 cases of MDS cases diagnosed every year. And it is a disease of elderly. If you see the average age of diagnosis is around 70 years, and majority of the patients are more than 60 years of age, and around 30% is more than 80 years of age. Male predominance little bit, and this disease is very rare in children. Around 5 cases they diagnose per year. So incidence is very, very less. So as I told you, myelodysplastic syndrome is a disease of elderly. So what happens inside the bone marrow? There is hematopoiesis. Cell gets divided into RBC, WBC, and platelets. And RBC is known to carry oxygen, WBC is for the fight for infections, platelet is for the bleeding. So whenever there is a disturbance in all 3 components, either 1, 2, or all 3, the patient will have a symptoms of anemia, thrombocytopenia, bleeding, infection, like that. So in hematopoiesis, normal hematopoiesis, what happens? From the stem cell, you have a 2 lineage of differentiation. One is myeloid and another is lymphoid. So myeloid, if you see, differentiate ultimately into neutrophils, platelet and erythrocytes, and lymphoid series develop into lymphocytes. And the myelodysplastic syndrome is a disease of myeloid stem cell involvements. So the term is MDS. So what does that mean? M for myelo, D for dysplastic. Why it is called? because this patient will have a classical problems or description or presentation in terms of marrow finding or peripheral smear finding. Like erythroid series will have some dysplasia in terms of like budding or bridging. Granulocyte will have some amount of dysplasia in terms of hypogranulations or hyposegmentation. Megakaryocyte will have some kind of dysplasia. So that's why it is called myelo and dysplasia. And the third term is used called syndrome. Why it is syndrome? Because MDS is not a single disease. It is a group of disease. So it is like MDS post-cytotoxic therapy. MDS with associated with some genetic alteration like 5q, SF3B1 or TP53 mutations. Some is defined based on their morphology, like number of blasts present in the peripheral blood or the bone marrow, excess of blast, low blast, or cellularity. So that's why it is called syndrome. So the whole terminology is myelodysplastic syndrome. So when you are sitting in your clinic, how will you suspect that your patient might be suffering from myelodysplastic syndrome? So first, these patients will have anemia, leukopenia, thrombocytopenia, or pancytopenia. Any of this combination, either one or all three. Patient of anemia not responding to oral hematinics, what you are providing to your patient. Third is patient will have a history of recurrent infection, either cutaneous or visceral infection or whatever. Some patient will complain of bleeding spots all over the body. And whenever you find this kind of presentation in your clinic in an elderly population especially, you should think that you might be dealing with myelodysplastic syndrome. So when you see a patient in your clinic, you will not refer to a hematologist. You like to investigate the patient to see what is that. So what is the first investigation you will order in your patient is complete blood count with peripheral smear. That is very, very important, not the CBC. CBC with peripheral smear, because most of the patient you can diagnose or suspect that you might be dealing with MDS. So CBC will have anemia, neutropenia, thrombocytopenia. Sometimes you may get a circulating blast also. And these are some of the classic pictures under the microscope, like hypogranular neutrophils, like neutrophils with hyposegmentation, circulating blast. So that means if you have get a peripheral smear, this kind of presentation doesn't mean that you are dealing with MDS, because lot of other associated problems also can present this kind of peripheral smear. So now you need to do the next set of investigations, like you need to check the vitamin B12 level, folate level, iron, binding capacity, ferritin, copper deficiency, because there are a lot of non-clonal causes of dysplasia in the peripheral smear and the blood, like vitamin deficiency, zinc deficiency, alcoholic toxicity, toxin like arsenic, radiation exposure. All this can cause this kind of peripheral smear. That doesn't mean that your patient is suffering from myelodysplastic syndrome. So you need to exclude also some of the causes which can have dysplasia in the peripheral blood. So now the next investigation, what will you do, is the bone marrow examination. And the bone marrow examination, many a times we have seen that in peripheral setting, patient comes with just a bone marrow aspirate has been done, or aspirate and biopsy has been done, nothing else is done. So sometimes the investigation is incomplete and we need to repeat the bone marrow. So bone marrow test always consists of bone marrow aspiration, bone marrow biopsy, and cytogenetic analysis. 3 tests must be sent whenever you are doing a bone marrow examination, because this test you cannot repeat time and again. So first time is the best time you send all the investigation. And flow cytometry and molecular testing, if facility is available, you can send, or you can keep the sample for processing once you get the bone marrow report. So how does it look under the microscope? So like in dysplasia in the erythroid, as I told you, abnormal nuclear indentation, ring sideroblast, that is a very classical for myelodysplastic syndrome. Dysplastic changes in granulocytes. You will see hypogranularity, constant chromatin, sometimes circulating blast as well, and dysplastic megakaryocytes. So all 3 will suggest and conclude that you are dealing with myelodysplastic syndrome. So this is the morphological criteria for diagnosing a myelodysplastic syndrome. And the second most important is blast count. What is the blast percentage inside the bone marrow? Because that is important for your treatment decision. And sometimes we do immunohistochemistry also. So nowadays, this is the classification. I will not go into the detail of this. So this is like MDS with number of blasts present in the bone marrow less than 5 to 9%, 10 to 20%, less than 20%, hypocellular, cellular. So like that we classify the myelodysplastic syndrome. As I told you, this is not a one disease. This is a syndromic presentation of multiple type of diseases. Cytogenetic scoring has also been developed because this is a clonal disease. Patient will have a multiple clones which is causing this MDS. So there are certain cytogenetic abnormality which is quite classical with high risk, good risk. Why this is important, I will show you in the next slide. Now some of the genetic mutation like SF3B1, TET2 mutations are there that guide us what is the treatment you offer to your patient, and the patient will respond to the therapy. So the treatment of MDS, some patient you need to treat, some patient you observe, some patient gentle treatment. So based on that, when we diagnose a patient in a hematological clinic, we do what is the staging of the patient. So this is a very simple cytogenetic type, marrow blast count, hemoglobin, absolute neutrophil count, and platelet count. Not a very fancy investigation. A simple test, you will stratify your patient between very good, good, and intermediate. Why it is important? Because if your patient falls into a very low risk, their survival is more than 10 years. If the risk is very high, the survival is very restricted. So as I told you, low risk, you need to improve the quality of life. Don't go into the aggressive therapy. If the patient lands up into the high risk, you need to do an aggressive therapy for the myelodysplastic syndrome. So over the year, many drugs has evolved like azacitidine, decitabine, lenalidomide, luspatercept is the new drug which we used. And this is the treatment algorithm what we follow. So suppose your patient falls into a low risk category of MDS, you look for what is the cytopenia. If the patient is having only anemia, rest WBC and platelet is fine, you can give erythropoietic agents, supplement with some iron, B12, whatever is deficient. If patient is having thrombocytopenia, you just give L-Thrombopag and observe the patient like that. And once the patient fails this kind of treatment or they are progressing, you consider this patient for allogenic transplantation. But in high-risk patient, why it is high risk? They are more prone to transform into a frank acute myeloid leukemia, so you need to treat very aggressive. So sometimes we treat with azacitidine, venetoclax, and we take the patient upfront transplantation, and by that you can cure the patient. So in a simplified way, asymptomatic, low-risk patient, you observe until symptomatic progression happens. Okay? Low-risk patient, anemia, treat with lenalidomide if 5q deletion is present. Erythropoietin, other anemia like lenalidomide you can give, hypomethylating agent you can give. Other cytopenia, L-Thrombopag, GCSF you can use. High risk, transplant candidate, go for upfront transplantation. Not a transplant candidate, you can offer a supportive therapy. So what is the take-home message for all these slides? That cytopenia in elderly population, one of the important differential diagnosis is myelodysplastic syndrome. You should keep in your differential diagnosis category. CBC and peripheral smear is the first and most important investigation in your patient. Additional test is to rule out other causes of cytopenia, whether patient is having CLD or deficiency or whatso not. And for confirmation, always bone marrow aspiration, biopsy, and cytogenetics. All these three tests should be done together and should be read and evaluated together. Risk stratification is must before starting therapy. As I told you, low risk, asymptomatic, no treatment, high risk patient, allogenic transplantation. And goal of treatment is to improve the quality of life and delay the progression to leukemia. That is the goal of treatment of myelodysplastic syndrome. And allogenic bone marrow transplant is the only way to cure in a selected patients. So timely refer to a hematologist is the key for the best outcome of this patient, because these patients are elderly, they are very labile. So if you timely send this patient to a proper center where treatment facility is available, some patient you can cure, some patient you can improve the quality of life and prolong the survival of that patient. Thank you for your kind attention. And this is my place where I am working, Apollo Hospital in Calcutta with my team. Thank you.
Thank you, Anupam. Usually for a clinicians, MDS are very hard to understand. You made it a crispy and easily understandable presentation. Thank you very much.
Thank you, sir.
Now I invite Dr. Venkatesh Egbote to present his topic on transfusion reactions, diagnosis and management. Over to Dr. Venkatesh.
Go on to Dr. Venkatesh talk. For the last quiz, we have 2 winners. So I'm, inviting first winner now, and the second winner, because both of them have scored equal. The second winner is after just 2 talks. We have 2 last talks: approach to splenomegaly and management of transfusion reactions. So I humbly request all of you to bear with us for another half an hour. So I'll just share the names. Dr. K. Ramakrishna. Is Dr. K. Ramakrishna here? Yeah, sir, please, congratulations. So he is the winner of
Should I go ahead? This is for advancing the slides, or I can also use this, right? I'm more comfortable. Enter also, no? Not enter back and front. Okay. A very good evening to.
I request Dr. Venkatesh to hand over the.
Okay. Please. Sir, this one. Congratulations. Good evening, everyone. Thank you for being a wonderful audience. Again, words fail me to describe the amount of wonder and excitement to be part of Dr. Ganesh Jaishetwar's wonderful conference conclave, and thank you to all of you for making it a grand success. I come here as a representative of one other end of the Deccan plateau, that is Aurangabad. Once upon a time, Aurangabad and Hyderabad were part of the same kingdom of the Nizam. Today I am tasked with, you have already heard about 2 core topics of hematology, aplastic anemia and MDS. As clinicians, the entire responsibility of taking care of these patients can come upon you, and one important part of that is transfusion care in these patients. So I have been given only 15 minutes to tell you about transfusion reactions, the things that you must know. And I'm going to allude to the latest BCHS guidelines for the same. I'm only going to tackle the acute transfusion reactions, and I'm not going to delve into the core hematological aspects of delayed transfusion reactions or transfusion associated graft versus host disease or any transmissible transfusion related diseases or any transfusion targets or any policies related to when or when not you should transfuse. So thankfully we are in an era where we have access to blood products. Imagine the time when only whole blood was available. Right now we can choose a product based on the need of the patient. There has also been wonderful advance in grouping and cross-matching techniques with the help of automation and gel card testing. And as clinicians, you should also be aware of these methods that should help you to choose which blood bank you order your blood from. No more do we use whole blood, no more do we use any slide based ABO compatibility testing. So make sure that your blood bank is providing you state of the art gel card testing for ABO compatibility and also the blood product management that is essential. But if you think that blood transfusion only saves lives, look at this FDA data, and this looks at transfusion related deaths, and almost 183 patients have lost their lives over the last 3 to 4 years duration. The leading cause of death is transfusion related acute lung injury or transfusion associated circulatory overload. This is Indian data which we have just started collating in India. This is called a hemovigilance program where all transfusion reactions have to be reported. It is still not mandatory, but it should be made mandatory. Thankfully for us, almost 50% of the reactions are non-hemolytic reactions and non-fatal reactions so far. So what is a safe transfusion? Really the only safe transfusion is the one you don't get, but unfortunately we are not there yet. So until that time one must deal with the menace of a transfusion reaction. One must remember that every transfusion is a clinical decision in itself because it has risks involved. We must always understand that before ordering the next transfusion in our patients. That is because your transfusion is a immunologically active tissue. You are transfusing an immunologically active tissue full of plasma, full of cells and full of interactions with cytokines which are already released in a stored blood setting. So remember that when you order your next transfusion unit. Amongst, if we come to the definition, transfusion reaction really is an adverse event during or after transfusion. The acute transfusion reaction are within the first 24 hours and delayed are after that which you encounter after 24 hours. Now the traditional teaching has been that you divide them based on whether they are immunological or non-immune. On the left side, immunological are usually either fever related or hemolysis related. On the right side, non-immunological are either related to your circulatory overload or related to any dilution factor like transfusion related thrombocytopenia. The clinical features according to traditional teaching are range from simple fever and chills to hypotension, but you can get an entire combination of all these symptoms. So that's why this traditional teaching doesn't really contribute to a clinician's way of approaching or understanding or treating even a transfusion reaction, because it does not take into account patient condition and the transfusion related events. So you can't separate the two on the bedside. Again, it gives precedence to investigation. So are we going to wait for the report of investigations before we manage a transfusion reaction, or do we first manage transfusion reaction and then send the investigations? All that is a confusion that most emergency physicians face, and labs and most hospitals are not equipped, and hence we cannot train our staff towards it. So we must go to a clinically driven algorithm which we as hematologists learnt in CMC Vellore, and that is a very simple what, why, how and who approach. So we are trying to fact find and not fault find here. So whenever you are encountered with a transfusion reaction, what is the transfusion reaction like? Is it mild, moderate or severe? Versus why is there a transfusion reaction? Is it transfusion associated or is it related to the underlying condition? Very difficult to really point out. Then comes the investigative modality about whether it is an immune or a non-immune disease problem, and then we decide why this error occurs. And to answer these questions, the recent BCSH guidelines have come out. If you look at these guidelines, they are basically clinically driven. So whenever you encounter a transfusion reaction, first assess the symptom complex, whether the symptoms that are present like fever, chills, rigors, hypotension or simple plain nausea, vomiting, are they severe enough or life-threatening enough, or they are mild or moderate. So once you club them into these two categories, you decide the next action. In all severe cases, you have to discontinue transfusion. In all mild cases, you may re-challenge transfusion patient with under observation, and in moderate cases, you have to monitor after discontinuing the transfusion, and you may pre-medicate the patient, treat the patient and then probably restart the transfusion. That is the usual protocol. So before we do that, we must make sure that we do our basics right. So as a transfusion, as a clinician engaged in transfusing patients, we should understand right patient, identified and pre-assessed, always take a baseline parameters before connecting the blood transfusion, always check the product, whether it is the correct product and this is what was ordered, cross-check the group with the patient's details, cross-check the indication, the clinical pathway should be well laid out, a hematologist can help you in that. It should be in the right area that should be equipped to monitor patients who may become critically ill.
on transfusion, and the staff should also be trained, and all this should be a part of a standard operating procedure. Now some pointers towards acute transfusion reactions. If we get airway breathing and circulation embarrassment with skin and mucosal changes, usually it is an anaphylactic reaction, which are thankfully rare. But if we get shock hypotension without any signs of anaphylaxis like rashes or angioedema, then you are dealing with either a ABO incompatible blood transfusion or a bacterial sepsis. In patients where severe dyspnea predominates with or without hypotension, you should look at either transfusion related acute lung injury or transfusion associated circulatory overload. Just the difference between the two is transfusion associated overload is a cardiogenic type of pulmonary edema, whereas TRALI is a non-cardiogenic pulmonary edema. Just short pointers towards treatment of anaphylaxis. Really, intramuscular adrenaline is the best drug, and it is recommended even in patients who are severely thrombocytopenic. You can go through the guidelines for doses. My point is you should always have a adrenaline loaded 1 in 1000 before we connect the first transfusion to the patient, because you never know that the next will be a life-threatening anaphylactic reaction. Along with it, you should also have a pint of saline which should be ready to be connected in case he needs a fluid challenge. And subsequently, you should shift the patient to ICU care. In ABO incompatibility, which usually falls into moderate to severe reaction, we must stop the transfusion and send back the blood for compatibility testing and hydrate the patient for the next 24 hours. Closely monitor CBC and coagulation profile, because ABO incompatibility is potentially a condition which can initiate a disseminated intravascular coagulopathy. So at least 12 hours apart, we must test these investigations, send these investigations. We should also watch renal functions very closely. The very common mild to moderate reaction is a febrile non-hemolytic transfusion reaction. So in this, we have to be careful before you call it a febrile non-hemolytic transfusion reaction. Check two temperatures at least 1 to 2 hours apart. If they are more than 2 degrees, you are dealing with sepsis. If they are less than 2 degrees apart, then you are truly dealing with a non-hemolytic transfusion reaction. The usual culprit are leukocytes, and for the next time, you should order a leukodepleted blood product which will take care of your leukocytes, which can induce the febrile non-hemolytic transfusion reactions. Allergic reactions are very easy to identify and treat. You can give chlorpheniramine and also some paracetamol, sometimes some nebulization in moderate to severe reaction usually takes care of the allergy, and you can actually restart the transfusion. But the only real problem is recurrence. Recurrences can happen, and if they are of severe nature, you should look at IgA deficiency in such patients, and we should look at that. And we must use pooled plasma suspended in a plasma, pooled platelets suspended in a plasma-free diluent, or you can use saline washed red blood cells. Now my last couple of slides will be on TRALI. This is an immunological reaction to any product. Presently, platelets are the main culprit. It causes leukocyte flooding and infiltrates. You can see here a whiteout lung within hours of transfusion and drop in SpO2. There is a elaborate criteria. The first thing is hypoxia, and the second thing is we have to rule out left arterial hypertension. If there is left arterial hypertension, then you are dealing with a circulatory overload condition which responds to diuretics, whereas in TRALI, usually diuretics don't have any effect. So if you look at the symptom complex between TACO and TRALI, that is the main thing. Just one more minute. Okay. So in patients who have TRALI, they usually end up with hypotension without left heart failure and without any pleural effusions, whereas in circulatory fluid overload, there are multiple types of pleural effusions, and there is usually a circulatory overload related hypertension, and diuresis usually responds. So remember these two conditions the next time your patient has dyspnea. The best way to prevent it is to source plasma or products coming from males only, because females are usually alloimmunized, and this is an immune related disease. And like I said, right now with this kind of policy, now the platelets are the chief culprits. And to summarize, blood transfusions are like marriage. It should not be entered upon lightly, unadvisedly, or wantonly, or more often than is absolutely necessary. Thank you so much.
Thank you, Dr. Venkatesh, for dealing with elaborating the transfusion related reactions in a practical way. Our next talk, and most probably the last talk of this evening, is I have a huge spleen. What should I do? To go through this, we have our speaker, Dr. Chepsi Philip. Over to Dr. Chepsi Philip.
Yeah. Okay. I'll start. Yes. Thank you for staying through the entire session, and I thank Dr. Ganesh Jaishatwar for organizing this wonderful conference and having us all here. And these are unusual topics. I am very intrigued by the selection of topics that Dr. Ganesh has chosen, but I understand that now he's trying to improve the interest in hematology across Deccan region, and I wish him all the best, and I think he succeeded a lot in doing that. So this was the topic that has been given to me. I have a huge spleen, what should I do? Well, I think this is the exact question which John Moore must have asked his physician. Now, John Moore landed up in California on the October 5th, 1976, with some mass in his abdomen, and he probably must have been diagnosed to have splenomegaly. And this is the exact question that he must have asked his regents at the University of California. And Dr. David Cook was his physician or the hematologist, and he diagnosed him with hairy cell leukemia in 1976, and the treatment offered then was splenectomy. He underwent a splenectomy. So this was the answer for the question which John Moore had, but the problem was the tissue got removed, and they were able to isolate hairy cell leukemic cells, and just like Professor Agarwal had told about Henrietta Lacks, John Moore cells were immortalized as your hairy cell leukemia cell line, and David Cook sold it to another company, and he made a huge profit out of it. Eventually, John Moore came to know about it, and he said, I underwent the procedure, these are my cells, and I didn't get anything out of it. So we'll come back to what happened to it later. Now, the spleen, as you all know, this is a learned audience. I just don't need to tell you exactly where the spleen is located. So this is between 9th and through 12th ribs, and it abuts the stomach, kidney, and the colon. And normally, it measures around 11 centimeters or 12 centimeters, but depending upon your gender, depending upon your age, the spleen weight, volume might vary. Now, this is a cartoon which shows you that it is different between males and females, and the older you are, and if you are a male, your spleen volumes are likely to be higher. Now, the major function of the spleen is filtration of the circulating blood, which is really reflected in its histological structure. So you have a red pulp and the white pulp. The red pulp contains your cords of Billroth, which act as a bottleneck for all the abnormal erythrocytes. And if there are abnormal erythrocytes, they're going to get filtered over there. Your white pulp with the arteriolar sheath contains your T cells. They are interface for immune sensitization. T cells, B cells interact. So the spleen plays a major role in the hematological world as well as in the immunological world. And diseases which affect either of it can affect the spleen. So by definition, the gold standard for a splenomegaly definition is an increase in the splenic weight. But that is some diagnosis which you're going to get out of a post-mortem. So otherwise, we radiologically give a cutoff for splenomegaly as 11 to 13 centimeters. It varies, ultrasound versus CT scan, but any increase in spleen is a splenomegaly. Now, John Moore had a hairy cell leukemia, but there are a myriad of reasons where you can have splenomegaly. But the way to approach it is to see what is the physiology behind the splenomegaly. So you can have congestive causes, you can have infiltrative causes, immune causes, and neoplastic causes. You can divide it by pathophysiology, which causes the splenomegaly, or you can divide it as the pathology which causes the splenomegaly, or all this. Ultimately, it will help us plan out our treatment decision. So broadly, just for your understanding, the flow, the branching tree which I've shown on the left side gives you the pathological causes of splenomegaly. So either you have an increased work hypertrophy. So the normal cells in the spleen are working higher. So I already told you, you have the red pulp and the white pulp. So you can either entrap circulating erythrocytes, that part can increase, or you can have your immune cells which have been sensitized and that part can work more. So that is your work hypertrophy, which can happen due to so that can happen either due to the red pulp part or the white pulp part. Then you can have congestive cause, that is whenever the flow through the splenic vein is obstructed, that can again lead to back pressure or a change in the spleen size. That can either occur due to liver diseases, or it can occur due to obstruction or clot within the portal circulation. So that is what your congestive causes are. Then you can have infiltration. These can be cells which are not domestic to spleen itself, but they could have migrated from elsewhere. So you could have metastatic diseases which have migrated to spleen causing a splenomegaly. You can have amyloidosis, which is again a cause of splenomegaly. So these are the various causes which you might have to explore if your patient has splenomegaly. And you can also have physiological causes without all those diseases that I mentioned. So that can be a transient splenomegaly, which usually resolves as soon as the transient insult is gone. So you have blood loss can also cause splenomegaly, pregnancy can cause splenomegaly, volume overload can cause splenomegaly. But in a clinic, the most common causes, now this is from the Danish registry, where they try to find out which are, amongst all these causes which I gave you, which is the most common. And if you can see, roughly 30% of the causes, whichever era, despite the diagnostic advancements, continues to remain hematological causes as the dominant cause for splenomegaly. And followed by that is your hepatic causes, and then you have something known as isolated splenomegaly, where any cause might not be identified. So how do we go about assessing the spleen? So the table on the left shows you, like, you need your history taking to give you a clue or a pointer as to what exactly should I try and diagnose. So you can have fever, infective causes, you can have B symptoms, you will try to look at malignant causes, you have jaundice, you try to look at hepatic causes, and so on and so forth. And mostly in most patients, what we end up doing is we will have a basic CBC, and your basic tests might include LFT in most places. So this should roughly give you a flavor of which side it might go. So I told you hepatology or hematology are the likely two major causes of splenomegaly. And then depending on your history, if you are able to tease out good history, you might be able to navigate your path and reach a more appropriate workup. It might also happen that at the end of all this, you might not still get a clue in spite of getting a good history. Maybe the tests are not telling you, or you don't have a facility to do all these investigations. There might be some pointers which will tell you, okay, I'll try and do this. So if you have a cytosis, so mostly all splenomegaly patients might have a cytopenia, but if you have a cytosis, it is more likely going to be a hematological cause. If you have any LFT derangement, it is most likely going to be a hepatologic cause, and you can refer the patient appropriately or send them forward for the same. Even after doing all this myriad of investigations, you will still have a subset of patients, which I showed you, roughly 30% of patients, in which no cause is likely to be identified, and that is something we know as isolated splenomegaly. Now in these cases, it is more of your clinical intuition. There is a school of thought which says that if there are no B symptoms, patient looks non-toxic, you can continue to watch and wait. If it is a non-progressive splenomegaly, you don't really need to investigate further. But if the splenomegaly is getting progressive, then you need to intervene. And what can you do as intervention? People have approached splenic biopsies, FNACs, even a diagnostic splenectomy to reach these causes. So in the past, when we didn't have these answers, this is a table which shows you that in an isolated thrombocytopenia, when they went ahead and did your diagnostic splenectomy, the majority of cause would have been a hematological cause. So it might be a precursor or a warning sign for a hematological condition. So if you have B symptoms, you really might have to end up doing either a diagnostic biopsy or a splenectomy, as where your expertise or your center's expertise is. So the evaluation of splenomegaly does revolve under a comprehensive history, physical examination, all that, but you still need to rely a lot on diagnostic techniques. Still, you might end up without finding an answer, and in those kind of patients, you might have to proceed with the diagnostic splenectomy. And the yield is, like I showed you, 30 to 50% of cases you're still able to diagnose, but you need to recognize that splenectomies come with its complications. You need to recognize that if it is a huge, massive splenomegaly that is more than 20 centimeters, the chances of complication are high. That's an Indian study which reported 41% complications. Usually we do electrosplenectomies now, not for these diagnoses. We usually do them for hereditary non-immune hemolytic anemia if they have growth retardation or transfusion dependence. But this is also one area where you might have to explore a diagnostic splenectomy. And why do you have to chase it? Because irrespective of whatever disease caused the splenomegaly, spleen itself can cause a myriad of symptoms because of its location. So it can lead to early satiety, abdominal discomfort. You can also have a larger spleen has the risk of splenic ruptures. So that again is a fear that you have. So you can't leave a large spleen unattended. That usually requires some diagnosis to be established. And once you have diagnosed it, then the purpose of the diagnosis is to find a solution for what is the cause of splenomegaly. So if you have a diagnosis, then you try and treat the underlying cause that should resolve the splenomegaly. But at times you might not end up with a good solution for the problem that you might have identified. Then even as a comfort care or as a palliative intent, or at least to reduce the symptom, you might offer spleen reduction therapies. In the past, irradiation has been offered, busulfan has been offered. But it really is not much in vogue right now, and sometimes you will end up doing a radical splenectomy. So a splenic radiation has been reported in the past to reduce size, relieve pain, not done much nowadays. Splenectomy for a symptom you might still offer, particularly if they have cytopenias, or if you're thinking in terms of hypersplenism, felties, you might try and offer a splenectomy. But recognize that splenectomy carries an infection risk. These are studies, these are areas where you might not have great evidence. It's not likely to come out of it, but these are the reports. But even though it's 3.2% infection rates, the largest study from India has reported complications of up to 41%. So recognize that there are going to be challenges. So you really try and evaluate and put most investment in trying to find out the cause better than proceeding with the diagnostic or a therapeutic splenectomy. Again, there is definitely a subset of patients who are going to benefit. There is also a subset like a massive splenomegaly who are going to have a misadventure with the splenectomy. So be alert to these challenges before you make a decision. So to summarize, I've told you about the anatomy of the spleen, what a splenomegaly is. These are the causes of it, and try and do an ordained approach to it. So it is difficult to give you an evidence-based strategy. Watch and wait for isolated splenomegaly is a potential way to do it. But try and review the history, clinical examination, and try to come about a decision. And then finally, what happened to John Moore was, this was a landmark case because the patient had put in a case that you can't use the patient tissue for research, but the state of California ruled in favor of the physician, which was landmark because that removed any further restriction on using tissues from the patient for research. This was the basis of the case against Henrietta Lacks, which was taken up, and eventually they reached an out-of-court settlement, even though the court ruled in favor of the state of California, but the hospital reimbursed him for whatever charges had taken place. So please take an informed consent for whatever procedure that you do. Thank you. Thanks for it.
Thank you, Philip. Even though it is a last session, but very interesting and most important session, I thank you. And now I once again thank you and congratulate Dr. Ganesh Dasevar for compiling such a clinical excellent scientific program, due to which The large presence of audience till the end of this evening hours itself gives the credentials to the conclave. I congratulate once again, and we conclude this session now.
Thank you so much, sir. And once again, I will like to thank all the eminent physicians and clinicians here for coming all the way and sparing the entire working day Saturday with us. Your presence till the last 1 hour, we are running out of time, but your presence till the last talk shows your commitment towards hematology. We are really grateful. It's an overwhelming response. Before we conclude, I had the second winner of the fourth quiz, Dr. Syed Jalaluddin, sir. Is Dr. Syed Jalaluddin? Congratulations. And we have another surprise prize tomorrow afternoon. So I request all of you to please be there as possible. And I request Dr. Shweta to conclude and with the vote of thanks.
I would like to express my appreciation to all the participants and the delegates for their valuable contribution on the occasion of the first Deccan National Hematology Conference, Deccan Hematolink 2024. My deepest gratitude goes to all who attended this event and helped to make it such a successful event. I would also like to extend my sincere appreciation to Dr. Ganesh Jaishetwar, Senior Consultant Hematologist, Yashoda Hospital, High Tech City, and Team Yashoda for organizing this conference to explore opportunity for sharing knowledge and experiences which are contributed by the experts and professionals from all over the India and all the delegates coming all over from the Deccan region. Thank you. Don't miss out our next session, which will be at Hotel Westin Mindspace. Hope to catch you all at around 7 p.m. for symposium as well as for gala dinner. Thank you, everyone.